few rules in Ghana work very, very well. Males don't go to female toilets. That's what I was told. The rules that work in Ghana, most is about the toilets. Men go to men's toilets. That's something. I want to welcome all of you to this workshop. It has taken quite a number of years to establish, what the COVID has done. My name is Soforia. You call me Mark. Clinic surgeon. Together with the MotecLife who run this charity for the past 70 years. This is the fourth of Alton calls for practicing surgeons and radiologists. We have quite a number of our own here to train you at the workshop. And most importantly, we have the president of the Ghana Clinical Facility saying, I always want to remove the instruments. I always want to remove it and say, Ghana Clinical Facility. One day it will be a separate college. I'm sure you all know. You need a separate college for radiology. That's right. But the Phoenix has just managed to escape to have a separate department in West Africa. Mr. Nkrumah Nail System with us, and I've actually worked with him for more than 14 years. Also, we have the head of Radiology Ghana College of Surgeons. Dr. Benham is here. It's been very good. This has been possible because you have been very supportive. Now, I'll let our August visitors introduce themselves. And please, don't be superficial. Tell them everything I'm doing. I'll start with the leader of the team.
Morning, everyone. And first of all, a big thank you to the College of Physicians and Surgeons of Ghana to invite us and giving us the privilege to come here and speak to you guys. Just very briefly, I'm a consultant radiologist at that hospital there, West Hertfordshire Teaching Hospital Trust. We've got 3 hospitals in the trust in 3 different cities, Watford, Hemel and St. Albans. And I became a consultant radiologist in 2003 in the UK. Before that, my training, quite a large part of it was back in India. So I qualified as a radiologist in 1994. Then I came to UK and did some fellowships from the Oxford University, and then became a consultant at West Hertfordshire Hospital Trust in 2003. So essentially, I'm an old breed, which means I'm like the dying breed where we do everything. So I'm a general radiologist who dwells in lots of subspecialties. I think by the time you guys become radiologists and be very subspecialized, chances are you'll have to kind of select what you want to do within radiology. Whereas at the moment we are trying to kind of hold on to as much as we can. So I do a lot of neuro, I do chest, I do GI, but I'm essentially a musculoskeletal radiologist. So apart from musculoskeletal, I do all of these other specialties. I'll hand over now to Nick.
Hi, my name is Nick Tessier. I'm the lead superintendent radiographer at Watford General Hospital. So I run the emergency CT scans within the department. I'm also a CT head reporting radiographer, something we do in the UK when the division on board certain examinations. I'm also an interventional radiographer, so I do my own percutaneous ranges. And again, I'm going to talk about that today. I qualified in 98. I became the superintendent radiographer in 2008 and the lead superintendent in 2006.
Good morning, everyone. My name is Paula. I'm a secondary radiology trainee in West Hertfordshire Hospital. Dr. Bakar is my consultant. He's kindly invited me to participate. I'm originally Algerian, did my primary medical qualification in Accra, and then moved to the UK to do my master's degree in public health and pursue specialty training in radiology. I'm really excited to meet you. I'll be discussing UK radiology training. Next time when I come back, I'll touch on radiology training in Nigeria, another African country. I think it's a different experience. I look forward to chatting with you guys during the break and find out what the training program is like in Ghana. And I'm sure there is a lot that we can learn from each other. Okay?
We have some supporting staff who came from India as well.
Hi, my name is Vivek Awasthi. I have nothing to do with medicine or anything connected. I work in financial technology in London. And we move money across borders. So I think the only link is when you're a doctor and you earn a lot of money and you want to move it, come and see me, right? Yeah, so I'm probably a part of that journey, but probably a little bit later for you guys. Sorry, that's why I'm friends with all of these. Yeah, it's great to be here. Actually, my son is here. I'm accompanying him. He's an aspiring medical student, so he's coming, doing his attachment here.
Hi, I'm Drew. I'm medical. Wait, I want to study medicine at uni. I'm here for an attachment. I'm going to be shadowing a doctor.
We all know that I'm Federal Secretary, the head of the General and Faculty Secretary. I'm happy that you are here. You learn a lot from facilitators. I finished my training in 2005. Those days we were going to Nigeria to work. Because at that point faculty of radiology. I don't have any staff specialty. I'm holding on to everything. Thank you.
I think the right time to ask the President of the College to give us a
Thank you very much. Good morning, everyone. I'm grateful to be here. I'm here because somebody else is coming. I have had an anxiety that I may not have sufficient subscriptions as it were. We've been a bit busy, I must confess. So, what did you finish? They've been really busy. So our organization didn't seem to go the way we wanted it. And I'm really grateful to have here. Thank you, Paul. So perhaps I'm knowing you from before. He's saved my neck in some situations. It's been good. And then all of a sudden, they couldn't help us. Really, this program, as I'm saying, organizing wasn't tip-top. This program is the fourth Alton course for the Ghana College of Physicians and Surgeons. I don't know the physicians, but I'm president of both. Yeah. It's only the COVID which came and intervened. They're coming regularly. Not only were they coming, teaching, training, they also assisted us with, the college's program for the fellowship. It's an external attachment. Assisted us, and I think on the 5th, before the academic board meeting, we are going to evaluate the program of the vascular surgery. We didn't have vascular surgeons in Ghana. So they assisted, and then now there are 3. And I can assure you they are doing very well. So we are really grateful for them. So Lord Alton, somebody financing some money. So I'm suggesting that you people graduate, and as I'm told, you receive a lot of money. Make sure you would also give a grant to the college to help train. Because if you don't train, by the time you need the service, you might get a service you don't want. And that is the thing to do. So I'm really grateful. Now he said the things that work. Actually, sometimes we intentionally don't make them to work for our purposes. You know, the washrooms used to be labeled women, men. When I needed to go, and the men was not, because somebody was there, took a piece of paper, piece of plaster, stuck it on the W-O, so it read men, and I used it, and it was very good. So when some things don't work in Ghana, don't think they just don't work. We don't make them work. That's for the short term. But we'll keep doing that. I don't think we'll stop yet. Then I see on the program, and it's very dear to my heart, you heard him say, don't jump. What's that? That's right. Don't do that. Safety issues are extremely important. Unfortunately, we tend to say that, don't think about it. I mean, why did you think about it? If you mention it, hey, why did you use your mouth to mention this? And we think if you don't mention it, it will happen on its own. It won't happen. That is it. You must deliberately develop the attitude. I saw in the program something on safety, isn't there? Yeah. Patient safety and quality improvement in imaging. We can't do everything every day, so I don't think it's any drawback on the program. Doctors have been interested in patient safety all along. Doctor safety. I think we should take care of ourselves as well. And with that, some time ago, I suggested to some of the radiology residents that they should form an association looking at the safety issues. Because years ago, you found that there were lead aprons with several cracks all over the place. And we're using them. Why should you work hard and harm yourself? Yeah, you may get lots of money for it, but not compensation for this. No, there's no point to it. So I'm suggesting once again, because I know that was not formed. And if you form it, I would make sure that the faculty will give everybody 5 points in the exams before they start. So you make sure you form it and look out for safety issues. Because if you don't, some of us will know. And having said that, I want to welcome Ash and the team because they've been doing it, and we are really grateful. And I'm hoping that we'll continue with this collaboration and even make it deeper, so that if anybody ever comes here and needs service, you get the right service also. Yeah. On top of that, you have to add advocacy to getting the right equipment. You're not special surgeon and you don't have things to work. What's the point? So I welcome you all to the 4th Lord Alton course. And, I can assure you we are going to have a very lovely time. Thank you all.
I think I need to introduce you to the meeting of the hospital, which is responsible for the arrangements here, and hardware. And our senior radiographer, Irene, my left is my secretary, Thelma. So if you need something, you can go to any of these. So I'll call on Dr. Ash to start the program with the talk on role of X-ray, CT, and acute trauma. Thank you.
Thank you, Paul. Okay, keep abdomen. And it ties in quite nicely with Nick's talk later on when we talk about keep and habit drainages. Now, it's extremely obvious to you guys, I think, that CT is a very important modality for examining acute abdominal patients. But I'll just show you a few examples of cases and the kind of thought process of the surgeons and the physicians who are ordering the scans and how we can work in collaboration to make sure that we deliver the best results for the patient. So essentially, acute abdomen or acute abdominal pain, nearly 5 to 10% of patients visiting A&E will present with these symptoms. And out of the acute abdominal pain, acute abdomen is when obviously you have more seriously ill patients with abdominal tenderness or rigidity or features of peritonitis. But essentially I will be covering cases which cover all patients with abdominal pain. So not just acute abdomen, where you would have peritonism as well. Just before I start off, very quickly, if I can get a grip of how many surgical trainees and how many radiology trainees. So if I can have the surgical trainees raise their hand up and the radiology trainees. So it's essentially all radiology trainees. Right, so in fact we were all under the impression that there will be a mix of surgical and trainees. So a little bit of the talks may be centered on the surgeons, but it's very important for you guys also as radiologists to understand the surgical perspective. Because we sometimes think from the radiologist point of view, oh, why is he asking for this, why are we making him do this, but sometimes you have to put yourself in the surgeon's shoes as well. And so it will be useful to kind of see their perspective as well. So essentially, acute abdomen can be from benign self-limiting causes, or it could be really from life-threatening. And sometimes it's pretty hard to make this differentiation just based on your clinical examination and your history and potentially your bloods. And that's where sometimes imaging really plays a massive role in deciding which way is it going. Is it kind of heading towards a more benign self-limiting cause, in which case you can probably sit and wait and things will remedy themselves, or do the surgeons need to actually dive in? Yeah? And that critical decision makes a lot of difference, because if the surgeons go in unnecessarily, that causes a lot of harm. If the surgeons don't go in time, that causes a lot of harm. So it's extremely important to kind of find out on which spectrum is your patient. Is he kind of going to self-resolve himself, or is he heading towards a more traumatic surgical option? So from a radiology perspective, I think essentially X-rays and CTs play the maximum role, and then you have ultrasound and MRI for problem solving as well. For certain conditions, ultrasound obviously is still the first line. So X-ray is a very good starting examination. I think it serves the purpose of triaging further investigations. So if the patient is not very unwell, just a little bit of tenderness, bloods are fine, and you get the X-ray done, and if the X-ray is fine, you can probably stop there. But obviously, if the X-rays are normal, but the examination was unremarkable and the bloods were too bad, you would still want something else. So kind of the X-ray can help you modulate which way are you going. Are you going to investigate him further or not? It is extremely unlikely that the X-ray will kind of answer the complete question and therefore you don't need anything else. Even if the X-ray shows free air under the diaphragm, the surgeons would like to know what's causing free air under the diaphragm, and therefore it would still be useful to kind of do a CT to kind of plan their strategy as to what they need to do when they go in. So even though the question is answered that they need to go in, but exactly what they're going to find is very useful for the surgeons to do. So utility of CT in the acute abdomen, obviously it's the technique of choice for diagnosis of acute abdominal pain, except for cholecystitis, as you probably know. It has a substantial effect on the management of patients. It's the preferred technique for bowel ischemia, and in certain circumstances ultrasound is useful. Pregnant patients, young patients who you don't want to expose to radiation. And MR is also a potential alternative as problem solving if the situation is more pelvic related, cardio related, or again if the patient you would like to avoid radiation. Right, so essentially this is when a patient comes in with an acute abdomen or abdominal pain, the whole process is of making the decision, and the decision making is based on these three things. Yeah? Your history and clinical examination, that's extremely important. And I'm sure as radiology trainees you realize that they don't provide enough information on the request to us, and that's why you know that it kind of links in with the radiology. So it's not like the history and clinical examination is just for the surgeons and physicians. We need to know as well what they found, because that tempers exactly what we might kind of recommend. Then obviously you have bloods. So these three, if you put all these three together, then you get decision making. If you have even one missing, it's extremely hard to get to the right decision. So we play a kind of very critical role in the whole process of the surgeon's thought process to decide which way he's going. Now this is pretty useful. I thought I'll put this, I won't spend too much time on it, but essentially how is the surgeon thinking? And I'm sure John is there, he's there. And I'm sure you will agree with that. The first question that a surgeon wants answered, do I have to go in or do I not to go in? So that's the kind of key question he has on his head. Do I go in or do I just sit on it? Then, if I do have to go in, what am I likely to find? So what is exactly the diagnosis? What am I supposed to do when I go in there? Obviously, he could open up blindly and then make up his mind on the table. But it's extremely useful to know beforehand. Because you kind of plan your strategy as to how you do it. What do I need to look out for? So just to give you a very brief example, yes, the diagnosis might be colon cancer, but it might be very important to know that the colon cancer is attached to the duodenum. Because then the surgeon is kind of thinking, oh, not only do I have to kind of do a colectomy or a hemicolectomy, but I also need to take care of the duodenum. And that's again information which you can relay to the surgeons. So if you just say colon cancer, he goes in and he says, oh God, it was a nightmare. Was a colon cancer, yes, but then it was attached to the duodenum and I don't know what to do. But if he knows beforehand, then that's again extremely useful for these surgeons. Do I need someone else's help? So these days, obviously, even surgeons are subspecializing, and therefore a colorectal surgeon might feel a little wary trying to do something to the duodenum. So if he knows beforehand that the duodenum is attached, he might say, oh, I'll get the upper GI surgeon to come along, yeah? Because then he can kind of decide what to do. So that's again information, unless he has imaging, he won't know that that's what he needs to do. Do I need to consent the patient for unusual eventualities? So it's possible, yes, if it was attached to the kidney and the patient might end up getting a nephrectomy, but you need to kind of consent the patient that you might lose your kidney or you might lose your uterus, and that again is a very important bit of information that's important for the treating physician to know, and that therefore imaging is extremely important. If he decides that, okay, there's nothing for me to go in, is there a need for any intervention? What needs to be done? Can interventional radiology do something? Can Nick Tessier do a drainage for me? Can the interventional radiologist block off the bleeder? Or is this a self-limiting condition, or does it need antibiotics, or does it need medications? So, and again, because if the treating physician or the surgeon needs to know what exactly he needs to do with the patient. Can interventional radiology help? Any more diagnostic tests that need to be done to get to the bottom of this? So this is the kind of thought process that's happening on the physician's end. And that's where we need to help. So your report just doesn't need to indicate, okay, colon cancer. You need to be answering all of these questions. Some of these questions are difficult to answer on the report itself. So you can't on the report say you need to go in. Yeah? But when the surgeon comes and sits with you, he's actually pleading and asking you. So I've noticed many times in my meetings, they won't ask directly because obviously it goes against their ego to ask the radiologist, do I need to go in or not? But he's essentially asking, okay, how bad is it? Yeah? So he's actually asking you, do you think this needs to go in or not? And that's where you need to be as good as him clinically. You need to be as good as him to understand the bloods. You need to be as good as him, and you ask him the question. How bad is he? Is he peritonitic? What's his lactate? What's his LDH? And then when you have all of that information, you can say, oh, I think we need to go in. And then you know, okay, yeah, two people are thinking the same, then you need to go in. Right, so today's talk essentially will go through in a systematic approach from a radiology perspective, which is abdominal anatomy, systematic approach in terms of looking at the tubes, lines, foreign body, bowel, free gas, calcification, soft tissues, bones, and finally the decision-making process. Right, so just starting with the radiographic anatomy, obviously you know all of this, where the colon sits, where the small bowel sits, the stomach, duodenum, and all of the other organs. From an X-ray point of view, there are essentially just a few tissues which cause contrast, and that's why we are able to see things on X-rays. So it's air, fat, soft tissues, bone, and metal. Unfortunately, within soft tissues, there is no contrast, so you can't see liver from spleen. So the attenuation that X-rays cause for urine in the urinary bladder, for blood in the heart, the pericardium, the muscle, the liver, the spleen, they all look exactly the same. But the reason why we see them still on X-rays is because of the fat around them. So the fat is extremely kind of useful. So having fat in the body kind of gives us this contrast, which can make us see things which we otherwise won't see. And then obviously bone causes far more attenuation, and as does foreign bodies and metal. And therefore we can use all of these tissues to kind of give us an idea of what we are seeing. So essentially on an X-ray, you'll see there's air in the lungs, and that causes some contrast. They are the fat planes, so that's the paracolic fat line, and therefore it outlines, can you see the liver? Yeah, so it's outlining the liver there, but this liver is obviously going down quite a long way, very similar to a Riddle's lobe. But if there was colon there, it could even outline the colon wall. You can see air in the colon is kind of outlining some of the colon. There's a little bit of air in the stomach, and therefore you can see a bit of the stomach margins. And then you also have, that's the liver, which is visible because of the fat around it. You can see the bones, and you can see metallic things, so those are tubectomy clips, which are also visible because of the contrast. So you get a lot of information on the X-ray based on just these 4 or 5 tissues. In terms of the anatomy, obviously you have the stomach bubble there, you have small bowel with air within it, you have the large bowel, so that's the cecum, that's your hepatic flexure, that's your splenic flexure, your descending colon, sigmoid colon, your liver, and your psoas muscles, which are very important. Always look at those, and then your urinary bladder. So using and the renal shadows, yeah. So don't forget the renal fat shadows, because obviously there will be problems with kidneys as well, which might be visible on the X-ray. Obviously CT gives you far more information, but then once you know that's where you're heading, you might tailor your CT examination based on the clinical findings and what the X-ray has shown. So those are the kidney outlines, again the bones and the SI joints. SI joints again important, because if you have sacroiliitis, then you know the patient might have inflammatory bowel disease, so you're just kind of picking up as many clues as you can. Yeah? So CT anatomy, again you obviously do CT in the axial orientation, but you can reformat the images into the coronal orientation as well. And you need to be very familiar with your CT anatomy, so liver, hepatic veins, IVC, aorta, so that's the liver there, the spleen there, the kidneys, pancreas, the small bowel. In this particular patient we have given oral contrast, but now more and more we have actually stopped giving oral contrast, we just give water. And obviously in a patient who is acutely unwell, we might either not give anything at all, or sometimes a little bit of water. That's the stomach again, outlined by the gastrographin that we have given the patient, the gallbladder, the pancreas, head of the pancreas, kidneys. And then obviously you see a lot of the fat, so you see the mesenteric fat, you see the omentum there, you see the flank musculature, the psoas, the vertebral bodies, and all of that information is available on CT to be garnished. Yeah? And sometimes things can be quite subtle on CT as well. So even though the contrast is beautiful between different tissues, you still have to kind of look out for findings on CT. So there's the appendix there. And again the SI joints and the rest of the pelvis, including your sigmoid loop in the pelvis and the urinary bladder. So same anatomy is also visible on the coronal orientation, and it's useful to actually scroll through both, and you can reformat it in sagittal and you can reformat in oblique directions as well to get more information if you see something which needs information in multi-planes. So that's your gallbladder again. You can see the portal vein quite nicely there. The pancreas just sitting on top of the portal vein, the third part of the duodenum as it crosses over. So watch out for the position of the duodenum, because sometimes you'll have intestinal malrotation and the duodenum might be in the wrong position. Again, cecum and the vessels as well, the aorta and the IVC. So this scan has probably been done at the 70-second interval, which gives you the portovenous phase, and you get reasonable contrast in the aorta as well. And again, all the structures that we saw on the axial scans again visible on the coronal images as well. Right, so X-ray, always look at obviously name and age to make sure that you're looking at the right clinical information for the right patient. Projections invariably is now supine. You hardly ever do a standing AP. If you, the chest X-ray, if that's done along with the abdominal X-ray, then that is a standing X-ray. And then occasionally you might do some special radiographic techniques like a IVU, contrast study, or polemic transit study. Technical factors for CT, you can do them in various ways. So you can do just a plain CT for example, for renal stones, single run 70-second delay, mesenteric angio, which will include a plain, arterial and portovenous phase. For mesenteric angio, you do the plain as well, because you see sometimes hyperdense contrast in the bowel, and if you don't have the plain and the angiographic phase shows contrast, then you're not sure whether this was present on the plane as well. If it was not present on the plane, then it clearly tells you that there is some contrast extravasation. And the delayed portovenous phase again to show contrast extravasation and bleeders. You can do a dual phase where you kind of do one run only, but you inject the contrast in kind of two delays with the saline push. Nick can talk about it in more detail when he talks about his CT. You can do CT as a urogram, which is again a plain KUB nephrographic phase and a delayed urographic phase. You can do CT enteroclysis, where we give mannitol to distend the small bowel and buscopan to stop the peristalsis, and then just do arterial run. So that gives you very good information of the small bowel. And then you can do CT pneumocolons as well, where again you instill air into the large bowel with buscopan, and you give gastrographin as well for fecal tagging. That gives you a colonographic picture of the colon, and with the software you can kind of run through the colon to kind of look for polyps and other abnormalities. Obviously in the acute situation, sometimes you might give oral gastrographin or water, but most of the times you probably won't give anything at all. So essentially the things that you're looking out for when you're doing CT for acute cases is look for tubes and lines and foreign bodies, bowel gas pattern, bowel thickening, pneumoperitoneum. So the bowel gas pattern would mean look for dilatation, because obstruction obviously is the commonest cause of the acute abdomen, calcification, bony abnormalities and soft tissues. So we'll run through a few cases looking at all of these. A plain X-ray report might typically just look like that. A bowel gas pattern is normal, no bowel thickening, no pneumoperitoneum, no bony abnormalities. But you actually look at far more than what the report just says. Management-wise, check previous films, correlate with the clinical history, discussion with the relevant clinical teams is extremely important. Further imaging if necessary, more X-rays, ultrasound, CT, and collaborate with decision making. I think that again is a very important part of the radiologist. Your job is not just to do a typed report and that's it. That's not where your role finishes. You are a physician. That's why you're part of the the College for Physicians and Surgeons. And that's why you don't have a separate college of your own, So because you're physicians. Right, so let's just start with the bowel gas pattern and a few examples. So this is what the normal bowel would look like. So you would see colon which is a bit fecally loaded, a bit of small bowel with small amount of air, little bit of the stomach, there's no dilatation, and that's a normal pattern. How do you differentiate between small and large bowel? Small bowel is more centrally placed, large bowel is peripherally placed. There are valvular conurbations which go all across the small bowel, whereas hostrates, they stagger themselves and don't go all the way through. Small bowel normally should be less than 3 centimeters. Jejunum can be up to 3.5 sometimes, again 2.5. Cecum, if it's more than 9, that's is considered as dilated. But patients who can be chronically constipated, sometimes it can be quite large. Colon in inflammatory bowel disease, so that's a kind of dilated colon. And you can see the hostras, they're not going all the way through, and therefore you can recognize that this is large bowel and it's peripherally placed. If you look at this one, okay, so these loops, are they small or large? Small. Yeah, so the valvular conurbations are going all the way through. Is it dilated or not dilated? So, did you have to measure it? So it looks dilated. Is the wall thickened anywhere? Right, so essentially, like this area here. So that's where the two walls are meeting. So there's a bowel loop there and there's a bowel loop there. And the two walls are touching. So this is the kind of combined thickness of two small bowel loops. And you can actually see it's a bit thickened. So it's probably fine there. The fat outside the large small bowel is kind of outlining the wall thickness, so it's not that thick. But probably it's this loop which is probably contributing to the thickness of the wall. So there are areas where the bowel is getting a bit thick, which again kind of warns you that something's getting more and more acute here. So now unfortunately here you can see the X-ray kind of demonstrates there is small bowel dilatation, there is probably obstruction. The colon is collapsed, so obviously it looks like it's a mechanical obstruction. It's possible there are some not dilated small bowel loops, but then it can't go any further. It can't tell you what the cause of the obstruction is. Is there an internal rotation? Is there an internal hernia? Or is there a tumor? Or is it just adhesions? So that information again can be gleaned by CT. Those are kind of likely sites of lesions. Right, so in a child, again, you can't use the adult dimensions, but you can eyeball whether the bowel is dilated or not. So is that dilated or normal? So that's clearly dilated. Anything else that's catching your eye? So there's a pneumoperitoneum. So did you guys spot that? So there's a Wriggler's sign there. You can see the inside and the outside of the bowel there, and that tells you that there's a little bit of, so all x-rays for newborns and children will be supine, yeah? So you won't get air under the diaphragm. The air normally will get somewhere on the top there, and occasionally you will see the falciform ligament or you will see the Wriggler's sign, and that's the Wriggler's sign there because you can see the inside and the outside of the bowel. So not only is there bowel dilatation, but there is perforation as well. Right, so again, dilated small bowel loop, small bowel, large bowel?
Small bowel.
Small bowel, okay. What's happening to the large bowel? Collapsed, dilated?
Collapsed.
So it's collapsed, so which tells you that there's probably mechanical obstruction somewhere, yeah? Where do you think the obstruction is? Jejunum, ileum? Okay, any other clues? I can see one of the girls pointing to something else. So tell me what you're seeing. Just
In the pelvis.
okay, yeah. So you're worried about that, yeah? So what is it?
A calculus.
So it's something calcified. It could be a calculus. Where could it be? So it could be in the bowel, but because the small bowel is dilated, it's possible it's a calculus stuck in the small bowel. So it could be in the small bowel. How would a calculus end up in a small bowel? Yeah, gallstone ileus. So what would you look for?
The gallbladder and within the biliary tree.
Great. So can you see any?
Yeah.
So it's there in the biliary tree. So the X-ray can actually give you a lot of information, isn't it? So even though I was saying that the X-ray gives you limited information, but sometimes it can answer the question nearly completely. Yes. So here you have small bowel dilatation, you have obstructed calculus, and you have air in the biliary tree. So you know straight away this is gallstone ileus without actually having to do CT. But chances are you will still end up doing a CT just to confirm it. And that's, I think it's the same question here. Can you see there's a calculus stuck there? The small bowel is dilated, and on if you scroll through, you can actually see that's the site of the obstruction. And let me go back. I think it was. Can you see there's air in the biliary tree? And there's air in the gallbladder there. Partial, so, and that you can kind of decipher from the fact that is anything going past. It also, if say for example the colon is very collapsed, there's no feces at all, it tells you that the obstruction is probably been longer than 24 hours because the feces are all gone off and nothing is getting past. So you can gauge the extent of the obstruction by looking at how much is getting past the site of the obstruction. And you can also make a rough idea of how long it has been going on for. Obviously with CT you can find out the level of the obstruction. You will quite often see a cause of the obstruction. If you don't see any cause of the obstruction, then adhesions is most likely. With adhesions you will sometimes see several times, you will see angulation of the bowel acutely at the site of the obstruction, and that gives you a indirect sign that it is probably adhesion. And that's very useful for the surgeon to know as well. Obviously with the history that the patient has had previous surgery also points towards that. And then if everything is dilated, small and large bowel, then it's heading towards ileus, or sometimes you might have localized ileus, like the pancreatitis, where part of the transverse colon and some of the small bowel loops are dilated. There's no clear-cut transition. So if there's no clear-cut transition, then it's possible it's ileus. Right? Obviously, it causes adhesions, hernias, inflammatory bowel disease, TB, Crohn's, radiotherapy, ischemic, gallstone ileus, intussusceptions. So with CT, look for all of these causes because that's very useful for the surgeons to know exactly what's causing the obstruction. Further investigations, this we talked about the various ways we can kind of do the CT. Right, 63-year-old male with change in bowel habits. Small bowel, large bowel? Okay. Any transition? So where do you think it's dilated up to? Rectum? It's not the rectum, yeah? Transverse colon is dilated? Planning flexure is dilated? Descending colon is dilated? All the way up to sigmoid? Sigmoid is dilated? So where do you think the transition is? So it's at the junction between the descending colon and the sigmoid. So something's probably going on there because you can see it's a kind of sudden transition and then this is not dilated, there's no area in the rectum. So you've deciphered it's large bowel obstruction. There is no definite pneumoperitoneum and there is something causing obstruction in the descending colon. And I'll just go back to this. I think there's a video here. So right, so that went quite fast, didn't it? So, I don't know whether you caught it or not, but there was a lesion in the descending colon. And the next slide kind of shows that. So there's a little tight stricture near the apple core kind of appearance. So there's a descending colon cancer which is from the obstruction. So this is a test for the speed at which you can pick files. Yeah? So what did you spot in that very quick run? Did you spot anything at all or nothing? Missed everything? Yeah, okay. That's good. Large bowel dilatation. Let me see the analysis of it. Right, so this is the third run now. Did you guys spot anything? So the problem is there. Yeah? It's in the splenic fracture. I can't scroll it. The mouse isn't working very well. But again, very similar to the last case, there was actually a tumor here. If you go up a bit, it's coming from the pancreas. So there was a pancreatic tail tumor which was obstructing the splenic fracture. Right, okay. Again, X-ray, normal, abnormal? So clearly abnormal, yeah? And I'm sure that's the abnormality you guys are thinking about, yeah? And what does that look like? Yeah. So do you think it's a cecal or a sigmoid volvulus? Right. So cecal volvulus invariably won't have this. Yeah. So so Hostra's both might have, but the sigmoid volvulus will have this large because it's the sigmoid which is doubled up on itself. So that's the kind of wall between the two dilated bits. Whereas in a cecal volvulus, you won't see a wall in between, but it's just one round thing which gets twisted. So the fact that you have this, what's this called? It's called coffee bean, isn't it? Does that look like a coffee bean? Yes. And inverted U-shape, apex in the pelvis on the left, and then heading towards the right side. And essentially try and ascertain if the cecum is normal because the differential is between cecal volvulus and sigmoid volvulus. Again, dilated one. Look at that. So that's the mesentery where the sigmoid is twisted. Yeah? And whenever you see that swirl, and it will happen in multiple places. Obviously, it will happen with the sigmoid volvulus. But if you have intestinal malrotation, again you will see the swirl. So look out for the swirl sign. Once you have swirl sign, that means something's twisted. Yeah? The mesentery is twisted, and then you can trace it to exactly what's twisted and then decipher which bit of bowel is got twisted. So that's how the sigmoid volvulus happens, and that's why you see that line in between because it's the kind of doubled up sigmoid. And that's more a cecal volvulus. Yeah? So the cecal volvulus tends to go up there because it's normally cecum lies there, so you won't see any bowel there. And then it's a dilated one single round kind of large bowel loop heading towards the left upper quadrant or the midline. So that's how the cecal volvulus invariably kind of forms. Yeah? And then you have intestinal malrotation. So watch out for, again you'll see the swirl sign. So normally the duodenum is supposed to cross over the aorta and the SMA and go on to the other side. But when you have intestinal malrotation, the duodenum stays on the right of the abdomen and the cecum can be high up. And because the small bowel mesentery goes from the DJ junction to the cecum. So normally the DJ junction would be lying there. So the small bowel is stuck to the back of the abdomen with a mesentery which extends from that point to the cecum there. So it's a very long base of the mesentery and therefore it can't twist. So the normal small bowel, the way it's placed in the abdomen, it can't twist because it has a very long mesentery. But when you have a situation like this where the DJ junction is here and the cecum is here, then the root of the mesentery is just heading from there to there. So it's a very small pedicle. And it has a tendency to kind of twist. Yeah? And then once it twists, you will get a mid-cut volvulus. Right, so here we know a little bit of the clinical history. 37 years old male with ulcerative colitis. So what are you seeing? Small bowel, large bowel? Dilated, not dilated? And very dilated or medium dilatation? Yeah? Very dilated? Yeah? So large bowel, so the process colon is quite dilated and the descending colon isn't that dilated. And with that history, then what are you thinking of? What else can you see apart from dilatation? Yeah, so the wall is thickened and it's also become ahostral, yeah? So it's really like a kind of lead pipe. So in inflammatory bowel disease, if the large bowel is dilating, that's not a good sign. That means chances are he's developing toxic megacolon. And the reason that happens is the inflammation is reaching up to the myopic plexus, and that's knocking off the innervation of the bowel, and then the bowel is dilating, which means that the inflammation has reached up to the serosal surface, where or the deep muscular layer where the myopic plexus sits. And therefore they are at a very high risk of perforation. If they perforate, then it becomes very messy. So surgeons would invariably try and offer a total colectomy prior to perforation. So if it's a patient is heading towards, so toxic megacolon obviously is a combination of findings. They have to be clinically toxic as well, white cell count has to be up, ECRP has to be up, and they have to be a bit peritonitic, and then the bowel is dilating. With that combination, the surgeons would go in. So even at this stage, because they won't wait for it to perforate. So normally large bowel you would use 8 to 9 centimeters as the cutoff where the risk of perforation is gone up to the normal bowel. But in inflammatory bowel disease, and if you're suspecting toxic megacolon, then 5 to 6 centimeters is enough to start ringing your warning bells. Yeah? You need to tell the surgeons, I think we need to go in. Yeah? And then they can do a total colectomy. So dilatation greater than 6 centimeters transverse colon required a hospital high risk of perforation, obviously with inflammatory bowel disease. Right, so causes of large bowel dilatation, like we saw, volvulus, sigmoid, cecal, stricture, carcinoma, diverticulitis, ischemic, ileus, toxic megacolon. So always remember these various causes. Now heading towards bowel wall thickening. So again, large bowel, small bowel. Dilated, not dilated? So a bit dilated, yeah, but that much caliber of the large bowel is still within acceptable limits. But more importantly, so can you see this appearance of the wall, yeah? So this is what we call as thumbprinting. You can see they're kind of nearly, you can put a thumb there, so there's a bump there, and there's a bump there, and a bump there. And that means that there is, when you see thumbprinting, it is essentially on a histological level, there is hemorrhage happening in the submucosa. So it's kind of blood collecting in the submucosa and forming a bump, and then the hostra is still preserved, so the next bump and the next bump. But that's not a good sign. That's a sign that it's getting ischemic. Yeah? So this, if you see thumbprinting, that's a sign of ischemic, whatever bowel is thumbprinted. So it could be ischemic colitis or ischemic enteritis. So in this case, obviously it's large bowel, so it's probably ischemic colitis. So same thing happening there. Here you can see the thumbprinting is even more prominent. Yeah? And again, that's a sign of ischemic colitis. Right, so just for comparison, that's what so that's not thumbprinting, that's normal. Yeah? So normally the wall should look like this. But if you look here, that's where you can essentially put your thumb. Right, so look out for inflammatory colitis, infective colitis, pseudomembranous colitis, ischemic and neutropenic colitis. Then pneumoperitoneum. So pneumoperitoneum, obviously chest X-ray is pretty good at finding air in the large bowel, and you can see it under the diaphragm. But again, even if you see a large amount of pneumoperitoneum, you'll still end up doing a CT to try and find out where is this air coming from. This again we were talking about earlier. Not only is the small bowel dilated, but there is also what sign? Regular sign, yes. So where all are you seeing regulars? So there are regulars in lots of places, yeah. So there's a regular there, there's a regular there, there's a regular there. So there's a lot of small air within the between the bowel loops, yes. So that's again pneumoperitoneum, but as seen on a supine X-ray. And same thing on CT. Obviously, you will see a lot of air. You can see the falciform ligament there, and on CT you might also be able to decipher where the perforation is. So that's again important. If you see a large amount of air and fluid, then chances are it's small bowel. The small bowel has a lot of fluid, and fluid comes into the peritoneal cavity. If it's only air, then chances are it's probably large bowel. or it might be duodenum because there isn't enough fluid to kind of leak out. The duodenum, the sentinel air is more likely in the upper quadrant around the falciform ligament and the subhepatic location. So wherever you find sentinel air, that's a good sign of that's likely where the perforation is. And if you look carefully on CT, quite often you'll actually see the perforation. So first you can try and localize where is it most likely to be, the large one, small one, and where is the sentinel air in the mesentery, the maximum amount of air. Once you spot that, then very carefully crawl through the bowel in that area, and sometimes you'll see the hole. You'll see air connecting between the peritoneal space. And you can even tell the surgeon how big the hole is. Yeah? They get pretty impressed when they come back and say, oh, it was exactly the same size. Right, so again, you can see a dilated stomach and wriggler sign. Yeah? So the wriggler sign is outlining the wall of the stomach as well as of the small wall there. Again, pneumoperitoneum in a child, so that's the kind of football sign it's called, isn't it? Football sign?
Yeah.
So where the air kind of connects under the anti-abdominal wall, and it can also outline the kind of falciform ligament. Right, so what are you seeing here? How old do you think this? Is this a child or an adult? How old do you think the child is? Newborn, yeah. How do you know it's newborn?
Or premature.
Yeah, might be premature as well. Right? So the femoral ossific nuclei hasn't come up. Yeah. So when does the femoral ossific nuclei normally come up? 6 months. So actually, it would be less. It would be less than 6 months. But he is actually a newborn. Yeah, and he's also preterm. If you know that information, then what are you thinking? So you can see there's a lot of air in the bowel wall there, and that kind of tells you child baby is going into necrotizing enterocolitis, and there's a large amount of the air. So the amount of air can also prognosticate. So this one has a bad prognosis. It looks like nearly all of the small bowel has got air. And the air can then travel through the bowel wall into the portal system as well. So you can see air in the portal system, and that again is quite a ominous sign that the baby is not likely to survive. Same thing on CT. So you can see there is gas in the portal system. Portal system gas goes more peripherally. You can actually trace the veins and see that it's in the veins rather than in the biliary tree. And you can see there is air within the wall of the bowel, which might be hard to appreciate on this window. So then that's air in the bowel, yeah? And you might actually miss it. You might think that's just fecal matter. But what you can do is you can change the window and you can mip your images, which is stacking up multiple images, and you can actually see that the air is all in the bowel. Yeah? So that's quite a nice, impressive picture to demonstrate here. Right, so pneumoperitoneum, erect chest X-rays, supine X-rays, falciform ligament, and all of these signs, and look for portal venous gas as well. Coming to calcification. So renal stones, gallstones, vascular calcification, liver, spleen, pancreas, uterus, ovaries, fibroids, dermoids, twisted dermoids, prostate, seminal vesicles. You can get calcification in all of these areas, and that can sometimes give you a clue as to what's going on. So you can see there's a bit of calcium there. There's some calcific deposits in the pelvis, which are probably phleboliths, nicely rounded, but that could be a renal stone. And you can do a CT renal plaques on a horse, even if there isn't a stone, because they might eventually form stones. And it might be useful for the physicians to know that they have a tendency to form stones, and they can then alter their dietary things to make sure that stones don't form. So renal plaque forms invariably in that calyx there, but then it becomes bigger, and when it becomes bigger than 2 millimeters, then it becomes a stone, then it can get dislodged, and it can get even bigger, and that obviously is a Staghorn calculus. and you can do we hardly do intravenous urograms anymore. Do you guys do any IVUs? Yeah?
Now more of sitting.
Yeah. So we replaced IVUs with CT urograms now essentially. I haven't seen IVU for the last maybe 10 years. But historically we did IVUs. But obviously, if you don't have CT, it's a fantastic tool. And the resolution actually on IVU is sometimes better than a CT. So when you find nasal abnormalities, but we've probably got de-skinned looking at IVUs. So subtle TCCs, which can be hard to see. I'm an old timer, so I might still spot it, but I'm sure the new guys, they're not used to seeing IVUs. So here's a historical IVU. So normally we do a plane to look for any stones. Then we do a nephrographic phase, which covers the kidneys, and then you do a delayed urographic phase, which is about 10 minutes. And in between, you might sometimes turn the patient so that the contrast kind of falls through to the ureters. And majority of the time, we are able to see the ureters in their full length. Quite often, bits of ureters may not be seen. But as long as there's no dilatation proximal or distal to it, even if you're not seeing the ureter, you can be reasonably assured there's nothing sitting there. So I think even though they're not as good as the conventional IVUs, they give much more information in terms of where the stone is, the size of the stone, and when there are tumors, you can obviously stage them as well. I just left. A bit faster. Right, so a bit slow. to kind of look at the ureters, but the one ureter there, the other ureter there, and that's how you would kind of scroll through. You would actually scroll through much faster than this speed in real life. We'll spot vascular calcification, which when it gets very close to the ureters can mimic calculi, but if you do a urogram, then you can kind of clearly say it's outside the line of the ureter. So ureters going into the pelvis there, that's the other ureter, bladder appearing now. And the secondary junctions of the bladder. Did you spot it? Yes. Okay. So that's how the CT-IVU makes things so much easier to catch. This bladder cancer on a normal IVU would have been slightly harder, yeah? Because it's small, and if your view of the bladder is slightly oblique, you might kind of miss it. Yeah? Young women, pregnant women, young children, again, you won't want to use CT, and that would be a situation where you would definitely use ultrasound. So do you guys use ultrasound for appendicitis? Ultrasound, yeah? Is that the first line, and then if you don't, yeah, and then if you don't see it. So how often can you find a normal appendix in ultrasound? Now, okay, well, what are your own personal experiences? So how many times have you seen a normal appendix? Never. So the literature rate is about 11%. 11% of times you should be able to see the normal. But it's extremely operator dependent. I have done a study on my own self, and I find it about 80% of time. But you have to spend a lot of time, and you have to kind of know where to look for it. But it's extremely useful to find the normal appendix, because then you can stop. Because if you haven't found appendicitis and you haven't seen a normal appendix, then you're not 100% sure that it's not appendicitis. But if you find the normal appendix, then you can check it. You can stop. Say, okay, it's not appendicitis, I've seen a normal appendix. Right, so that's the CT. So C comes a bit dilated as a result of the ileus. And did you spot the appendix? Right, so again calcification, you can see there's a lot of calcification which appears to be in line with what? Okay, so it is kind of, that's chronic pancreatitis and calcification for chronic pancreatitis. Can you spot where the problem is? Sorry?
Triple A.
Okay, so Nick is saying triple A, right, left?
On the left.
On the left, so he's worried about this. Yeah. So there is, again, you can see a slightly calcified soft tissue density. It's got kind of peripheral margin to it. And so it is a triple A. So the again, X-rays can kind of give you clues as to what's going on, and it's very useful to have thought of that, because then you would do the CT as an angiographic study rather than a normal single run study. Okay, gallstones. So they can be occasionally calcified, but majority of the time obviously they are not. Ultrasound is obviously the modality of choice for gallstones. Calcified fibroids in the pelvis, you might just incidentally see them. Invariably they don't cause any problems, but calcified dermoids, if there's pelvic pain, then think of torsion. Calcified autosplenism, so sometimes the spleen can be just calcified and lying in one corner. Might tell you the patient's got sickle cell disease. Does he have sickle cell disease?
Oh, yeah, it's common.
Does he have sickle cell?
I don't know.
So, he-
The right.
so the right hip is gone. And the vertebrae are showing the H sign. Can you see the H sign? You guys see it more often than we do. Agree? Sickle cell? What was the hip okay?
It's a calcified hip.
Right, so coming to bony abnormalities, obviously look at the bones for lytic or sclerotic lesions, metastasis, fractures, spinal alignment. So here you can see there is osteitis condensa ilii, but you could also see erosions which would suggest sacroiliitis, which would indirectly say it's possible they have inflammatory bowel disease. So that's a kind of good clue. Here again, you can see that hip is arthritic, but the SI joints are poorly visualized, and the transverse colon is ahostral. So that's inflammatory bowel disease with underlying sacroiliitis. What's happening here? That was fine. Yeah. So that's ankylosing spondylitis, very severe osteoarthritis. Needs Paul's handiwork there. What's happening here? Yeah. So multiple sclerotic lesions and a pathological fracture there. So obviously most likely metastatic. What's happening here? Which medical? That one? So missing pedicle. Historically, we were very good at picking these things, isn't it? Now we hardly ever kind of do that because you obviously have CTs and MRs to kind of pick these things up earlier. But occasionally there might be a situation where you have abdominal X-ray and you spot that. That then clinches where it's heading. Right, so soft tissues. So again, same air, fat, soft tissue, bony, calcification, metal. That's in the morning to remember those things. So here you can see the tubectomy clips visible. Okay. What's happening here? Bowel abnormal. So there's a so you can see there's a kind of, this shadow is a bit bigger than you would expect, and the spleen is heading a long way down, so there's splenomegaly there. What's happening here? There's obviously something happening there, isn't it? So there's a soft tissue there. Where do you think it is? What? Spleen. Yeah. So either spleen or could be kidney as well. So he actually had a Wilms tumor. Oops. So Nick is pointing to the psoas on the right. So that's again an important thing to kind of watch out on abdominal X-rays. You can see the psoas on the left is normal. On the right it's clearly bulky. And so there's an aneurysm of the aorta which is ruptured into the psoas. Yeah? So it's a leaking aneurysm. Okay, what's happening here? So you can see the bowel loops are kind of all clustered in the center, maybe a bit dilated, stomach's not dilated, but just a generalized age. Yeah, so you can see the flanks are kind of pushed on the side, lots of soft tissue on either side. So again, indirectly tells you that there is a ascites. And you can see on the CT his liver is very nodular, very shrunken, so obviously cirrhosis related. Right, so tubes and lines, this is gastric band. We see it quite often in UK, obviously, with lots of bariatric surgeries. Just a feeding tube, jejunostomy, the tubectomy clips. This clip here, and it's kind of useful to remember this appearance where it folds a little. That's a Felci clip. This used to be used about 15-20 years. They've actually stopped using them. They were tubectomy clips, and they have a tendency to slip. So they slip many years down the line, and then they float around in the peripheral cavity, and they will end up in various places. Recently, I had a spinal surgeon who came in and said that the MR, patient was having an MRI and they put him in the MRI. There was a big artifact from this spine. And they stopped. They said, "Don't know what it is." And he said, "Can you tell us what's happening? Can you have the MRI? Can you know what happened?" So it was a filchy clip which had kind of migrated up there, lying next to the spine. So it's actually compatible with an MRI. But because I knew about it, I said, "Oh, that's a filchy clip." It migrates. So they were thinking it was a bullet or a foreign body or something. So, but they can sometimes cause pain once they step. They might lodge somewhere and then they can cause tummy ache. So it's useful to kind of find these lying in places where they should be. Right, so what's that? So we see it all the time, but I don't know whether you guys see it. Do you know what that thing is? Yeah, so it's an EVAR prosthesis. So that's a stent which they put for aneurysm of the aorta. So it comes in various segments. So you can see there's one stent there, then there's an iliac limb, then there's a left iliac limb. So in our hospital we have 3 vascular radiologists who do these procedures. Very common procedure. And when you have a EVAR, so that's what it looks like on CT. You can see the stent. The aneurysmal sac is still on the outside there, but because obviously there's a stent there, no pressure is being transmitted into the aneurysm, so the aneurysm doesn't rupture. But sometimes you get leaks, and with EVARs they're called endoleaks. It's not like a leak from aneurysm, it doesn't come out, but it leaks from the inside, and there are 6 or 7 different types of endoleaks. So you might get an endoleak as a result of collateral supply through the lumbar vessel. So if you see contrast in the sac, that means there is some form of endoleak. It might be on the top of the stent, it might be on the bottom of the stent, or the stent might be damaged and there might be a hole in the stent, or it might be from collaterals. Yeah? And an endoleak, again, because the pressure gets transmitted to the aneurysmal sac, again it can rupture. So once you have an endoleak, they'll just watch it. Sometimes they might want to embolize collaterals, or then surgically repair. So this one doesn't have an endoleak. So you can see there's no contrast in the sac around around the EVAR stent. Right. So occasionally you will have again displaced operating devices or IUD devices. Again, for a radiologist, very important to observe that there is a IUCD. Recently we had a case, in fact I was thinking I'll bring it and I forgot completely. In fact, Nick was involved in it, we biopsied as well. So I'll just tell you the story so that it kind of stays in your mind. It's something that will occasionally happen with you guys. So 38-year-old woman came in with very severe pelvic pain. We did a scan and there was a lot of soft tissue in the pelvis centered around the sigmoid, and people thought it was a sigmoid cancer or something, but she was just 38. And she also had a lesion in the liver. She said, "Oh, most likely colon cancer and a liver met." But then the thing to note was that she had an intrauterine contraceptive device. So what did she have? So a lot of very aggressive looking soft tissue in the pelvis centered around the bowel and the adnexa with an intrauterine contraceptive device and also a liver lesion. What are you guys thinking of? So Carla is thinking of infection. Which infection? Which infection? So there is one particular infection which is very prone with coils, especially copper coils, actinomycosis. Actinomycosis invariably presents as tumor because it looks very aggressive, and then you can get hepatic actinomycosis as well. So in fact, they can be biopsied the tissue around the colon, which came back as inflammatory, and then we biopsied the liver lesion as well, which also came back as inflammatory. And she was put on penicillin and she responded dramatically well. Right, so what's that? So that's a VP shunt, yeah. And anything else? Nick is saying there's a plate. So you can see there is a big soft tissue density there, and then it's pushed all of the bowel there, and then there is a VP shunt. So you can have pseudocysts forming around VP shunts. So the CSF kind of gets encapsulated, yeah, and forms a cyst, which can also block the shunt off. Right. So it's kind of hard to spot on this X-ray, but anything catching your eye? Okay. In the left upper quadrant. Yeah, so Collar is, I think, talking about these little densities there. So what would you think of? So 43-year-old man came in recently from South America. I'm making up a bit of the story. And reported in A&E with abdominal pain.
And we're just down the road from Heathrow.
He's come directly from Heathrow Airport.
That's only small.
So, and we get this quite often, yeah, so it's not uncommon. So it's cocaine packed in little packets, small amounts of various. Okay, so, right, so sorry I overshot it a bit, but X-ray abdomen in a child with abdominal pain and vomiting. The thing to look at is the stomach looks a bit kind of soft tissue, density, a bit distended. The rest of the bowel looks reasonably okay and unremarkable. So, what would you think of? Yeah, so it's a good one. And when we did a barium, you can see it, so it was all hair, yeah? So some children, when they're mentally challenged, they keep swallowing hair. So it was a trichopizar. Okay, anything? Yeah, everybody can spot the foreign body. What is it? Hair clip. Okay, anybody else? Come on, you can guess. You're allowed to guess. What do you think it is?
I just can't.
You don't need to be a radiologist to guess this.
I'll say foreign body. Foreign body.
Foreign body, yeah. But what's the foreign body?
That's what they do.
Radiologist, come on, we have to beat the surgeons. Okay, then can anybody describe it? What shape is it?
I know, like a ring shape. Or a bit like a. Okay, it looks like a.
It's an end-on view of whatever it is.
And on, oh, okay.
So it's nearly oval shaped, isn't it?
Yeah,
It's a bit pointed there and a bit rounded there, so nearly like a boat-shaped thing.
Like a crown.
Crown, yeah. The Queen's crown, somebody saw. And small dots, very nicely lined up in rows, and they're end-on. So. Okay, I think you guys are giving up, yeah? It's a toothbrush.
And it's the power brush.
Right, so these few cases happened just, I think, a couple of days before I came, so I thought I'll bring them along. So pain abdomen with drop in hemoglobin. We did a CT angio. I didn't note the whole images, it was taking a very long time, so just one picture of. So this was, we did it as a mesenteric angio. This is the delayed picture of the mesenteric angio. And there was a little blush of contrast in the colon. So the patient was bleeding in the colon. So we spotted the bleeder on the CT. One of my colleagues, Dr. Zamir, who's really good at this, he got into the area and you can see there's that little extra precision of contrast. So he spotted where the bleeder was. And he went in using microcoils, reached up to the point of the bleeder, and then he squatted. So This was another patient he recently did. This was a bleeding angiomonal lipoma. And Dr. Zubair again went in, first did an angio, so you can see that's where the blush of the contrast is, that's where the bleeding was happening. He found the bleeder and embolized it with a coil again. So these are things again, you can do additional things. Once you have found something on CT, the interventional radiologist can go in and sort things for you as well. So 90-year-old with pain, abdomen, distension and vomiting. Okay, now this one, obviously it will go fast, it's a video, yeah? Whoever spots this, and Nick and Khala, you're not in the game, yeah? There's a bottle of wine at stake. I'll get it tomorrow for you. So this video I've taken with my phone camera, yeah? So it's a bit shaky because my hand was shaking. Oh, too fast. Let me see if I can make it go a bit slower. Actually, maybe if I come over the slideshow. I'll try and pause it. So essentially I'll help you obviously because the scrolling was too fast. So small bowel dilated, large bowel was not dilated. So you're not in the game. And you couldn't see, so this was first reported by our teleradiology company and they said there was some intussusception. So the surgeons came down, what are they talking about, what intussusception? Then our radiologist said there is no intussusception. It looks like ileus. Yeah? And then they said, oh, ileus, but the large bowel is not dilated, patient's unwell, she's 90. And the surgeons didn't want to go in. Yeah? As surgeons obviously do, they never want to go in. You have to push them. So, then the third radiologist said, oh, I don't think it's ileus, it's mechanical, but there's no real cause, so it's just adhesions. And the surgeon again said, oh, okay, then let's just leave it. Maybe she'll resolve, she's got lots of comorbidities, don't want to go in. But then we spotted something which we said, no, you have to go in. And it's on this picture. Carla's smiling, she's smiling.
Hello.
The abnormality is somewhere in the pelvis, below this line. It's in this area. Yeah? Okay, I'll narrow it even further because I want to get. Sorry? Yeah, fantastic. So there is a small obturator hernia. Can you see that bit of the bowel just poking out under the pectineus muscle? So you could actually trace a bit of bowel which was going out and was stuck in the obturator sac. So obturator hernias, the morbidity is really bad if you don't operate. Yeah, they will invariably die, and it's very easy to sort. You can even do it laparoscopically. Just go and pull the bowel, put a couple of stitches in the obturator membrane, and it can be sorted. So even though she was 90 years old and she had lots of comorbidities, we kind of pushed the surgeon to say that no, go in, this can save her life. Even if she's 90, it's worth doing it because it's but unfortunately, I think because she'd been sitting on it for a couple of days, she actually died before the surgeons could go in. But the surgeons agreed and they said, okay, let's book her for theatre, but she died before they could go in. But that's how kind of radiology, this is I think my last case. Which, there's one more. I think because I've run out of time, I don't want to infringe on other people's time. I'll just quickly show what's seen on this. So X-ray was normal, patient was unwell, a bit peritonitic. CT also looked reasonably unremarkable, but just very, I'll go back again. So If you look carefully, can you see there's a little few specks of air there? So clearly there's some perforation there. Then the rest of the bowel looked all okay, but when you look very, very carefully as you came to the duodenum, you could actually see a hole in the duodenum. Can you see that little spot that way? And we could do reformats. We did a few reformats to actually show where the hole was, and we exactly told the surgeons that the duodenum perforated. This one they went in and sorted the patient. Right, so I think that finishes it all. Essentially, I'll just summarize. I think we'll skip these. This one's an interesting one. This was a 70-year-old with pain and sepsis. And we did a CT, white cell count was very high, liver functions were off, so they were thinking there's a liver abscess or something. But then there was this abnormality which was centered around the duodenum. And when you reformatted, you could see that little white dot there. When you reformatted, it was a linear thing there, like long linear thing. So got it back for an ultrasound. That's the duodenum there, that's the liver, that's the portal vein. There was this linear thing which was going from the duodenum into the portal vein. Toothpick, yeah. So it was a toothpick. Swallowed. With an entroportal fistula.
I've seen a couple. It will give you that density.
Right, maybe one last one. Okay, another bottle of wine on this one. 81-year-old male admitted with severe lower abdominal pain, 2 centimeters. Now, reason it's ABC, you might think this is from a journal. Actually, we presented this case, so I think it's been accepted. It went through a few revisions. And we had 3 or 4 cases in a series, so we presented all of them. So we presented with severe abdominal pain, 2 to 3 centimeter tender, irreducible lump in the suprapubic groin area. So there was this lump here, lots of soft tissue inflammation. The bladder showed a little bit of air. There was possibly a little bit of erosion of the pubic symphysis. This was the MR. The patient was in very severe pain, so we did an MR, and on MR there was extensive edema along the adductors and the pectineus and in the pelvis. That's the unibladder there. And when you do the SAG, you can see that's the unibladder, so they catheterize the patient. So what's the diagnosis?
Anybody?
The clue is here. So he's been treated for prostate cancer. He's had surgery, resection, and radiotherapy. So this is...
could we say something about necrotic and then perforation on the air?
Right. So your logic is absolutely right. So
You mean from orthopedic surgeon?
and in fact, out of the cases of, I think we had finally 5 cases, 3 of them were under orthopedic surgeons because they all had groin abscesses and they had...
And osteomyelitis, maybe.
Yeah, so this is a condition called urosymphyseal fistula. So you get a fistula between the bladder base where the prostate surgeries happen. Because with prostate surgery or radiotherapy, there's a normal fascia there which gets injured. And over a period of time, the urine passing through the posterior urethra can communicate into the pubic symphysis. So the urine leaks into the pubic symphysis, causes osteomyelitis, and then leaks into the groin from the front of the pubic symphysis, causes a massive amount of edema in both muscles. In fact, this appearance on the MR, we called it Lorax sign because it looks like the comic picture Lorax, character Lorax. And I think if it gets accepted, then one of my registrars who did it, it will be named after his invention. So, very unusual, only about 60-70 cases reported, but we had 5 cases in our hospital. So we thought it was worth presenting because it was a series of it. So urosymphyseal fistula from previous prostate surgery. Right, so essentially to summarize, your approach should be quite systematic, kind of look at all of the things. Once you become very good at it, you just go through and you should catch the findings. But always put in clinical information always put in the bloods, find out what the bloods were, what the kind of story is in a acutely unwell patient, and always sit with the surgeons, or when they come down, discuss with them and try and form a collaborative action plan. Yeah? Because you can contribute tremendously to the patient's outcome. Thank you.
That's absolutely fantastic. Do you think that having private laboratories or X-ray companies outside the hospital helps us in learning what is happening in patients? Do the surgeons communicate with private radiologists? Does it happen? Do they learn what they was correct or not? So we have a problem in this case.
It's even difficult to get that collaboration.
It's not working. Okay. Right. The next topic is so you have anything to say before the second speaker comes to? Do you think you learned anything from it? I think I've learned a lot. I didn't know much about a bowel, but today I've learned a lot. Absolutely fantastic.
I think had we known that it was all radiology, we would have got more complicated cases. Because we thought they were going to be surgical registrars.
Now you can look at them on your own.
So what was the
I was Nigerian, did my primary medical qualification in Nigeria, then moved to the UK to do radiology training. This is where we work, the three of us, Nick, Ash and myself. This is a picture of the hospital, and our hospital is located just outside of London. So I thought I'd talk about radiology training in the UK, and there might be some practices that you guys might find beneficial that you could think of replicating. So I'll start off by discussing why I think radiology is great. The structured radiology training in the UK, the subspecialties that we have, the curriculum that we have. We'll talk about assessments, examinations, we have loads of those. What a regular day in the life of a registrar looks like, the modalities that we have, what others trainees can authorize, multidisciplinary team meetings, and what radial training is really like, and then at the end I'll share some free resources that you guys can use in your daily practice. So, I thought I was pitching radiology to non-radiology registrars, but given all of you are registrars, you know why it's great. It's a pivotal specialty upon which all specialties rely. Hardly any patient comes into hospital without undergoing any type of imaging, and will never run out of work. It's very diverse, different modalities, different activities. You could do procedures, you could scan, you could participate in multidisciplinary team meetings, you could do research. It's very diverse. It's a general specialty, there's something in it for everyone. You can choose a subspecialty from a large area of subspecialties. There's good work-life balance. It's essentially a 9-to-5 job. And consultants don't do on-call in the UK. I don't know about Ghana. Do you guys do on-calls?
Occasionally, yes.
Occasionally. There's a shortage of radiologists worldwide. In the UK alone, there's a shortage of 500 posts of consultant radiologists. So we're badly needed everywhere. And finally, it's a very flexible work. You can do teleradiology. You could be essentially in the UK reporting scans in India or elsewhere in the world. And nowadays, especially since COVID, consultant radiologists, at least in the UK, have working stations at home, and you could be essentially working from home. There's full-time and part-time work. You could choose from different subspecialties. You could do research. You could work in a district general hospital and be a general radiologist, or you could work in a teaching hospital and subspecialize in a single thing and believe that the whole body is just comprised of a single thing. And finally, you could do private work and make money. Okay, so there are two types of of training pathways in the UK. There's the academic pathway. Only a minority of people apply for that, people who want to go into academia. and they divide their time between doing research and doing clinical work. And I think they're expected to have finished their PhD prior to finishing radiology training, but most of us do general clinical radiology pathway, which I'll discuss in a bit. As the graph shows, it's an increasingly competitive specialty in the UK. As you can see, the competition ratio is quite high. Essentially, 5 people compete over a single seat. So when I applied, I think 1,600 people applied across the UK, and they only had 150 seats. So yeah, it's very competitive. Okay. So the training scheme is usually 5 years, but 6 years if you decide to undertake IR, Interventional Radiology, as a subspecialty. It's a run-through program, which essentially means that you can apply to clinical radiology straight after finishing your house job. Whereas for medical specialties like cardiology, respiratory medicine, you need to have done internal medicine training for 3 years and then apply to them. Whereas radiology, you can go straight after your house job. In the UK, the house job is 2 years, FY1 and FY2. And then go into clinical radiology training. The first 3 years are core radiology training. And the second 2 years is when we subspecialize in our area of interest. Upon completion of the training, we get our CCT, Certificate of Completion of Training. And some trainees go on to do a fellowship in an area of their interest just to gain more work experience. So, ST1, in the first year, ST refers to specialty training. So ST1 are first year residents. Essentially what we do in the first 6 months is get introduced to different modalities like X-rays and CTs, and we prepare for an exam. It's a physics and anatomy exam, which I'll discuss in a bit. In the second 6 months of ST1, ST2 and ST3, that's when we learn core radiology, and we start interpreting cling film, CTs, MRs, fluoroscopy, etc. So all modalities, and we do that in 3-month blocks to cover all subspecialties. And we enter the on-call rota. I've done my first on-call last week. So we don't have evening or night on-calls in all hospitals. Some hospitals do, other hospitals don't. And we prepare for another fellowship exam, a first year part 2A at the start of ST3. That's the theory-based exam. And then the final oral exam is in ST4. So ST4, ST5 is when we do our subspecialty training. As I've mentioned, some people do a 6th year if they choose to subspecialize in IR. And yeah, FRCR Part 2B is taken at the start of ST4. And upon completion of FRCR, one can add FRCR letters at the end of their name. Okay, so these are the different subspecialties that we have. IR, MSK, breast, GI, pediatric, neuro, chest and cardiac, GU, head and neck, and nuclear medicine. And we cover all of these in 3-month blocks, as I mentioned, during ST2 and ST3. So the FRCR is the most intimidating part of radiology training, and it's what dissuades most people from applying to radiology. I've done part 1, so part 1 covered physics and anatomy. Basically, we were shown random pictures, and we just asked to identify what the structure is. Part 2A consists of 2 papers containing 120 questions that cover the range of all subspecialties, and it's done in 6 hours, 3 hours for each paper. It's a 1-day exam, and that's taken, as I've mentioned, in ST3. And then in ST4, we take the 2B exam, and it consists of 3 parts. So rapid reporting, we report rapid plain films, so you need to pass at least 28 out of 30 to pass. If you fail more than 2, you failed your exam. It's a very, very difficult exam. The second part are long cases. You're shown 5 cases, and they show you different modalities. You start with an X-ray, and then I think if you identify the pathology, you move on to CT. meeting, and then you move on to the next modality. And the last bit is an oral exam where you show random cases in an hour. So the RCR is the Royal College of Radiologists, and they issued a new curriculum in 2021. Basically what they're trying to do is to move away from emphasizing exams and more to encourage radiologists, encourage trainees to develop capabilities and skills, and we're tested on those skills in addition to passing our exams. I'll discuss that in a bit. So basically the goal is to make sure that trainees develop specialty-specific capabilities in addition to generic professional capabilities that are expected of all doctors. So what we're expected to achieve by the end of our training is to be able to provide general and emergency radiology, diagnose and monitor major morbidities, detect, diagnose, stage and monitor cancer, guide the referring clinicians to the most appropriate investigation. This is done through consulting. So when we're in AU is acute assessment unit. So basically when we're on call, we get calls from GPs, clinicians, and we're asked to give advice on what the best modality is for a specific clinical question. We review findings. And yeah, the next bit is we participate in multidisciplinary team meetings. I'm not sure if you have those in Ghana. We do, yeah. And finally, we're expected to develop leadership, management, educational skills that are required to train other professionals in radiology skills. So this is how they test us. We have an online platform called Kaizen. It's basically an online portfolio that each one of us as trainees has. We enter basically evidence of our progression, and consultants are the ones who vouch that we've progressed. Okay? So there are a number of assessments that we need to enter onto the platform and get consultants to sign for us. And then by the end of the year, there's a yearly assessment that's done by a TPD, which is basically a consultant who's responsible for all trainees in a region. Okay? And they make sure that we fulfill all the criteria for us to pass our year. If we don't pass, we need to make sure that we fulfill those criteria before we move on to the next stage. Most people pass because it's straightforward. We know at the start of the year that we need to achieve these criteria in order for us to pass. So the first thing is called mini IPX. We need 6 of those in a year. It basically means that when we report in AU, which is basically we're on call, we ask consultants to rate us, to give feedback on how we performed. I'll show you what that looks like on Kaizen in a bit. Red dots is when so a consultant or sonographer or radiographer observe us perform ultrasound or perform something practical. And again, they give feedback on our performance. 360 appraisal just basically means we're getting feedback from all team members on our comportment, how we behave as a team member. Audits and quality improvement projects, we need to do at least 1 in a year. I'll discuss what that's about in a bit. And in ST3, starting from ST3, we're expected to start leading multidisciplinary team meetings, and we get assessed on that. And we need to write down reflections, at least one of them. I'll discuss reflections in a bit. We all have an educational supervisor. Each one of us has an educational supervisor who makes sure that we have a personal development plan. We know what we need to do. We meet them at the start of the year so that we know what we need to do. In the middle of the year so that they track our progress, and then at the end of the year to make sure that our file, our e-portfolio is ready before we undergo the assessment. So this is actually from my own portfolio. This is an entry that I made for an IPX. So this is just I did a session in AAU where I reported CTs, and I'm expected to just make comments and assess myself and send this to a consultant, and the consultant will actually agree with me or say that, Khawla's done a terrible job, she needs to do more studying, or she's safe. And then they rate my performance. So this is what I wrote. There's no structure to do it. You can do it whichever way you do. This is the structure that I use. I say what I've done. So I reported CTs in AU. The cases were varied. What types of scans I've reported. The positives, how I think I've done. Negatives, and then I finish by highlighting points for improvement. So it's usually the same thing. I need to increase the number. of reports that I need to do. I need to read more, I need to use it. So this is my structure, and these are the comments from my consultant. So suggested area for development, we agree on an action plan, and then they decide on the level, my level, which is the most important bit. So level 1 means I'm entrusted to observe only. Level 2 is trusted to act with direct supervision. Level 3 is with indirect supervision, and level 4 means I can act and supervise. This is important because this is how consultants and the department as a whole knows that I'm progressing, and when it's safe for me to do job by myself. If I'm still in level 2, level 3, that means I can't authorize things. And consultants need to review my work and verify it before clinicians can see my report. I've mentioned that we need to do at least an audit or a quality improvement project to pass our ARCP, our yearly assessment. You guys do audits and quality improvement projects in Ghana? Are they part of the requirement? Okay, perfect. Then I'll just glance through it. So it's just a tool of clinical governance that helps us evaluate our current practices. We basically choose a standard to compare our current practices to and see how we're doing. If we're not doing good enough, that means we need to improve, and we need to identify what the problem is and make improvements. So an example, a very easy one to do in the UK is CT heads, see whether the CT heads that we're performing are actually indicated. So the standard that we use in the UK are NICE guidelines. Secondly, we'll do a retrospective assessment of all the CT heads that we've performed. Were they actually indicated? Were they not indicated? We do statistical analysis, and if we're below the standard is usually 90 to 100% for most things. That means we need to make changes. One of the changes that you can do is teach clinicians about the indications for a CT head, or you can choose to design a proforma and give it out to clinicians to make sure that they know what the indications are before they can request it, and then we typically reassess after a few months to show that we have improved. Reflections are basically text entries that we upload onto Kaizen, where we not only write down a narrative of an event that we've encountered, but we also show that we have insight into how we're doing, and that we're showing evidence of basically critical thinking, that we can assess ourselves, and that we can demonstrate that we're open and honest about how we're performing, and that we can identify our learning needs, and we can take action to improve. So an example could be a clinical encounter that you've had with a patient during ultrasound, or a teaching event that you've attended, or teaching that you've delivered. It could be anything. So you can just say, I don't know. So for example, for today I can say, I delivered a teaching session in Ghana. This is how I think I've done well. This is what I think I didn't do greatly. This is how I think I can improve. This is what I'll do next time. We're expected to do at least one of these a year. Assessments and examinations. Unfortunately, it's not just FRCR, there's more. So FRCR exams, as I've mentioned, we have all those Kaizen entries and the yearly evaluation. In addition to that, we have deanery and local exams. I've recently done the ultrasound reporting exam. There's an A&E plain film reporting exam, abdominal pediatric spinal film reporting exams, and then there's an on-call CT reporting exam before we start doing on-calls. This is essentially to show that we are safe enough to authorize these examinations by ourselves. If we fail these, we can authorize, and we need to send to consultants for them to verify. So this is actually a picture of our registrar's room. These are two of my colleagues just doing some work during the day. We have a very tiny office, 2 meters big. We're crammed, there's 6 of us now, crammed in a tiny room trying to report. Yeah. We don't have space to put our bags. We put our bags on the floor, and we're always crammed. Anyway, enough complaining. So what our day looks like. So we report and get our reports checked, and that essentially means we're chasing consultants. So if I run into Dr. Bagat in the corridor, I'm like, Dr. Bagat, I've sent you 2 CTs, can you please look at them? So we do a lot of chasing. We perform ultrasound and fluoroscopy exams. We attend local and deanery arranged teaching. we used to have to go in person, or people used to have to go in person and travel 100 kilometers to go and attend training. Sometimes from London to Cambridge, depending on which deanery you're in. But nowadays, luckily, we don't have to travel. We just log in from our room. We use Zoom and Microsoft Teams. Even for local teaching. You know, the consultant could be in another room, but we're doing it using Zoom because we're radiologists and we're introverts. Self-directed learning, we spend a lot of time learning for our exams. Vetting, I'm not sure if you refer to it using the same terminology. Vetting essentially means that we're looking at requests from clinicians and deciding whether it's indicated or it's not indicated yet. Weighing, obviously, safety and the clinical question and looking at the individual patient and whether that's the best examination to answer that clinical question. Consulting, basically answering the phone in AAU. We spend a lot of time doing audits, attending meetings, and making entries on our portfolio. So a lot of admin work. I don't know if I can zoom in here, but this is a sample of a timetable that I've taken from my GI blog. I can zoom in. So we attend meetings. There's a whole day where I attend meetings, upper GI, lower GI, MDT meetings, and basically just observe how it's done to see how the consultant radiologist conducts it and learn from that. Because starting from ST3, I'm expected to start reading those Tuesday. So I think I did a bit of plain film reporting. We have targets to hit. I haven't mentioned that. We need to report at least 1,500 plain films in ST1, 2,000 ST2, 3,000 ST3 onward, so it goes up. We have numbers to hit to pass our ARCP. We attend teachings Tuesday afternoon. I do a bit of AAU, so that's on-call work. Ultrasound, fluoroscopy, more plain film reporting. So as you can see, it's a mixture of reporting alone in a room and doing on-call in AAU with consultants and sonographers, a bit of fluoroscopy, a bit of ultrasound. So it's varied. We learn about all modalities, plain film, ultrasound, CT, MR, fluoroscopy, and nuclear medicine during our training. So what we can authorize, just radiographs, usually starting from ST4, ST5, and it's competency-based. What I mean by competency-based is if consultants think I can act without supervision through Kaizen, if they rate me as level 4, that means I can start vetting them. It's usually around ST4, ST5. Other plain films, it's after we pass our exams. CT, again, it's competency-based, usually around ST4, ST5. Even if you're sure, you still want the consultant to have a look and make sure that I haven't missed anything. MR, again, competency-based. Otherwise, we ask our consultants to kindly look at our reports and make sure we haven't made any mistakes. So duties, it's essentially a 9-to-5 job. We don't do any on-calls in ST1, as I've mentioned. Starting from ST2, we start doing weekend on-calls. I've mentioned consultants don't work overnight. Most NHS hospitals do insourcing or outsourcing. That means they ask external companies or they ask internal consultants to do work outside of contracted working hours to report, and they pay them. It's a true apprenticeship in the sense that there's a high proportion of consultants to trainees. Basically, on average, there are 7 consultants for 3 trainees, so we learn a lot from consultants. We spend a lot of time on them. In medical specialties, we don't have that. You barely see your consultant, they show up and then you work in the NHS. They leave and you can't get hold of them. Whereas in radiology, there's always a consultant around. They're very nice and friendly. And I'm not saying that because Dr. Baga can hear. And finally, we get continual feedback because we ask consultants to give us feedback, but we need to choose them. Yeah, we do a lot of choosing. MDTs, I think, you guys are familiar with MDTs. It's essentially meetings that involve all healthcare professionals, surgeons, clinicians, vascular sonographers, basically everyone who's concerned. Every patient with a new diagnosis of cancer has to be discussed in an MDT in the UK. In non-oncology MDTs, it's complex cases where clinicians are not quite sure and they need advice. And the radiologists are at the center of the MDT. We review scans, we present relevant findings pertinent to the clinical decision making, and we provide them with recommendations. So what radiology training is really like, it's general, decision making heavy, because we're expected to make decisions on the spot in AAU, in IR, as you've seen. Dr. Bagas showed us an example of some work that Dr. Zbi, one of our national radiologists, does. He basically is just looking at a screen and deciding what to do on the spot. The patient is deteriorating, and he needs to decide what vessel to block using the portal. So we need to make decisions on the fly. It's very busy. But I think the most dissatisfying thing is the difficulty to get continuity of care. And you don't know whether your diagnosis was right or wasn't right. The onus is on you to contact clinicians and get feedback from surgeons and ask them, is this really what you found? Was I right in identifying this? It takes a lot of work and academically challenging. Okay, so in terms of resources, I'm sure you guys have heard of Radiopedia, and you know you can get the free access. Perfect. Radiology assistant, doesn't it? Do you guys use it? Yeah, it's amazing. RSNA?
Yes.
Perfect. Amazing. Do you guys use the top 10 reading list? Top 10 reading list is really good when you're doing your blocks, because you select individual subspecialties and you know which articles to read when you're in ST1, which articles to read when you're in ST2. So basically it tells you what you can read depending on your level. Dr. Khan, has anyone heard of Dr. Khan? Amazing. Okay. That's it. Thank you very much.
So the first one is on FRCP. Is it possible that I register with the GMC and begin to take the FRCP whilst it's the FRCP? CR, sorry, the FRCR.
Yeah, you can definitely take it. So you can take it from here. There are different locations where you can sit the exam. I think Egypt and Africa, you sit it in Dubai. I don't think there's any requirement. Maybe just the radiology training, right?
Yes.
To take up first year part 1 as an international medical graduate. I think you can. I have friends who can.
One of us has done it, so
Yeah.
we'll talk to you.
Then the second one is the degree or the on-call exams. Is it organized by the hospital you are working? Who organizes that exam?
It's a locally arranged exam, which means one of our consultants actually chooses the cases, and she makes us sit the exam and then she reviews our answers. I haven't done it yet, but it's going to be locally arranged.
Okay. Then the final one is I saw your requirement, the number of X-rays you are supposed to report. It's quite a lot, and you don't see that many X-rays here. So I want to know, do you report all X-rays that are done? Because over here, the patients do the X-rays and then they take it to their doctors without, just reports. So do you report all X-rays that you take over there?
Radiographs are reported by clinicians, radiologists don't look at them. And in the UK it's different, so I understand the struggle. I think, so in the UK, all plain films are reported by the radiology department, either radiographers or radiologists. So they are accessible, but at the same time we struggle to get our numbers. So what we've been doing lately is just have 2 or 3 of us look at the same X-ray and add our names, just to hit our numbers. Otherwise it's hard. But I'm not sure what you can do here locally. Maybe speak with clinicians and get help from
The
them.
X-rays are kept on a system where you can look at it wherever you are. You can get numbers. But when they come and they X-ray them and they give the films to the patients to go away, when they have access is different. Any more questions, please?
So before I ask my question, HOD is here, so concerning plain film reporting, maybe we could look at, coming up with some policy where, just to increase the number of X-rays that we do. So maybe the X-rays that are done, an extra, so that everyone comes to us, because our numbers are being pushed down, so that we have work to do. Then my question is.
Can I answer that before you continue? I have good news for you. The good news is that now polyclinic, all their X-rays will come to us through limbs.
Oh, through them.
Yes. So we are no longer sending it to the periphery. So all, the polyclinic, they see a lot of, and they request a lot of it. So they are coming through the limbs. And please promise me that you will look at them and you will report them. Thank you.
That's fantastic. Very soon you complain there are too many films.
My question is on post graduate training. How easy is it to get a subspecialty program in the UK, having trained locally in Ghana?
Having trained in Ghana. So what I know is he's done more than 18 months of radiology training elsewhere. We're not eligible to be radial. So yeah, if you're a ST2 here onwards, you have to come as a consultant and take exams. Once you've started FRCO, then you might be able to work as a consultant. So you'll go straight into working as a consultant. You won't be able to do subspecialty training because you're not a local trainer.
The president of the Ghana College, watch out, they're looking for whoever needs to go.
I know. I decided to discuss this for you to learn.
I haven't completed my studies.
I don't want to cause a brain drain, but in all fairness, I've done 1 year of radiology internship in Algeria before going to the UK. I'm not sure how things are in Ghana, but I think next time maybe if I come back, I'll discuss what radiology training is like in Algeria. It's another African country and show an example of what it's like locally. The grass isn't always greener elsewhere, is my honest opinion, even though I've got 2 of my colleagues here. There are pros and cons in doing training wherever you go. In Algeria, for example, we did tons and tons and tons of ultrasound.
Which states were you in?
What didn't I say? Sorry.
The state hospital in Nigeria.
At their state hospital.
Algeria.
Algeria. North Africa. North Africa, Morocco, Tunisia, Algeria. So there are pros and cons in doing training wherever you go. In North Africa, for example, there is high reliance on ultrasound because we don't have as much capacity to do CTs. So our training in ultrasound was really good. We didn't get plain film exposure because clinicians reported that. So wherever you go, there are pros and cons. Appendicitis, I've barely seen 2 in the NHS in almost 1.5 years. I've seen 1,000 in Algeria. I've been de-skilled. I could find the appendix very easily in Algeria. In the UK, not really, because we don't ultrasound them. They have CT straight away. So there are pros and cons to training wherever you go and to working wherever you go. Just need to make the best out of it and learn from other countries' experiences.
I think one of the things that Ash would have discussed is some form of attachment. We will discuss that behind closed doors later.
Just answering your question, like how easy is it to do a post-graduation or a fellowship? I think it's going to be very hard because these posts are oversubscribed by the internal graduates. So coming from outside to get a fellowship in UK is harder. But it's easier in Canada and lots of other countries. So, but then once you do a fellowship, it's easier to actually get a consultant post. So it's harder to get a fellowship post because we are so short of consultants. You could actually apply for a consultant post and get a post. And then once you are there, it's potentially possible that you could sub-train into something else you wanted as you progressed in your career. So there's always a potential, I think, in any country, even after having graduated or having done your radiology, you can pick up skills as you go along.
Looking at this, but I was looking at the disappointment of view. I need my people here. Question I want to ask is when passing training and the consultants request any imaging modality, at what point are you able to consult with the person? Because the tendency is that the senior person requesting this, is this the appropriate thing? So how do you go about that?
If a clinician requests an imaging modality and we disagree with them,
Yes.
if we can, okay, yeah. I think through communication. I think if they call us, I think it's what consulting refers to. If we manage to convince them that it's not indicated that another imaging modality that's easier and can answer the question is safer, I think if we manage to convince them, yeah. But it's our obligation to justify requests if it doesn't make sense. So for example, if the question is cholecystitis and we think an ultrasound will be able to provide an answer, then it's our responsibilities to refuse, reject, and actually tell them that ultrasound is indicated. So it's our responsibility, and the referrer is just making a request, and it's up to us to say yes or say no. We're the bosses.
Yeah, I think we should understand that the request is for radiological opinion. And they can come back to you to discuss. But it's important that you can also go to them to look at the case, and they can advise. So it's a two-way traffic. Not that they just write and sit somewhere. You should be able to discuss if necessary. It helps a lot.
Obviously, hence the word consulting. They're going to consult us and ask us what the best modality is. And it's not through communication.
Paul, can I add to that?
Yes.
So, John, just to answer your question, there is a pretty good two-way traffic in terms of the communication between the referring consultants and the radiology, either trainees or consultant radiologists. And in the UK, we always say there are radiology requests. A lot of times clinicians will come and say, I've ordered this. The moment they say, I've ordered this, we say, no, it's not an order, it's a request. And if it's a request, then there is obviously our prerogative to refuse the request or to alter the request. Yeah. So we get really annoyed if somebody says and says, I've ordered this. But we are also working for the patient. So essentially, if there's something, but there are some consultants, having said that, old timers who say, oh, I want this and that's it, how can you refuse? And then they come and kind of fight, and it can sometimes get a bit nasty. So I can relate one of my historical episodes which I had with one of our vascular surgeons. It was Mr. Iwad, you might remember. So he's a hot-headed vascular surgeon. And he requested a gastrographin enema for a patient who had some colonic problem. And the request came to me, and I said, oh, why gastrographin? It's a long way off. The gastrographin won't reach the hepatic flexure. We'll be better off doing a CT. So I changed it to a CT, and I did the CT. And the patient actually had a colonic lymphoma, and he had a fistula, which we much better demonstrated on the CT. So he came down firing that, who's changed my request? Who can do that? So I said, I have changed the request. So he said, it was my request, you can't change it. I said, no, that's my prerogative. if you put a request, I can change it. And you can't override it. You can't tell my radiographer what to do. He's not going to do whatever you say. So sometimes you have to kind of put your foot down and say that I think this is best for the patient.
Yeah.
Thank you. I'm going to take us back just a little.
Mention your name so that we know it.
Dr. Mawena Donko, so a senior resident. So to president, bosses here, you know, a lot of your doctors do actually want to stay in the country. I mean, outside does not appeal to me personally. But here is the case. I find that in Canada and some countries, there are more privileged residents from other countries. Like, they consider applications from those countries more than any other country. So if there are, let's say, 5 slots for fellowship, okay, they will tell you that they will consider candidates from those other countries first. So you'd be lucky to get a slot there. So you can see that their colleges or their countries have made a way for them to go and subspecialize and do their fellowship. And then once you go through that route, you come back Like there is that surety that the person comes back, and they come back for you because they've subspecialized. So is there anything like that that the college can arrange with, especially the subspecialty is not done in Ghana, so that once we go through that route, we are considered also for those slots, and then definitely because we went through that route, we come back. Is there anything like that? Because we need a lot of subspecialties. I am very interested in thoracic imaging, but I mean, it's difficult when you see the countries that are given priorities over you. Yeah.
Yeah, and also if the country is worried that people will go and not come back. I think the attitude is changing. I've been in this for the past 70 years. It took quite a while before the Ghana College came into it. They have their reasons why they're not. But, you know, Ghana is progressive, although very slowly. They came in together.
The college is trying to encourage.
Yeah, I think this will happen. You have vascular trainees going to specialize, and I think if you make a lot of noise, the college will, you know, get people for training. There was a time we had 50 training slots for Ghana. Only 4 we could send because there was a lot of resistance across. Even though the president at the time agreed, the various people, the Ministry of Health, they resisted. So sometimes we are not looking to the future. In fact, if people go, eventually they come. I was away for probably 25, 35 years. I'm back. I've been coming back for the past 70 years to deliver. So, you know, it's a give and take. Some worry that people come back and they do private work. I feel that once you come back to Ghana and you are treating Ghanaians, together with those who are there, it's still a service to the country. So attitudes need to change at the top. And those of you who are going should make sure that when you go, you come back. I've got 2 guys who have been away for 5 years. When you go through the training, become marketable. And there are consultant jobs ready for them. And you're debating whether to come back or not. So if you don't come back, how do you expect me to send anybody else? Now, 8 people are in the queue, waiting for these 2 guys to come back before I make a move. So you may say you'll come back, but when you get there, yeah.
There's another program that I can signpost you to. It's called Global Radiology Fellowship. I think it's for international radiologists. I'm not sure if trainees can apply, but you can come and work in the NHS. Again, I'm not sure if you can choose a subspecialty to work in, but you basically get work experience in the NHS and then you can come back to Ghana. So that's something to have. It's called Global Radiology Fellowship.
Hello, my name is Stella. I'm from 37. I'm first year resident. So I feel like with the leaving the country, for us here, it's not just about leaving the country per se, but if you want to be satisfied, it's not just financially, it's also seeing the things you practice. So if we're going to be staying here and you don't get to see so many things that maybe if you were in a better privileged place you get to do, it kind of makes you feel a bit redundant. So if I want to be a vascular surgeon, I'm not going to get the opportunities here to really even have the career satisfaction, and then I'm just there. But I know maybe there's a place where if I go, I'll get everything I want, I have more facilities, everything. So I don't always feel like it's just based on leaving the country, but if you leave the country and you come back, what are you going to have to do all the things you've learned? Are you going to be able to apply them, or it's just going to dissipate with time? So I feel like for us, the younger people, even choosing your specialties, knowing that you're not going to have that opportunity to practice what you're actually, then it's not really fulfilling. So I feel like that's part of the thing for us as well.
Good point. We are supposed to learn from our past, but we never learn. If you look at how Kolebu managed to get their trainees to UK, and they all came back as heads of departments, if the college is behind your training, most times they will come back. But if people are allowed to struggle to go, you don't feel like coming back. I've said this many times, but it's not easy. They don't want to be seen to be encouraging you to go out. That's the thing about the talk. But I think if people are supported to go, they will come back. I went on my own. I wasn't supported. I came back. Okay. 70 years, coming back 4 times a year to Ghana. So, be the trick. Any more? We are very popular.
Thank you for all the concerns you raised. Concerning the college, there are plans to encourage those who want to do subspecialty. And at least I'm faculty secretary for radiology, so I can speak for radiology. If you get your slots, the college can help you. We can encourage you, to do the subspecialty and come back. Okay? So after membership, the fellowship, you can. Yeah.
We have to try and get the slots.
Look for the slots.
Okay.
And meet the necessary requirements. You won't, if you promise you come back. Yes. To the college, you will send you. Okay? Partially with little this, but all these reference letters and all that, nobody will sit on it. All right, you go and come. Okay?
I think I just want to add, based on what my HOD said, sometimes getting the slot is difficult if you are just applying as an individual. I know that sometimes for tertiary hospitals, teaching hospitals, they have this collaboration with other departments in other hospitals outside. So sometimes it's easier if, let's say, college has a relationship with maybe this university this way, and they say we have, let's say, 3 fellows we want to bring over for training and come back. It opens the door for you and it's easier for you because most of the time it's very competitive. So if they know that, okay, we have this thing with Ghana and radiology department, it's easier. So I would like to plead, if it's possible for college not to just leave us to struggle to get a slot because we are against so many people, but rather maybe give us an open door and then we go through that door and then it's easier for us to get the slot and then come back.
Loud and clear, isn't it?
Yeah. I think I've stirred a lot of trouble. We have a long and exciting program ahead of us. My colleague, okay. Yeah, I'm happy for us to discuss more during lunch break maybe. There's a long program ahead of us. A lot of exciting things to teach. My colleague.
Yeah, hello, thank you. Yeah, so I'm Cyril, first year resident. A quick question. What's the role of artificial intelligence and its limitation?
Leave that to Dr. Bhagat. The role of AI in radiology and its limitations. Or actually, can we discuss that during lunchtime? Would that be okay? Because there is a long program and there's a lot of exciting things, guys. And then during lunchtime, we can discuss more. Is that okay?
Yeah.
Thank you. I'll pass the mic to my colleague.
I'm going to show you a few examples. So personally, I qualified in 98. I was promoted to superintendent in 2009. I started doing percutaneous drainage just myself in 2015. I've done around 600 CT guided drainages in that time. I also teach our registrars to perform these procedures. So 4 years ago now, we went over to the Ridge Hospital and actually demonstrated some CT guided drainages. And we did a procedure and I've been in contact with one of the radiographers there since. So we have done this before. As an example of how I can teach using a phantom, in this case a lump of meat, but actually watermelon works quite well. So if you guys still intend to practice these procedures, it's worth having a chat to your radiographers, getting a phantom. As I say, watermelon works as well as anything else, and practice sticking some needles and things. And that was a procedure that we did. So CT guided drainage allows us to treat a collection. The major advantages over ultrasound when it comes to larger patients or where we need to gain access to deeper or more posterior parts of the body. A drainage is conducted after an enhanced CT scan, which gives us good visualisation of bowel blood vessels. So we know we're safe. Where we're putting our needle is the area that we hope we're putting our needle into. So the benefits of CT-guided drainage: it removes the collection, trips sepsis. It allows us to take a sample of that fluid, send it to the lab, work out which bugs are in the collection, and then which antibiotics can kill that bug the best. So, two-pronged attack. Firstly, get rid of the collection itself. Secondly, mop up what's left with antibiotics. It's less invasive than surgery. There's generally no need for a general anaesthetic, although we can consider that if necessary. And what are the risks of doing percutaneous drainage? Well, when I consent a patient, I go through these various categories. Essentially, there's a risk of introducing an infection, as whenever you put a needle into the body, there's a chance of introducing that infection, or moving the infection around the body, and in particular, the patient ending up with bacteremia. So we are very, very careful when we do put our needles in. If we're going for a structure, what else is in the way, essentially. Bleeding. So we make sure that our patient's clotting factors are appropriate before we actually conduct the procedure. We check that the patient isn't anticoagulated in any way. I don't know, are many of your patients treated for AF with anticoagulants locally? Yeah. So yeah, a lot of the patients in the UK, certainly the elderly population, are on NOACs, which, if you were to put a drain into a patient that is anticoagulated like this, they wouldn't last very long. So ensuring that the patient's been off their anticoagulant for an appropriate amount of time. I've got a list of the various anticoagulants and how long they bleed there. Testing the patient's INR to ensure that they're not going to bleed if you put a needle into them, especially if you're putting needles in or through the liver. We're also concerned about damage to surrounding structures. Quite often we're going very close to loops of bowel or through the liver, or very, very close to other structures. So it's important when we do these procedures that we know exactly what we're looking at, and we take many images and move the needle slightly. There's also a possibility of perforating the bowel, and you need to make sure that you've got the appropriate surgeons around should you do that. So if you are undertaking one of these procedures, you need to make sure that appropriate people are aware that you're doing that, and there's actually somewhere for you to send the patient should there be an issue. I mean, touch wood, out of 600 procedures, I've not had any major complications, but it's a real possibility. There is a possibility of killing your patient, so I consent each patient when I do these procedures for that. I think that's quite important that they realise, yes, okay, there are great benefits to this procedure, but actually you can do them harm as well. So before the procedure, myself as the radiographer that's doing the procedure will have a discussion with a radiologist. Quite often it's Ash, and he'll agree that what I'm doing is appropriate and safe. And there are times when I'll get Ash to give me a hand, certainly if we're doing anything extremely difficult. In the early days when I was doing these procedures, if it was a sort of mildly complicated procedure, then Ash or one of our other interventional radiologists would be present. When we do these procedures, it's important that we give appropriate pain relief. Now, local anaesthetic, lidocaine, is a really good friend when you're doing these procedures. It reduces the amount of pain that the patient has significantly. And the vast majority of the time, I don't need to give the patient anything else, even if it's a cholecystostomy where you're putting a drain through the liver into the gallbladder. If I need to, I can always give Entonox, which is 50% nitrous, 50% oxygen. And it's an incredibly good painkiller. It's equivalent of about 20 milligrams of morphine. And the benefit of Entonox is it has an incredibly quick onset. So after breathing it for 2 minutes, the patient should be pretty much pain-free. And it has a very quick offset time. So your patient is lying there, they're in agony, you give them the Entonox, 2 minutes later they're standing there looking at you with a big smile on their face, which is absolutely wonderful. And then you might be concerned, okay, you're finishing the procedure, you really don't want to be spending an hour waking this patient up. It's quite often the case with general anaesthetic, or if you give the patient midazolam or a heavy-duty painkiller. So with Ventanox, within 2 minutes, the patient is pretty much awake, and within 10 minutes, they're supposed to be able to drive. So, very, very useful drug when it comes to this. I don't know if you guys got availability of Ventanox. It's something that's worth looking into, because I mean, in the UK we use it in pregnancy when women are giving birth all the time. It's handed over to the woman, and they can control the amount of Ventanox that they have. When they have too much, they fall asleep, and then they wake up again. So it's not a big issue. So things that I consider when I'm doing a procedure: is it safe? Is the patient anticoagulated? What are the clotting factors? Are there any other options? Should we just be treating this patient conservatively, or do they really need to go to the surgeons and be operated? Okay. So I look at the previous images, I make a decision as to which technique I'm going to use. I try to consent the patient outside of the room. So the patient should be made aware of the procedure that you're doing in an environment where they can refuse. I don't know, do you do similar things when you consent the patients here, Paul?
Yeah, we do consent them. Sometimes it starts as verbal information, and we document it in the notes.
Yeah, so I mean, in the UK, we're sort of bound to do written consent for everyone, so that they are aware of the dangers of the procedure and the benefits. We then scan the area of interest. I put surface markers on the skin. Now, silicone surface markers are very easy to use. If you don't have them available, you can use a needle or blue tack or anything made with silicone in it. And if you want to talk about this later, I can give you a few examples. Mark the entry site, I clean the area, cover the patient with a sterile drape, give my pain relief, and then the radiographic technique. So I'll chat to the radiographer in the room. I think there's only one of you. Yeah. About the actual procedure and how we do it. So it's possible to do these procedures with the radiographer or the radiologist in the room using what's referred to as a smart step technique. And essentially, we put our foot on the pedal and we get a slice through the body that's available for us immediately. We can then move our needle, do another slice, look at the image, move our needle, another slice. And most of the time I only do 4 or 5 slices, so the radiation dose that I receive and the patient receives is very low. The other way of doing things is to everyone come into the control room, do an image, go back into the examination room, move the needle, back into the control room. Now, there are some benefits of doing that. A, you're not getting any radiation dose yourself, and B, you can look at the image in different planes. So, personally, I always use the smart step technique, so I'm in the room. I do my own radiography as well as the procedure, so I have even less people in the room, so getting away. So I'm going to talk about the difference between a single stab technique and a modified Saldinger. So a single stab technique, essentially the drain has a straightener going through the centre of it and a stellette which is sharp. And the idea is, if you're doing a drainage to a more superficial structure, or if you're doing it under direct guidance with ultrasound, you can put the drain straight into the patient. It's quicker, and on the whole, it's less fuss. It's also quite a lot cheaper because the various items that we use, the introducer needles, the wires, the dilators, are all reasonably expensive. However, the Saldinger technique is probably my preferred option. In fact, most of the procedures that I do are Saldinger. So the Saldinger technique, we use an introducer needle to start off with. We put the needle into the collection. We tend to take the centre portion out, leaving just a plastic tube. Insert a guide wire down through the centre into the collection itself. And I would do an image at the start to work out where I'm going, an image with my introducer needle in place, an image with the guide wire in place. You then use dilators to make the hole big enough that the drain will go down over the top in the least traumatic way possible. So benefits of the Seldinger technique, as I say, small incision. So literally it's just the width of the needle that you're putting in. Occasionally, if I'm putting in a really big drain, I will make a little cut just to allow the drain to go in smoothly. So in the UK, we have a major issue with the availability of radiologists to do these procedures, and in particular in our department, which is why I was trained by Ash to take over a lot of these procedures. And there's actually a national report that was written, and it quotes me as a sort of an additional skill that can be used by radiographers to allow us to care for these patients better. We have issues with our registrars getting the training time, and I mean, as I say, I do train our registrars, and I'm being looked at as if maybe I'm benefiting our radiographers that do these procedures over our registrars, and perhaps that does happen occasionally, but there we are. So within COVID, things changed quite a bit. Any percutaneous procedure was treated as an as an aerosol generating procedure. So effectively, we had to wear a full set of PPE. Now, I don't know if any of you guys stood around in full PPE for 2 hours per patient. Unfortunately, I had to. It's not an easy situation when you're doing these, and you know, much of the surgery that was happening pre-COVID pretty much stopped. And I'm pretty sure it's because the surgeons didn't want to be standing there in full PPE. So during the first and second waves of COVID, it was incredibly bad in our area just outside London. You know, I was scanning 30, 40 patients with COVID each day, and just the time it takes to actually conduct those examinations, you know, put our activity down significantly. Under normal circumstances, I can do 100 patients in a day without too much of an issue. That's using just our one emergency scanner. But in COVID, as I say, 30 or 40, there was a bit of a struggle. So many of the CT-guided drains that we were doing were, or are normally used to treat post-operative collections. So because the operations weren't happening, the numbers of procedures that I was doing dropped significantly during the first wave. Then we got quite a lot of patients that ended up getting quite sick because they didn't have their operations. And you have patients that were often profoundly septic that really should have been dealt with, you know, a few weeks or a few months before. But those patients didn't want to come into hospital because in the news, patients were dying in the corridors of COVID. And I mean, we're just outside London, and you know, some of the central London teaching hospitals got completely overwhelmed. We came very, very close. It couldn't have got any worse because we just had nowhere to put the patients. So, drainages in some respects took over for some of those patients that required surgery. And by the time we get to the second wave of COVID in the UK, I was doing more procedures again. In place of a surgical option, these were quite often more difficult procedures. I'm just going to take you through a few of the images of a few case studies, and you know, see what you guys reckon. Maybe you can point out what's going on. So, what's an abscess?
Abscess.
Yeah, it's an abscess just in the psoas here.
Yeah.
Okay, so how are we going to get to it? You can see I've actually put some markers on the skin. So essentially, I'll put in my local anaesthetic needle. I'm going to use this route. It's nice and straightforward, very, very easy procedure, ideal for teaching our registrars actually. And this was actually one of our other radiographers that conducted this procedure recently. I'm going to just tell you a little bit about the patient first. So 22-year-old patient, left-sided back pain, psoas collection was seen on MR, and this patient was previously treated for TB. So we think this is a TB abscess. Do you guys see many TB abscesses? Yeah. You do. And how do you treat them? antibiotics or?
Yeah. Some of them are that bad that it requires surgical breathing, but not many.
And surgeons sometimes
open. That's what I mean. But not many are quite open, isn't it?
So yeah, really simple way of sorting these out are to get rid of that collection. And the best way of doing that is to put a percutaneous drain in, and this can be done in 20 minutes without too much issue. So you can see my local anaesthetic goes in. I then put my introducer needle down through the muscle onto the abscess itself. I then insert the guide wire and the drain down over the top. So you can see I've only done 4 images. This has taken me 20 minutes, and I've got a wire into that patient's psoas collection. I've aspirated 75 mils, and the patient was continued with their tuberculosis treatment. And actually, for some reason, we've jumped ahead an image. So this is the drain sitting in place, and you can see that the majority of the collection has disappeared. So the next case is a patient that had an endovascular stent done 2 years before. They were in a lot of abdominal pain, they were confused and septic, and the original CT showed a collection, again in the psoas, but right adjacent to the graft. So I put a marker on the skin. My local anaesthetic goes in. My needle goes straight into the psoas, followed by a guide wire. Now you can see how close to the aneurysm sac I am there. So you know you've taken a careful measurement, so you know exactly how far you're putting your introducer needle in, and there's no possibility that you know you're going to end up in the aorta, which you know it's quite a bad thing. But actually, once you've got your introducer needle in place, you take the centre out, which is all sharp. So you're just left with plastic tubes and guide wires. It's very difficult to do any damage with plastic tubes and guide wires. So you can see my guide wire goes in, it's sitting quite happily in the psoas. The drain goes down over the top. It's a little bit close to the aorta, but it's contained. So that was a 10 French skater drain. I aspirated 70 mils of frank pus. The patient's antibiotics were changed on the basis of this procedure, and within 2 weeks the collection had completely resolved. And in actual fact, that's a CT that we did on the patient 2 weeks later. You can see that the drain is still in place and the psoas is back to its original size. So that was a reasonably hairy one that I did. As I say, it's never nice to be pointing your needle towards the aorta, but as long as you've taken things easy and you make those measurements, it's a very safe procedure. So this is our third case, a 43-year-old male, 7 days post-op, chose, well, you tell me, a pelvic collection. Let's have a look. So this is the pelvic collection, and it's reasonably deep. So there's a few things there, this is the collection itself, a few things there that I need to avoid. I've got some bowel, I've got some blood vessels. So I need to work out a trajectory where I'm going to avoid all of those and get into the collection. So my local anaesthetic goes in, my introducer needle is just inched forward. You notice the patients do move a little bit, and that's actually one of the dangers when you're doing these procedures, is, you know, when you do the initial scan, you think you know where everything is. The patients breathe and they move and they do all sorts of awkward things, so it's important just to keep re-imaging. So you can see my introducer needle is right up to the edge of the collection. And the drain is inserted down over the top. I'm reasonably close to Bell there. I'm well away from the vessels, but that was another successful procedure. So I've gone for a slightly smaller drain here because it was a reasonably hairy procedure. So just an 8 French skater drain inserted into the collection using that modified cell digging technique. I was able to aspirate the collection completely. 35 mils of the collection were aspirated and sent for microscopy. And you can see this is our drain sitting in what's left of the collection, and that was then removed a few days later.
So what caused the collection?
So this was a post-operative patient that had a bowel section. I seem to remember, let me just look at the images again. I think this patient had had a colectomy, and it was an anastomotic leak which has caused this collection.
I think just a point on that technique, the closer you stay to the sacrum and coccyx, the better. So you should just skim next to the because the arteries and the sciatic nerve is also there. So where is the sciatic nerve also there. So you don't want to hit the sciatic nerve. So just the approach is just skim next to the sacrum.
I was trying to avoid
and then if the rectum is there, avoid the rectum. Sometimes if the rectum is really full, then you can even give them enema to evacuate the rectum so you get a bit more space. Sometimes if the rectum's in the way, when you reach close to the rectum, then inject a bit of saline, so it pushes the rectum away, so it just creates a window and then you go through.
I'll show you a couple of cases of hydrodissection later. So this is an 88-year-old lady who was admitted with acute cholecystitis, 3-day history of abdominal pain, a CRP was raised, and despite the antibiotics, she wasn't getting any better. Now this lady wasn't a surgical candidate because of her age and the other comorbidities that she had. So we're left with the option of filling her up with antibiotics and hoping for the best, or we can go in and do a cholecystostomy to try to relieve her symptoms. This is the, where are we? Yeah, so this is the big distended gallbladder, and then we've got a little bit of fluid outside here and here. So whether or not this is actually a perforation, I think Ash will be able to tell you better than me. I think we decided it was an impending perforation, and that's why we went ahead and did the procedure. What do you think, Ash?
So nowadays a lot of our surgeons are getting very keen on. They go in, it's a mess, the gallbladder kind of rips, the stones fall out. So they obviously, first of all, they hope that the antibiotics sort it, and then once the attack is over, then they go in and do interval cholecystectomy. But if the patient is quite unwell, ideally either they have to go in or then we have to put in a drain. So these days we are ending up, and I think Nick is doing quite a few of them, where put the drain in, send them off home, they come back in 5 to 6 weeks, get the drain out, then get their cholecystectomy. So it kind of, it doesn't, putting a drain in will not prevent the patient from not having a cholecystectomy, but it just stabilizes the patient and makes the job easier for the surgeon 5 or 6 weeks down the line. Sometimes we kind of weigh and say, oh, is he a better surgical candidate? Or and if there's a perforation, sometimes it's better for the surgeons to just clean up everything. Whether they're loculated, there are lots of pockets, then one single drain won't do the job. This one looks like the fundal wall is becoming quite edematous, and if you leave it, chances are it will eventually perforate there. So reducing the pressure and draining the pus out makes sense.
And so telehearts that fluid getting into the abdomen quite well. The last thing you want is for you to release a lot of pus into the abdomen, or the patient to end up with a biliary sepsis, because that will obviously make them a lot more unwell. So by going through the liver, you do reduce that risk. It's possible in some of these cases to do a direct puncture into the gallbladder, avoiding going through the liver. But in these cases, as I say, there is that increased risk of biliary sepsis. Sometimes when the gallbladder is stuck down to the wall of the abdomen, you kind of risk it. And obviously, if you're going through the liver, there is that increased risk of bleeding. So it's a matter of weighing up what's the most appropriate approach for these patients. So I've not messed about with this. I've measured it once. I put my introducer needle in. I know exactly where I need to go. Have the courage of your convictions. Don't mess around with the needle in the liver for too long, or it can lacerate the liver. So I've gone straight into the gallbladder, exchanged it for a wire, and then the drain goes down over the top. So literally 20 minutes, no messing around, 8 French drain, and I've removed 275 mils of frank pus. And no doubt, this patient would have continued to deteriorate if we hadn't done this. The patient was actually discharged a week or so later with the drain in situ. How she did from then on, I'm afraid I'm not aware. But it's like everything. It'd be lovely to follow up all these cases, but being so busy with everything else, quite often I don't get the chance.
Nick, just to add one point about the liver, which Nick alluded to, is once you put your needle through the liver, you have to be quick and fast. So you might ask them to kind of stop breathing for a second and then again, but then let go of the needle. Because as the patient breathes, the liver moves against the intercostal surface, and if you hold on to the liver, the needles will lacerate the capsule of the liver. So once the needle is in there, don't touch the needle, let it move with the breathing. So you'll see the needles going wobbling up and down. But then when you put the guide wire, again we ask them to hold the breath quickly in, so that they're not breathing when you're holding the needle. Because if you hold it, the needle becomes static, liver moves against a static needle and it can lacerate.
Great. So that's my preferred way of doing these procedures. It's definitely possible to do these procedures with a single stab technique. The issue is that you're pushing quite a large bore drain through some quite sensitive structures. The Saldinger approach, although it takes longer, and some people may argue, increases the risk of lacerating the liver. I think if it's done in the right hands, actually it's safer and you're much less likely to traumatise the gallbladder and the liver itself. Ash will probably disagree with me because he normally does his single stab.
No, I think I agree with Nick. The Saldinger technique is safer and better, but the single tap technique is faster. When you're pressed for time, then just go in quickly and come quick.
And so, yeah, the vast majority of our radiologists, when we do these procedures, they will do them single stab. We have, I think, 2 radiologists that will do Saldinger, plus myself. My registrars, I always teach, do everything with Saldinger. Because if you're doing the same procedure the same way each time, you get that muscle memory. And it's not, if you've done 600 procedures the same way, it's very easy to do the 601st. If you've done lots of different techniques and they're all slightly different, you don't have that muscle memory for putting the drains in and knowing how things feel. I'm sure orthopedics have got many similar cases. So, case number 5, patients had a nephrectomy for a non-functioning kidney, and we've got a bit of a collection. So again, we've got a reasonable distance to go in. This wasn't visible under ultrasound, so CT is the way to go. Again, the patient, I believe, was quite septic. So this is our collection. My local anaesthetic goes in. My introducer needle heading in the right direction. And now my introducer needle is actually on the edge of the collection. The guide wire goes in place. And then I've deployed a 12 French skater drain, and again taken out another 75 mils of pus. So this is another case study. 65-year-old woman, back pain, diverticulitis, and a psoas abscess. We do see quite a lot of psoas abscesses, and again that's why I was interested in how you guys treat them, or if you treat them, or if they're just treated with antibiotics conservatively. So we can see on this particular case, we've got our psoas abscess. It looks a little bit loculated, but actually as you put the guide wire in, sometimes it does break down those locules. So even if it does appear to be a loculated collection, I still use the same technique. again, I don't know what Ash's view is on this.
Yeah, I think the guidewire could potentially, but with loculated collections, there's always the risk that it will drain one pocket and then it kind of stops draining. But it's still worth trying, because if it reduces to the point where the antibiotics can kick in, then it's done the job. Because the other alternative is they have to go in surgically. Pleuropericardium. Yeah, so again, pleural collections, multi-loculated, chances are a drain won't do the job.
Okay, so we can see got a pretty safe looking route here. Now, I've got a little loop of bowel which isn't a million miles away from the area. This is the collection itself. So what I'm going to try to do is give that loop of bowel a bit of a push, just to get it some distance away from where I'm putting my introducing needle. So as I'm introducing my local anaesthetic, I'm just hydrodissecting that area out of the way, just a wee bit. And you can see maybe it's moved a little bit. My needle goes in with a single stab into the collection itself. I deployed a 12 French skater drain, took out 100 mils of frank pus, and the patient was discharged 5 days later on antibiotics.
Sorry, can you go back? So you put water in first?
So what I've done is, in fact, I'll show you on another case just a couple ahead. I've got a much better demonstration of that. Okay, so similar looking collection coming up. This is a patient that presented with ischemia and was acutely septic. So we noticed when we did the CT angiogram of the distal limbs that they had this collection. So this is our collection. This is a loop of bowel, and our way through is probably quite a lot more limited than our previous case. So this is where we hydrodissect. This is our collection. This is our loop of bowel. So my local anaesthetic comes in, and then I inject a mixture of water and local anaesthetic, just to give that loop of bowel a bit of a push. So you can see the loop of bowel has moved. My local and water has created that little pocket so that I'm able to get the drain, or in this case the introducer needle, down safely onto the collection. And you can see I'm a good distance away from that loop of bowel now. That's my introducer needle in place. Guide wire. Okay, so very limited access. I've needed to hydrodissect to get that loop of bowel out of the way. I've introduced a 10 French skater drain, again using that modified cell dimmer technique, and aspirated 45 mils of frank pus. And that's the drain sitting in situ. Any questions on hydrodissection or how we do this? Right. I think I've duplicated that one. So this is a patient, here we are, 94-year-old, normally very fit and well, lucid, again acutely septic. She had deranged clotting factors. The ultrasound that she had suggested that she had gallbladder emphysema, but she wasn't a surgical candidate. So again, we've got our gallbladder with a very thickened looking wall here. And her clotting factors were off to the point that I wasn't brave enough to go through the liver itself. And in fact, a patient of this age wasn't a surgical candidate, so the only sort of last roll of the dice for this lady is to try to put a drain into the gallbladder, and probably the safest way is to do that going directly through without going through the liver. So again, very quickly, introduce a local anaesthetic, needle moving the gallbladder, guide wire, and so this patient was only given light sedation by the team. I had to do on what we call the consent form 4, so this patient wasn't able to consent for herself because of her sepsis. It made her confused. I did a direct puncture cholecystostomy, her prothrombin time was 17. I normally try, if I'm doing a procedure that goes through the liver, to keep the PT, the prothrombin time, below 15. Any higher than that, you do risk significant hemorrhage. So 7 French skater drain, that's as small as I go, but in this case was big enough. I was able to aspirate 100 mils of frank pus. The patient's condition then resolved along with the sepsis, and again the patient was actually discharged home. I don't have another image of that, it's a shame. One last case study I'll go through, and this is again a very sad story. Young lady, only in her 40s, who had metastatic cancer, large liver abscess, which you can see here. And actually, this happened at 4:30 on a Friday evening. One of the surgeons came down and said, look, we've got this lady, she's not going to survive the weekend unless you do something for her. I had a look at the clotting factors, prothrombin time was 19, which, you know, is well outside the range of what I would normally be happy to do. But with a surgeon standing in front of me saying, look, this really is the last roll of the dice, we've got no radiologists in the building that are prepared to do it. You know, you can either have a go at saving this lady's life or, you know, she'll be dead by the end of the weekend. So I decided to do the procedure with the appropriate consent, consented the patient for significant bleeding and death, and went ahead with the procedure. So you can see I've got all my markers on the skin here. My local anaesthetic. And again, I'm ready to go through the liver, so the last thing I want to do is have my needle sitting in that liver for any amount of time. So I've got my needle just the edge of the liver, and then I've gone through in a single puncture, a guide wire, and you can see the tip of the guide wire has gone down into this lower locule, and then the drain down over the top. So 2 weeks after the procedure, the patient was still alive, the liver abscess had resolved, the patient had much improved, and was able to be discharged to palliative care. She lived for another 6 months and saw both of her children's birthday. So it's one of these situations where I look back in retrospect, and yes, I did the right thing because obviously I had a good outcome. But this was quite early in the days of me doing these procedures, and perhaps the most dodgy procedure that I've done today. If I was given the same information 5 years in as I am now, I'm not sure I would have done the procedure. But who knows? That's me done.
Do you want to reserve your questions? Or if you ask one, two, only 2 questions are allowed. And safely skip back, isn't it? No way.
Thank you very much for the presentation. So I noticed that some of the images, it looked like maybe we could still have used ultrasound, but it seemed like all of them were CT. So I wanted to find out whether you simply use CT for all your drainages, or you first assess them with ultrasound, and those ones that you think ultrasound will not be good, then you do CT.
So the fact is, I'm a radiographer that's done CT for 25 years. My skill set is CT. There are patients that I do procedures on which perhaps could have had ultrasound if we had an appropriate radiologist or sonographer around that was prepared to do the procedure. So the answer is yes, you can certainly use ultrasound for some of these. Deeper structures, as I say, or if there's air in the way, loops of bell, it makes it very difficult to visualise on ultrasound. Again, I think Ash will probably have a go with ultrasound, if I'm honest.
I think you rightly pointed out some of the, especially the gallbladder ones, like I would have personally done them on the ultrasound, because again, faster, quicker in terms of the speed in which you can do the procedure. The pelvic one which he showed, you potentially can't do on the ultrasound at all. The psoas ones also would be very hard and difficult to do on the ultrasound. In terms of if you, the trouble is that now Nick does most of our drainages, and we are all so busy with so many other things. It's a matter of who's available to do it, and therefore sometimes the modality that we choose is based on the available skill set rather than what might be faster. In terms of safety, I think that for both equally good. Ultrasound just makes it quicker and faster. So I think speed is the only thing which benefits and radiation. Right?
So I mean, when I do these procedures from a radiation dose point of view, you'll notice that I only do half a dozen slices. The radiation dose is minimal, very, very, very minimal. So yeah, a lot of the time these patients arrive, the stochastic effects of the radiation aren't likely to give you any issues. But as you say, it's a balancing act. If you've got a younger patient, then it's certainly we would go for ultrasound first. But again, if it's a life-saving procedure and there isn't a radiologist available to do the procedure, it will quite often come to me.
The one difference between CT and ultrasound is on ultrasound you see the needle real time. So you can actually see your needle going through all of the tissues and ending. Whereas in CT, you measure and you push, then you check. So it's measure, push, check. So you're not actually seeing your needle in real time. But if you've measured it correctly, it's extremely unlikely you will go wrong. But ultrasound gives you the additional safety of actually seeing where you're going.
Right. Thank you very much. Next topic
So are we skipping it?
Oh, lunch will wait as long as possible. Because these guys, if you postpone lunch, you don't have to have pay money for dinner. So Ash.
We just want 5 minutes.
Questions? Okay, all right. Up everybody, in case you are sleeping.
SPECT scans. I'm going to concentrate only on MRI, but where necessary, I might just allude to the other modalities that are useful for particular pathologies. So anatomy-wise, obviously you have the osseous parts and you have the discs and ligaments, dura, epidural spaces, thecal sac, and the nerve roots. So just very quickly, that's where axial slice through the disc. So that's your annulus, that's your pulposus, that's your annulus, that's your thecal sac with the nerve roots, that's the exiting nerve root, that's your facet joint, that's your ligamentum flavum, the lamina, and then the spinous process. And then you have the para-articular musculature around. So essentially when you're describing discs, you would talk about the signal intensity, the morphology, location of the disc, and the extent of the neural completion. And there is a certain kind of nomenclature which is internationally recognized, and it's useful to kind of use that terminology so that the surgeons who are referring the cases, they understand exactly what you are saying, rather than I've seen a lot of variation between countries and locally as to how discs and disc disease are described, but it's useful to follow the kind of international nomenclature which I will talk about. So the sagittal anatomy again, on the MR you can see the vertebral bodies, you see the discs, you see the corus medullaris, the cauda equina, the thecal sac, and that's a T2 weighted image and that's a T1 weighted image. The way you recognize that would be the CSF is bright on that. The marrow contains fat, so invariably the vertebrae are brighter than the disc, and the CSF obviously is dark on the T1 weighted images. So the first important thing when you're reporting MR of the lumbar spine is to try and ascertain whether you've got the levels right. Quite often there is a transition vertebrae at the lumbosacral junction, and just on the lumbar spine MR it can be slightly hard to decide which one is what, but it doesn't matter what you call what, as long as you clarify which disc or which vertebrae you're talking about. So there are a few landmarks which you can use to try and ascertain which vertebrae represents. So like here, it's slightly hard to be sure whether this is the S1 or is this the S1. And the landmarks that you can use is if you have previous imaging, then obviously you can count from the top. That's the kind of only one sure way of knowing which vertebrae is what. But then you can use the renal artery. So the right renal artery is normally closest to the L1, L2 level. Quite often the renal artery would be visible on a parasagittal slice. and you can use the iliolumbar ligaments on the axial slice, and they normally come from the L5. So wherever the iliolumbar ligaments are, that's the L5. But sometimes you still can't make up your mind which one is what, so it doesn't matter. So you might just say that, okay, I'm considering this as S1. So in your report, you might say that the last disc that has been scanned actually has been considered as the L5 S1. So you're just saying that, okay, I'm saying this is S1 and this is L5. Actually, if you count from the top, I might be wrong, but it doesn't matter, because I've just clarified that on my report, this is L5 and this is S1. And the reason for that is because the surgeons quite often, if they're operating on a disc, on the day of the surgery, they'll put the MR and the report might not be in front of them. And then they'll get the report, and if there isn't a disclaimer on it saying that there is a translation vertebrae, watch out, this is what I'm on, he might assume that, okay, this is L5S1. He'll use this fluoroscopy and he'll go at the wrong level, yeah? Because the report says L5S1, he's assumed this to be the S1 and he thinks this is the disc in problem. So on the X-ray, he can't see which disc is coming out. So he can easily get the level wrong. So it's very important to kind of highlight and say that there is a transition vertebrae and this is what I am considering this vertebrae as. Right, so the marrow, you have T1 and obviously T2, as I said, because there is in the adult, the normal hemopoietic marrow converts to fatty marrow, and as you get older, it becomes brighter and brighter on T1. In a young child, you have reasonable amount of hemopoietic marrow, so it might not be as bright on the T1. After you give contrast on the T1, the marrow picks up a bit of contrast, so it picks a bit brighter. So you can see the contrast between the disc and the vertebral bodies on the post-contrast scan. The contrast is far more because of the uptake of contrast in the vertebral bodies. So quite often on the MR you will see a little bit of low signal intensity where the basivertebral vein enters the vertebrae in the front or at the back there. And that's again hemopoietic marrow, because that's the last place where hemopoietic marrow will just hang around till you get old enough for it to become completely fatty. So not to be mistaken for a lesion, and you can see quite often it will be seen in multiple vertebrae. Right, so that's a T1 weighted image, that's a fat suppressed stir image. This is a technique by which you can suppress the fat and the fluid really highlights, and that's a T2 weighted image. So what's happening here? L3 vertebrae, normal and normal. It's clearly looking different to the other vertebrae, isn't it? So, yeah. So what do you think is the abnormality? You can guess, don't worry, don't be afraid to be wrong. Sorry? Met. Okay, caller is saying a metastatic deposit. Anybody else? Right, so all marrow infiltrated lesions will be dark on T1. So you can see this is actually very bright on T1. So bright on T1 is good because it's just fat, isn't it? So, and if there is excess fat, most likely this is hemangioma. Quite often hemangiomas will be just one rounded thing, but this one is involving all of the vertebral margins, all of the vertebral body, and therefore it looks and stands out as dramatically abnormal. The other thing you can notice on the T1 is that there is, on the T2, there is increased trabeculation, which if you did an X-ray, which we did in this case, you can see there is the coarse trabeculation on the vertebrae, which on CT, if you did a CT scan through, will give you the polka dot sign. Yeah? So you get these little bright dots through the trabeculae. So it's an incidental hemangioma, it's a leave it alone lesion. Right, T1 weighted, T2 weighted image, dark on T1 and slightly bright on the fat suppressed T2 weighted image, and dark again on the T1 and very bright on the CT. So these are again reasonably common things which might happen incidentally in the spine. They're just bony eyelids, so anostosis. Yeah. So on the T1 and T2, they can surprisingly sometimes look like tumors, but then if you do a CT, you see that it's a single solitary sclerotic lesion. Obviously, the differential is between sclerotic mets and sometimes it might be hard to make the difference. You might do a bone scan to see if there is activity. Sometimes inostosis will become bone activity as well. So then you are again stuck, and if there is no known primary, patient doesn't have prostate cancer, you might just do a follow-up scan to make sure that it's stable. Right, so dark on T1 and dark on T2. So when you see dark on both T1 and T2, that's something not right. Yeah, so it could be a marrow-infiltrated lesion. But sometimes you might really have atypical hemangiomas. So hemangiomas, obviously, they have fat and they have hemangiomatous components. And there's a varying proportion of the hemangiomatous versus the fatty component. If there is more fatty component, which is what normally happens, so they're bright on T1. But some hemangiomas may have very little fatty component and more hemangiomatous component, and then they might be dark on T1. And then again, you can't be sure, oh, is this a lesion or not? So you'll probably end up doing a bone scan to make sure there is no activity. If there's no activity, no other underlying primary, then you could just do an interval scan. So in a degenerative spine, you invariably see these changes on MR around the end plates. They are called modic changes, and we normally classify them as type 1, type 2, type 3. So type 1 is when there is marrow edema, so that's bright on T2 and dark on T1. Type 2 is when there is fatty infiltration, so it's bright on T1 and bright on T2. And type 3 are when there is sclerosis, so it's dark on T1 and dark on T2. So invariably, degenerative changes, they go through this lifespan of changing from type 1 to type 2 to type 3. Sometimes you might see different levels or different grades of Modi's changes in the same spine. So you might have a type 1 hair, but you might have a type 3 hair or a type 2 hair. Type 1 Modi's changes can be symptomatic because there's marrow edema and there's actual, they can trigger off pain because you have the sharpie fibers there. So type 1 Modi's changes is worth mentioning on the report. Type 2 and type 3 sometimes will even disregard. But invariably I would drop a line saying that the vertebral marrow appears unremarkable apart from type 2 changes at this level. And that's just for that no smart aleck comes back 5 years later and say, oh, you didn't mention this changes there. So they're reasonably irrelevant, the type 2 and type 3. Type 1, there was one paper from I think it was Norway, which said that they're actually low-grade infections. And they did lots of discal biopsies to prove that there was an organism. But then that was the only paper that proved it. And they had suggested that you should put them on long-term antibiotics because it is a low-grade discitis. But then it has been discounted on lots of other papers. So I think it's just a degenerative process, it's not necessarily an infection. Right, so T2 weighted image, T1 weighted image, sagittal slice through the middle of the spine. Normal and normal? Okay, how are you saying abnormal? I put some normals in as well. Okay, so she's worried about the marrow signal. What do other people think? Worried or not worried? Anybody worried? No, not worried. Okay. So the marrow, so that's probably fine for a T2 weighted image. The discs are bright, marrow is a bit darker, but that's not fine for a T1 weighted image. So on T1, the discs should never be brighter than the vertebrae. You see, if you look just for one shot view, you can see that the discs are standing out. Yeah? Even though the vertebrae is bright as well, but the discs are brighter than the vertebrae. And that indicates that there is something going on. The marrow it should have been fatty, it's no longer fatty, and it's not fatty to the point where the signal is flip-flop. So this is called the flip-flop sign. And this is what it should normally look like. So the vertebrae should always be brighter than the disc. So if the vertebrae is not as bright as the disc, then think of marrow infiltration. And things like hematological malignancies like lymphoma, leukemias, they will do that, yeah, diffuse. Or even very diffuse metastatic disease could give that appearance. There is one exception to this, and I have a case which I might show later where you can get this signal again, but it's not a malignancy, yeah? But I won't tell you what, so when we come to it.
More.
Right, so again another example of T1, the vertebrae, the discs are brighter than the vertebrae, and because the abnormality is so diffuse, it nearly looks normal. This is something like in the bone scan, you have a super scan. Have you guys heard of a super scan in the bone scan? Yeah, where everything is picking up so much isotope that it looks normal. Everything looks uniform. The only giveaway is that you don't see the kidneys. Yeah, the kidneys are missing, so, and then something tells you that there's too much isotope uptake in the bone. So this is a bit like a super scan. The T1 where everything is infiltrated and therefore it looks completely normal. Right, okay. Anything catching your eye? So that's T1, that's T2. Yeah. So here the thing to see is if you just notice because we're talking about marrow, so look at the marrow. So you can see that's what T1 vertebrae should look like. That's fine. But suddenly when you come to L5, S1, it's become too bright. And it's very sharply demarcated. So you can see here it looks fine, but then suddenly it's too bright on T1. And similarly on T2 as well, it's too bright. So too bright on T1 and too bright on T2, anything which is bright on T1 and T2, think of fat. Right? So it is fat, but it's become even more brighter than the normal fat. So there is essentially hyperplasia of the fat. And it's very geographically demarcated. There is a sudden kind of transition. Any ideas? Sorry? Yes, exactly. So it's radiation. So when you give external beam radiation, you get marrow infiltration, and that's a clue that the patient's had radiation. Quite often it won't be on the request, and then you just looking at that, you know there's patients have radiation, and then that kind of makes the penny drop that something's happening to this body. Right, so obviously with MR you'll sometimes be imaging collapsed vertebrae, so this vertebrae become a vertebra plana. Here again you can see two vertebrae which are completely collapsed, and quite often when you see a collapsed vertebrae, especially in the elderly, the differential is between osteoporotic collapse versus malignant collapse. And there are certain features which kind of help us differentiate. So if the back wall is not bulging, it's not convex, it's more likely to be osteoporotic. If the marrow edema is kind of sharply demarcated from normal fatty marrow, then it's more likely to be osteoporotic, because that's where the kind of fracture line is, and there's normal marrow is. Sometimes with osteoporotic, the acute fracture causes edema throughout the whole vertebrae. But then you're looking for soft tissue and you're looking for the posterior vertebral margin. So like this collapse, you can see the posterior vertebral margin is bulging. Yeah? So even though the front of this vertebrae could have been an osteoporotic collapse, that's a giveaway that this is probably not an osteoporotic collapse. There's probably underlying malignancy which is caused. You can obviously use contrast, which might show enhancement, and then diffusion imaging is quite useful as well to show reduced diffusivity in malignant marrow infiltration. Right now, discs, when they degenerate, obviously you can get disc herniation, so that's a normal disc. So initially as the disc degenerates, you get annular tears, and then the pulposus kind of oozes out, and then it forms a disc herniation. Or the disc might just degenerate and desiccate. So normal disc, then you start getting a bit of degeneration in there, loses water, and then it kind of collapses, becomes very dark, and the disc starts bulging because it loses its kind of elasticity. So these are kind of two ways the discs can kind of degenerate. So you can see disc on T2 should look like this, but as it starts degenerating, loses height, loses water, and therefore it becomes a bit darker. We quite often use the word desiccated or dehydrated, but technically that's actually not correct, because it's not the water which, there's actually no drop in it. So they have done studies with degenerate discs to see what's causing the darkness. It's actually glycosomic glycans which kind of form in the disc rather than it losing water. But I think for colloquial use, it's quite useful to say desiccated. So you're just saying they're dark. Yeah? And then in some of the degenerate discs, you'll see this little bright spot at the back. Spot there. Yeah? So what's that? Yes, sorry, louder. Yeah. Yeah, so that's an annular tear. So the pulposus kind of gone through a little radial tear in the through the annulus, and it's ended up at the back of the posterior longitudinal ligament. So the Americans call them HIZs, yeah? High intensity zone. So because it's bright on T2, and they essentially represent annular tears, and they can be painful because you have sharpy fibers there, and therefore if a patient has low backache and you have annular tear, it's probably explainable on the basis of that little bright dot there. Yeah? So it's worth mentioning. So again, another annular tear, you can see a little bright spot there, so there's a diffuse disc bulge, but then you can see the pulposus is kind of reached right up to the annulus, and it's bulging under this thing. So on the axial slice, it's that little high signal there, and again representing an annular tear. Right, now in terms of the nomenclature, you obviously have normal discs, then you have a disc bulge, which is just diffuse bulging of the disc, then you have a protrusion, then you have extrusion, and then you have sequestration. So disc bulge is when all of the disc or a large part of the disc focally just loses its elasticity, but actually the annulus is not torn. Protrusion is when there is a little tear in the annulus, but the pulposus is still confined to the posterior longitudinal ligament. It hasn't gone beyond the confines of the posterior longitudinal ligament. And extrusion is when it goes beyond the confines of the posterior longitudinal ligament, and sequestration is when it loses contact with the parent disc. It can migrate, so it can migrate a long way, sometimes even at the back of the thecal side. So that's the kind of terminology that normally is recognized internationally. So that you might call that a diffuse disc bulge, this a disc protrusion, this a disc extrusion, and you can see here there is a little bit of material which has gone behind the L5. It's slightly hard to say, is it come from the L5S1 and gone up, or if this has come from there and it's gone down. But it looks like there is a sequestered fragment there. Most likely it's probably the L4, L5 which has kind of gone down. So you can get a symmetrical diffuse bulge or an asymmetrical bulge. And a focal bulge, like if it's only about that much, then you might as well call it a protrusion rather than a bulge. But some people use the term focal bulge as well. But technically a bulge is either all the way through or marginally asymmetrical, but a very large proportion of the circumference. Protrusion versus extrusion, even though I said that extrusion when it goes beyond the posterior longitudinal ligament, but obviously it's hard to know that on MR whether it's gone beyond these things. But the morphology is the giveaway. So if you look at a disc and the largest diameter of the extrude or the disc herniation is not the base. So here if you draw the diameter at the base, you can see that's not the largest diameter of this thing. The largest diameter is there. Here is the largest diameter is this. Yeah? Well, it gets smaller, smaller, smaller. So the left one is disc protrusion and the right one is a disc extrusion. The next thing is location. So normally you won't talk about discs coming out there. Those are irrelevant. So don't even mention them on the report. So you're only talking about discs in that area which can be relevant. So you normally use words to kind of describe where the disc is coming out. So this is central, this is paracentral, this is foraminal, and this is extraforaminal. So it's useful to kind of use those words. This also on the international classification, you can use paracentral or you can use subarticular. So central, subarticular zone or lateral recess or paracentral, and this is your foraminal zone, and this is the extraforaminal zone. And then the disc level wise, it could be suprapedicular, pedicular level, infrapedicular level, or disc level. So the disc comes out, it might go up or it might go down. So and it might end up in any of these levels. So when you're describing a disc, you often describe the level where it is as well as which zone it is in. So level and the zone, yeah. So is it in the central subarticular zone or the paracentral or the foraminal zone or the extraforaminal? Right, so how many cervical nerves do we have? How many pairs? And how many thoracic? How many number? 5. So in all, how many? A few oxygen as well. So under 31 or 32 pairs. Right? Now the trick is that cervical vertebrae, obviously there are only 7 cervical vertebrae, but there are 8 cervical nerves. Yeah. So the C1 comes out at the occiput C1 level. So in the cervical spine, the nerve that is coming out between 2 vertebrae is the one which is the lower one. So at C3, C4, the C4 comes out. Yeah? At C4, C5, the C5 comes out. And so on and so forth. But at C7, T1, the C8 comes out. So there is a C8. Yeah? So at T1, T2, the T1 comes out. So in the thoracic, it kind of flips. So in the thoracic spine, if I say the nerve that's coming out at T4, T5 is the T4 nerve. Yeah? But at C4, C5 it's the C5 nerve. And in the numbers, again it's the, at L3, L4 it will be the L3, so it's the 1 before. So when you are describing a disc and its effect on the nerve, you should describe which nerve is this. So you should actually number the nerve. A lot of people say exiting, transversing, and this thing. So, but it's appropriate to actually say which nerve root is affected at which level. So now the extent of the nerve root compression. So the nerve roots can either be just touched, mild, moderate, or severe. So sometimes the disc might just touch the nerve, it's not actually compressing. But that might still be relevant because discs, when they come out, they produce a lot of chemicals, interleukin and a lot of other chemicals. I don't even remember, there's a whole list of them, GABA and anti-GAD. And so all of these chemicals, they irritate the nerve and they can cause a lot of pain. So, but invariably, over a period of time, that settles. But then obviously there can be compression, and mild, moderate, severe compression is based on the extent of the compression. So if you quantify the space that the nerve normally has, wherever it is, either in the foramen or in the subarticular zone, which is the right lateral recess or the left lateral recess, divide it into 3 parts. So 1/3 of the space gone, 2/3 of the space gone, more than 2/3 of the space gone. So if 1/3 of the space is gone, mild compression. If it's between 1/3 and 2/3, moderate compression, and if it's more than 2/3, then it's severe compression. So it's useful to quantify the extent of the compression as well. So eventually you end up then describing. So now let's have a look at this. So I'll do that for you, then I'll get you to do one. So you can see the disc which is coming out is the L5S1 disc. On the axial T2, you can see the disc is in the central and left paracentral. So you can add up the locations. If a disc is big enough to be in more than one location, you can say central and left paracentral. Or sometimes you might even say central and bilateral paracentral. Or it might be left paracentral and left foraminal. So it can be more than one space. So this one is central and left paracentral. So there is a disc. Is it an extrusion or is it a protrusion? What do you want to go for? Protrusion. So you guys are looking at this and you're saying the biggest diameter is there. But what I didn't tell you was look at both the sag and the axial. And if of anyone, if the biggest diameter is not the base, then it's an extrusion. So on this one, you can see here the base is only that much, but this diameter here is bigger. So this is probably an extrusion. Because on the sag, it's an extrusion. On the axial, it looks like a protrusion. But because on the sag, it's an extrusion that takes precedence. So it's a right central and right paracentral L5S1 disc extrusion causing mild, moderate, or severe. Severe, because nearly all the space is gone for the nerve root. Yes, a severe compression of the which nerve root? So the L5 nerve root is actually already gone. So the L5 nerve root is here. So it's not the L5 nerve root. So it's the so it's the left S1 nerve root in the so that's how you will end up describing this. So left central and left paracentral L5S1 disc extrusion causing severe compression of the left L5 nerve root in the lateral recess by international nomenclature. So nobody can come and kind of say you got it wrong. Right, okay, let's go now. So this is this level, yeah? Okay, location? Central. Okay. Protrusion, extrusion? Protrusion. Okay. Is it doing anything to the nerve roots? Touching? Abutting? So I think you can probably say it is touching, because normally the disc should be actually concave like this. And the nerve root should have, so you can see the discal material, it's probably not this bit, but that bit of the disc is touching. So you could say, and you could even kind of qualify this as a central and bilateral paracentral disc protrusion. Abutting or touching, which bilateral? So which nerve root? This is L5S1. So bilateral S1, nerve roots in the lateral recess. Right, sometimes the disc will go all the way out there, so that's a kind of far lateral disc, so L3, L4, and you can see the disc is also gone into the foramen, so, and it's nearly extrusion, so, and it's in the foramen and it's kind of extra foraminal. I don't have the T2, but you would have seen that it's in the foraminal area and in the extra foramen. So how do you describe that? And it's on the right side. So the right, which level? The right, L3, L4, disc, extrusion, yeah. Causing compression of the, so yeah, so causing compression of the right L3 nerve root in the, so in the foraminal and extra foraminal. So it's because it's in both, yeah. So in the foraminal and extra foraminal. So in fact, it's severe. So I call it moderate. Okay. Who wants to go? Anybody wants to go? So it's that disc we're talking about, that on the axial there. Let's give somebody else a chance. Anyone wants to give it a try? So, okay, I'll prompt, yeah? So, left, which level? Louder? Yeah, so left L5S1, disc, protrusion, extrusion?
Extrusion.
Okay, so it's an extrusion on this one, it's a protrusion on that, so extrusion, yeah? So left L5S1 extrusion, causing? So we can say location, isn't it? So left L5S1 extrusion in the central or so left paracentral. Right? The left paracentral location causing mild. So normally the nerve should have been actually sitting there. Okay. So it's actually got pushed a bit, and it is. But it's fortunately what's happened is it's not gone against the facet. So it's managed to find a little bit of space. But the disc is actually taking up a lot of space of where the nerve would have been. So you can say moderate, yeah? It's not compressed, so not severe. So moderate compression of the left, which nerve root? Yes, yeah, so left S1 nerve root in the lateral recess. Yeah. Okay, now we only have axial. So this is central and bilateral paracentral disc extrusion, causing severe compression of bilateral, whichever level this is, nerve roots in the lateral recess, and also causing compression of the cauda equina. So this has become big enough to actually start compressing the cauda equina. The normal CSF signal intensity is lost there, so that needs to be highlighted. Yeah. So ligamentum flavum with degeneration can we say hypertrophy, but technically it doesn't hypertrophy. When we look at it histologically, there is actually nothing growing in the ligamentum flavum. Essentially, as the disc collapses, the ligamentum flavum starts buckling because there is less space for it, so it buckles, so it looks thicker. So it looks thicker, but otherwise it's not hypertrophy. But it's okay to use the word hypertrophy, yeah, because it looks hypertrophy. Right, so here, apart from the disc, you also have a grade 1 spondylolisthesis. So at L4, L5, there is a grade 1 spondylolisthesis with a diffuse disc bulge which extends into the whichever, no, I think this is probably the right, so right foraminal region, causing severe compression of the right L4 nerve root in the foraminal region. Yeah. So canal stenosis now, this is what a normal canal looks like. Some people are born with a kind of small narrow canal, so and then on top of it, when the discs start kind of degenerating, it can get even narrow. So this is an inherently kind of narrow canal to begin with. Yeah? This is what it should normally look like. And then as more and more of the disc and the ligamentum flavum hypertrophy because of the disc degeneration starts buckling from the back. And people who get a lot of backaches, they get epidural injections, and with the steroids, they get a bit of epidural fat pad thickening as well. So all of that kind of contributes to canal narrowing. And you can quantify the canal narrowing by actually measuring the cross-sectional area, but that's too tedious, nobody does that. So you can essentially eyeball, yeah? Or you can take a mid-sagittal dural sheet dimension. So just measure the dural sheet, don't include the fat, just measure it from the front to the back here in millimeters. And if it's less than 6 millimeters, it's severe. Between 6 to 8 is mild, more than 10 is normal. So mild, moderate, severe. Yeah? But the one thing which really correlates with symptoms is loss of the CSF signal intensity. So normally if the CSF gets lost, the reason the CSF intensity on T2 gets lost is because the space gets narrow, the CSF is flowing faster. So the flow is causing a flow void, which is dropping the signal on the T2. So it's not like this, any tissue there, it's just that the CSF is flowing faster in a narrow column and therefore it moves away before the MR picks up the photons. So it looks dark. So this is severe canal stenosis. You can see the canal, the thecal sac is dural sheet is just there. This is the epidural fat at the back, yeah? And very severe, it's so knocked off you can't see, you can hardly see this. So this is the kind of severe canal stenosis at 2 levels. When that happens, the nerve roots above and below, they become very tortuous if it's been going on for a very long time. This doesn't, even though the thecal sac is so badly squashed, this doesn't necessarily mean there is Cauda-Equina syndrome. So Cauda-Equina syndrome is a clinical thing. Yeah? You need to have bowel, bladder, anal tone, and weakness. So if you don't have that, and quite often because this has been happening slowly over a very long period of time, despite very severe compression of the Cauda-Equina, they actually don't have clinical Cauda-Equina. So don't say Cauda-Equina syndrome because that's not a radiological terminology. Right, so what's happening here? So the arrows are a bit of a giveaway. So that's a fat suppressed image, and you can see the bright signal, really all of the corners, yeah? What's the diagnosis? Yeah, so two things there. One is this is a rhamnus lesion which is inflammatory. You can get fatty rhamnus lesions as well. But there is active inflammation at the enthesitis which is giving the high signal on the stir. The second thing to note is straightening of the vertebrae. So vertebrae normally they are concave on the front. Yeah? But with ankylosing spondylitis you get a bit of squaring. So the squaring of the vertebrae and the ossification of the anterior and posterior longitudinal ligament is very hard to see on MR. It's very easy to see on X-ray, but it's extremely hard to see on the MR. And quite often ankylosing spondylitis will get missed on MR because you might have a bamboo spine and you just don't see it on the MR. So the clues are quite subtle. So that squaring, if you see that squaring, just kind of stop. Oh, is this guy got ankylosing spondylitis? And sometimes it might be useful to do an X-ray. So here again, you can see this patient's got a bamboo spine. But apart from that rhamnus lesion, it's extremely hard to see that. Yeah? Because there's that fine ossification which is going along the anterior, but difficult to see. This is the inactive rhamnus lesion which is bright on T1, but not bright on stir. Right, what's happening here, you can see clearly the two vertebrae there, the marrow signal is abnormal, the disc has kind of also lost its signal on the T1, on T2 the disc is extremely bright, on the axial you can see this kind of fluidy stuff within the disc and even in the paraspinal region. So that's discitis here. So you can, when you see high signal in the disc, straight away start thinking of discitis, especially if there is end-plate marrow edema. Tubercular spondylitis, the disc and the vertebrae go very quickly, so quite often you get a kind of kyphus deformity, you get paraspinal abscess formation, and you get posterior paraspinal abscess as well, and you get a kyphotic deformity quite quickly. So this is quite unique because the patients aren't that unwell. Quite often they will first time present in this situation. Yeah? And then again you start thinking, oh, could this be TB? So we see now you encounter abnormalities when there is a signal abnormality in the cord. Yeah? Now there is a massive differential of what could be going on. Yeah? Obviously they have, invariably they will have neurology. And the way to kind of get to the bottom of what the final pathology is to put the clinical information. You can't just do it by radiology alone. Okay? So first of all, you need to kind of know, is the condition acute or subacute? Because your differentials for acute and subacute problems are completely different. And you can also add chronic to it. So acute would be like sudden onset, or so acute can also be hyperacute. Absolutely sudden onset, or it could be in days or weeks. So that's all acute. Subacute would be kind of months. Chronic would be years, yeah? So the problem's been going on for years and then something has happened. So first of all, try and find out, is it acute, subacute? Within acute, is it hyperacute, or it's kind of few days or weeks? And subacute, is it kind of in the months or in the years kind of framework? Then you have to put the history in, because there will be lots of clues in the history of as to what's going on. If you don't do this, you won't get to the bottom of the diagnosis. So were there any previous events? Is there any family history, vaccinations, surgeries, in surgeries, gastric bypass, gastric surgeries, was there relevant yet? So you compare. Any immunosuppression or any previous known infections which can cause immunosuppressions, previous tuberculosis, any history of radiation. Then look at the abnormality of the MRI. And I'll come to the details of what to look out for on the MRI. And then for any ancillary clues on the MRI. So that bit obviously we are good at, but we need to add this, and then when you add all of this, you quite often can get to the bottom of exactly what the diagnosis is. So acute conditions, acute transverse myelitis, infectious myelitis, infarctions, pneumonitis optica. Subacute combined degeneration, dural aviform malformations, MS, which can be acute, but quite often will be like multiple episodes. And then hereditary spastic paraplegia, they will all be subacute or long-standing. So in history, previous events, look for history of MS. Is there a family history? If somebody else in the family has a similar problem, then it might be hereditary. Vaccination, post-infectious, did he have a sore throat or something? Any known infections like HIV, tuberculosis, or viral infections? Surgeries, bariatric surgery which causes copper deficiency, which can then cause myelopathy. AAA repair, which can cause cord infarctions. History of Crohn's and malabsorption, which can cause subacute combined degeneration. Zinc overload, which leads to copper deficiency. One of the causes of zinc overload, in fact, I have a patient there, diagnosed it once long back. Had a cord myelopathy. Weakness, some sensory symptoms, high signal in the cervical cord. Nobody knew what was going on. Everything was normal. And then this is actually one of our radiologists, his uncle who lives in Pakistan. So I asked him, does he have dentures? So you would say, why the hell did I ask him? Does he wear dentures? He said, yeah, he wears dentures. And I asked him what cream does he use over his dentures? And this is a dental cream which has zinc in it. And the zinc overload, where we keep using the zinc cream to calm your dentures on the gums, that causes a zinc overload, that causes a copper deficiency, because zinc and copper get absorbed through the same mechanism in the gut. So if you have too much zinc, then the copper gets inhibited, and you get a copper deficiency, and you get a copper deficiency induced myelopathy. But now this diagnosis should come from the radiologist, it should be the physician who should be doing it. But if you know this, then you know who it is.
Yeah.
So that's why it's really important, right? So history for myelopathies, you won't get away by getting to the diagnosis unless you have very good history. Right, the pattern of the abnormality is to look at obviously the signal intensity. Is it CSF or is it just edema? So CSF is much brighter, edema is not as bright. CSF will look dark on T1 as well, whereas edema will merge imperceptibly with the cord. So T1 you won't see edema that well. And that will help you differentiate whether it is CSF signal intensity or edema. Then the cross-sectional location, longitudinal extent. So how many vertebral lengths are being involved? So is it a short segment or is it a very long segment or it's a medium segment? Is there cord atrophy? Is there more than one lesion? And is there enhancement? So these are things you can see on the MRI. And then based on that, extensive, which means a very long segment abnormality, you have dural AV fistula, hereditary spastic paraplegia, infectious myelopathies. Intermediate segment, which is like more than 3 vertebrae, but not less than 3 vertebrae. So, acute cross-vasculitis, NMO, cord infarction, infectious myelopathy, and subacute combined degeneration. Short segment would be MS, NMO, when it is resolving. Normally NMO, neuromyelitis optica is 3 levels or more. And compressive myelopathy is short segment. Where is the abnormality located on the cross section? So is it right at the back? Yeah. And if it's preserving the kind of medial columns there, so this could be MS, this could be MS. So peripheral, but it could be the back as well, but it could be somewhere in the periphery. If it is at the back, but it is kind of preserving more along the grey matter and a little bit of the white matter tracts are preserved, then it is subacute combined degeneration, HIV, and hereditary spastic paraplegia. Subacute combined degeneration is B12 deficiency. And even copper deficiency and zinc overload will also cause this kind of experience. Polio, ALS, which is the motor neuron disease, and infarction, there will be more anterior and kind of bullseye pattern. The acute cross-vasculitis more central and MS periphery. So where is the abnormality of the cross-section is quite useful in deciphering where the problem is. Okay, acute onset, no relevant history, intermediate length. And I'll add one bit. He had a sore throat a month ago. So intermediate length, and on the axil, I haven't given the axil, but it was in the middle. So this is idiopathic acute cross-vasculitis. Subacute onset, there is family history that somebody else also had similar kind of gait. There was actually gait problems, yeah, abnormal gait, intermediate length, posterior column. So you can see the problem is at the back, it's confined to the posterior column there. Hereditary spastic paraplegia. So here the thing is the family history, yeah. So it's right. Subacute onset, focal neurology, short segment, epidural compression. So there's a little bit of high signal there. You can see a disc there. So, and it's the abnormality is where the disc is, so that kind of nearly clinches it. It's a compressive myelopathy. So, cord injury. Acute onset, vision affected. Intermediate length, you can see the optic nerves are enhancing there, and central location. So that's neuromyelitis optica. Yeah? Neuromyelitis optica is quite a unique kind of condition. Now the name's been changed to neuromyelitis optica spectrum disorder, NMOSD. Okay? Because there is actually a spectrum of abnormalities. So you might get optic neuritis, myelitis, area post tremor, and it's kind of had a chronology of definitions. Yes, so finally in 2004 they discovered the aquaporin antibody is responsible. Yeah? And in 2007 neuromyelitis optica spectrum disorder was introduced. Yeah? And then there was a criteria for diagnosis in 2015. The abnormality can happen in multiple areas, but that's the kind of common area involved. You can see a high signal there, periventricular, around the third ventricles, around the optic nerves, periaqueductal, and in the area post tremor. So area postrema is this area here in the fourth ventricle. That's causes vomiting. So one of the presentations of neuromyelitis optica is incessant vomiting, nearly like hyperemesis gravidae. Yeah? So patient comes and there's no cause for it. Gastroenterologist will do endoscopies, they will do CTs, and all the vomiting. And the vomiting is as severe as hyperemesis gravidae, vomiting 30-40 times. And then somebody will say, get a brain scan done, is there a tumor or something? Yeah? And you won't find a tumor. All you will find is a very subtle high signal. Now, this is actually quite dramatic. But I've had one case where there was just one single dot there. And I said, check for aquaporin antibodies in your own policy. So that's called area postrema syndrome. Okay, multiple acute events, short segment, posterior peripheral location, lesions in the brain. So MS, yeah. Fever, raised ESR, mediastinal lymph nodes, long segment, central location. This patient was an immigrant from Eritrea. So this was tubercular myelopathy. Very unusual. Normally tuberculosis involves the vertebrae and spine, but you rarely even get a tubercular myelopathy. Yeah? But the giveaway is the fever, ESR, mediastinal lymph nodes, a bit of the history of where he's come from. Previously operated, long segment, CSF density. So you can see the cord, there's a signal which goes all the way, so the cord is very atrophic, very high signal, and then there is this big lump sitting in the middle, and you can see the spinous process is absent from there to there. So he's had previous surgery, but they didn't tell us what the previous surgery was. But then when you dig harder, so it was an ependymoma which had been operated. Yeah? And the syrinx, so that myelopathy is from the syrinx, but that's CSF signal intensity. So that kind of tells you that it's not edema, it's CSF density as a result of that lesion sitting there. Acute onset history. Acute onset, history of multiple previous cancers, intermediate length, central location. What's the diagnosis? Sorry? Yeah, so there's a clue on this thing. So can you see those vertebrae there? They're very bright. Remember the same as the lumbar one, yeah? And very sharp demarcation. So he had nasopharyngeal cancer. So he had radiotherapy, and that's radiation myelitis. Yeah? Clue. Multiple acute events, short segment, peripheral location, cord atrophy, lesion in the brain. So peripheral location and multiple lesions. There's one there, then there's one there, then there's one there, then there's cord atrophy, and there are brain lesions. Yes, good. You're getting good at it now, isn't it? No focal neurology, CSF density, short segment, central location. Right? So, yeah, so you could call this, it's a syrinx, but this is just a prominent central canal. It's a normal variation. Yeah? You see it quite often. So, and there's no neurology, you did the scan for something else and you spot this, it's just a prominent spinal canal.
It's not cerebral.
Not cerebral. Okay. Acute onset, rapidly progressing paraplegia, intermediate segment, central and anterior location. So what's against that?
Acute onset, but it's progressive. Rapid.
Yeah,
Progressive.
rapidly.
And it's paraplegia, so and it's anterior.
And there's another clue on the images. Ancillary findings. Clue. a cord infarct. Yeah? That's actually a diffusion. Yeah? Diffusion of the cord, and you can see it's very bright. So diffusion actually is best done in SAG because cord normally looks bright on diffusion. Where it is infarct, it looks even brighter. So either you have an eye for it and then you can say, yes, suddenly when you're looking axially, you say, okay, not so bright and then a bit too bright. But if you do a SAG diffusion is pretty hard to get. You have to manipulate your parameters really well. So we managed to get it very good with our technicians having set the parameters. And then you see the cord on diffusion is bright, and then very bright areas suddenly where the cord is. But you can see the owl's eye pattern there on the exit, the two round dots in the middle. So that again goes with cord infarction. That's the EDC, which is again dark, too dark. So this again is not an uncommon finding. Isolated focal settings, they can sometimes be symptomatic. They don't do anything. They leave it alone things. Yeah. So it's not like it's a normal variation. But you can see as focal settings. For quite often you will give contrast to make sure there isn't a tumor sitting there. But in building you don't find anything, and then you do a follow-up scan and it's right. Okay. Now who knows this one? Focal neurology, short segment, bit of cord atrophy, and abnormal location of the cord. You can see the cords coming there, and then suddenly it kind of takes a little dip. It's kind of too close to the vertebral margin, then it kind of comes back again. This, I think, if you have seen this before, you'll know it. If you haven't seen it, you won't know. So it's not like you can't think this one out. You want to guess? Yes, fantastic. So that's a cord hernia. Yeah? So essentially, what happens is over a period of time you get a little dural defect, and the cord herniates through the dural defect and gets stuck there, and it kind of is in an anterior location, gives you malopathic changes because of the cord edema there. The CSF flow becomes faster at the back there, so you see a lot of this kind of flow void, which is a bit more than you would normally expect, and needs to be surgically sorted. You have to go in and right. Unilateral left arm muscle atrophy, short segment cord atrophy, abnormal location of cord on MRI inflection. So now nobody does MRI inflection, isn't it? But for this condition, MRI inflection is the diagnostic mistake. But because nobody does MRI inflection, you would have to cast this on a non-flexion MR first to be able to suggest the flexion MR. And it's normally young adults, adolescents. Sorry? Yeah.
That's our new.
Yes. So the MR before flexion, the only thing you would see, obviously the history would be a bit of a giveaway. Just minor cord atrophy on one side. So the same side as the weakness, the cord would be a bit smaller than the other side. And then that kind of rings a bell, and then you say, oh, get him back for a flexion. Right, subacute onset, no relevant history, long segment, central location. And the clue is these little things there. Now the neuroradiologist will tell us. Louder. Neurology fistula. Yeah. So neurology presents CSF density, long segment, central location, and that ancillary finding. Anybody here? Then I'll go to the Acute onset, previous optic neuritis, intermediate length, central location. And it's quite a long, so it's nearly kind of 3 segment long.
So it's a toss-up between NMO and MS. Is this MS? And normally NMO won't give you kind of brain lesions there, but this one is
kind of NMO. NMO used to be labeled as a type of MS. It was the Pavix MS. Yeah? But then when they discovered the aquaporin antibodies, they knew it wasn't MS, so they took it out of MS.
okay. This I don't know what's happened there. You can't read the history, and the images are a bit blurred as well. But acute
history, pain and weakness after lifting heavy weights.
So I'll show you where the abnormality is. There's a little bit of high signal in the cord there, and you can see it's on the axial. I don't know why I noticed that, but it's nearly the Alzheimer's pattern that we saw earlier.
This one, let's see, neurologist.
So that Alzheimer's pattern, what was that Alzheimer's pattern we just saw on another case?
Cord infarction. Yeah. So that says that it's probably cord infarction, short segment. But what's that history? Lifting weights and why the hell has he got cord infarction by lifting weights? So the clue is in that disc there. You can see there's a disc herniation there, but there's a lot of space, so it's not like malabsorption condition. History is very acute. So this is again an unusual condition. It's so fibrocartilaginous embolism. The disc gets embolized into the arteries. So essentially that's the mechanism. So you get disc herniating into the peripendicular veins or arteries, and then it travels to the cord and causes an infarct. So there are only I think 40 or 50 cases. So we in fact have 2 cases, but they hardly ever get proven because you never get any histology. So it's kind of just the combination of the things which, so there's a criteria, and if it fits all of the criteria, the history fits, the cord, you get this, diffusion you do, and there's a disc there, then you can say it's fibrocartilaginous. There's some new drug they've said which dissolves the disc, and that can be given. So there's a trial going on for sorting it with some drug. Acute onset, recent upper respiratory tract infection, intermediate length, lots of brain lesions in a young person. So that's ADEL, yeah? Acute demyelinating encephalomyelitis. That's, I think we've seen this earlier, so that's just a prominent central canal, yeah? Normal variation, so no relevant history, long segment, central and CSF density. Okay, now this one's got a wine bottle going. 29-year-old boy presented with progressive sensory symptoms in the upper and lower limbs with tingling in pins and needles, loss of coordination in simple daily tasks, urinary incontinence. He had an MR brain which was reported as normal, but then when they came back again and they said, oh, he's definitely got something, try and find something. So that time on this MR you can see the abnormality. Where is the abnormality? Since this lecture is about cord, so the abnormality has to be in the cord. So the abnormality is there, yeah? So, on the MR brain, normally the SAG would cover a little bit of the cord, but quite often when you are reporting the brain, you don't kind of concentrate. But you can see there's a bit of high signal there, yeah? So we said, oh, get him back for an MR of the, so we did a whole spine MRI. Now then, this is obviously the amalgamated picture, so it's slightly hard to see, but I can tell you there's quite a lot of high signal in the cervical cord, and there was high signal in the dorsal cord as well. So findings more extensive, also extending into the dorsal cord, cervical and dorsal cord. Right. And then we couldn't fathom what the problem was. Okay. Right, so, okay, that's good, yeah, you got it. Did they hear it? Did anybody hear it? No. No. So we keep quiet, yeah?
So again on the T2 axis you can see cord abnormality in the, it's more in the, so here it looks like it's probably involving one of the cord, but if you narrow the window you can see the abnormality is actually more in the posterior cord. And differentials are obviously lots, but then the patient, the clinician came and told us the patient is saying that some of his friends are getting the same symptoms. So that's the kind of clue.
They drink alcohol.
So yeah, so Paul is on the right track. The fact that friends are getting it, that means they've done something in the net. So what have they drunk? Whiskey, vodka, gin.
Might be combination.
Huh?
It has to be spirit, some high.
Spirit. So you think spirit. Okay, anybody else? Okay, there's another clue. Nick spoke about it in his talk. Now we're checking who all were awake. Yeah?
Can you speak again?
I described it as a wonderful drug which was great for pain relief.
That's the nose.
Yeah, it's a nitrous oxide. Yeah. Not Entinox. Nitrous oxide. So in UK, I don't know whether kids do that here. Do they abuse nitrous oxide here? No? That's what they didn't know.
So everybody gets a wine bottle.
Right, so okay, where is the, so it's called, they come in these canisters, nitrous oxide, and it's called Whippet because it's used for whipping cream in the food industry. But it's available in any shop to kind of buy. And what these kids do is they buy these canisters, these small canisters about that big, and there's a device to puncture the top of the canister. So you put it in the device, it's got a pin in it, so as you squeeze the thing, the pin goes to the top and the gas leaks out. And they put a balloon on that device, so the gas leaks into the balloon. And then they inhale the gas from the balloon and they kind of pass it to each other. So, and it gives them a high for a little while.
The big difference between Entinox, which is what I use,
few animals which are kind of bipedal, so even the monkeys and all that, they're technically not bipedal, so you can see they kind of use their hands to stabilize themselves. The animals which do walk on the hind two legs invariably have a tail to balance the spine. So you can see the dinosaur there, which obviously they're no longer there on the planet. They also have a big tail to balance the spine, and so do the birds. So the birds also walk on two legs, but they also all have a tail to balance their spine. So it's an extremely difficult job biologically to balance your spine without having a tail. So since we don't have a tail, we've devised a kind of mechanism of making sure the alignment of the spinal column is adequately balanced, that we can stand without much effort. So looking at the human spine and comparing it to the other primates, you can see the primate spine is essentially kyphotic. So it's just got one curve here. Whereas the human spine has got three curves. So you've got a lumbar lordosis, then you've got a dorsal kyphosis, and then you've got a cervical lordosis again. And the whole balance is of making sure that the center of gravity of these bricks, which are lined in this very intricate mechanism, falls exactly in the right place. So there are lots of kind of measurements to kind of try and ascertain the spinal alignment, but the commonest or the best and the most simplest way to assess the instead of the C1. That plumb line, so if you drop that plumb line from there, that plumb line should normally drop behind the sacrum. Yeah? So this balance is actually a bit off. It should be behind the femoral heads and it should be behind the back end of the L5S1 disc. So it should be just behind the sacral ala. So that's a well-balanced spine. If the spine is not balanced and this plumb line starts going further forward, and we'll talk about why that happens and how that happens, then it produces a lot of stress on the spine. And the spine then starts degenerating. So understanding spinal balance is useful because it tells you why a particular spine is degenerating in a particular fashion, why degeneration in the spine happens, and then obviously what can we do about it, and if the balance is off, what surgical options we have, and if we do decide to go ahead for surgery, how much to sort. Yeah, because that's the kind of next important question that these surgeons will ask, that okay, the sagittal balance is off, but what do I do? What do I do to kind of sort this? And that again comes from radiology, so that's where we come in and play a role in analyzing and also then deciding the exact surgical option which will help the patients. So that's again, so there are other measurements as well. So you can have this angle, which is the angle between the plumb line and the top of the sacrum, and that can again go forwards or backwards, and that might, so but the plumb line is quite a simple, straightforward way of analyzing the sagittal balance. Now the sagittal balance is intricately connected to your pelvic balance or your pelvic angles. Now there are three angles in the pelvis. So if that's your pelvic bone, that's your femoral head there, that's your L5, that's the sacrum. So if you draw a line along the L5S1 disc, and that center point of the sacrum, you draw a line which is perpendicular along the sacrum, then this angle here is your PI angle, PT angle, and this angle here between the femoral head and the sacrum is the PI angle, and that's your sacral slope. So pelvic tilt, pelvic incidence, and sacral slope. So normally the relation is PI is equal to SS plus PT. The PI angle is fixed. You are born with that angle. So it's not something you can change. So unfortunately, some people are born with a spine which is predestined to degenerate. When I give this talk, most people are doing the back and everybody's wondering what's my PI angle. So unfortunately, this angle is fixed. This angle is fixed at the sacral ala because of the ligaments and this thing. As a child, there is a little bit of flexibility, but by the time you are 11, 12, then that angle gets fixed. And that dictates what happens to your spine. So essentially, PI is equal to SS plus PT. The SS is about 10 degrees, PT is 40 degrees, and the PI invariably is 50 degrees. But it could drop down to 30 degrees, which is bad, and it can go over 85 degrees, which is also bad. So if it becomes over 80 degrees, then you tend to have spondylolisthesis. If it becomes less, then you tend to get spinal degeneration. So you get discal disease and you get fascial degeneration. There are lots of other angles as well, and there are lots of formulas which kind of govern these angles. I won't go into the details of all of the formulas because I can see after having had lunch, if I go into the formulas, everyone will go off to sleep. Right, so the stages of imbalance, so they start with the spine being balanced to begin with. Then there is a bit of compensation. So the balance is becoming a bit abnormal. The plumb line is beginning to go a bit forward, but the body compensates for it. So there are compensatory mechanisms which come into play. And then finally, the compensatory mechanisms start failing and you can't compensate beyond a certain level, and then the imbalance starts getting even worse. When the sagittal balance gets really bad, what happens is your muscles will have to try and rectify the balance. So they're all going to spasm and they're trying very hard to maintain the posture. Yeah? And that's why you get backing. because your muscles are all the time working when you're standing to just kind of maintain the posture. Because if it doesn't maintain the posture, the weight is so much through the spinal column that it starts degenerating. So the body tries to compensate by using the muscles, but that causes backache as well, because the muscles are going to spine. So the compensatory mechanisms are, so one simple rule is all kyphosis are deformities and all lordoses are compensatory mechanisms. So say for example, if you see a lumbar spine which is hyperlordotic, yeah, there's a lot of lordoses, that means that's a compensatory mechanism. Something else is happening somewhere else and the lumbar lordosis is just a compensatory mechanism. If the lumbar lordosis is getting lost and the lumbar spine is getting straight, that's a deformity, yeah, because your balance is going bad. And similarly, dorsal kyphosis is a deformity. But when the dorsal spine is straightening itself, it's a compensatory mechanism. You're just artificially straightening your spine to keep the balance straight. Yeah? And similarly in the cervical lordosis is a compensatory mechanism, and cervical kyphosis or straightening of the is a deformity. So as the imbalance goes, the deformities kick in, but to compensate for the deformity, the compensatory mechanism kick in. So by being able to recognize what are the compensatory mechanisms and what are the deformities, you can actually see which way the spine is going. Now, when the compensatory mechanisms kick in, one of the things that first happens is, as the plumb line goes forward, is that your pelvis tends to go backwards. So it retroverts. Yeah? So if that's the normal pelvis, if the plumb line starts going further forward, your body will automatically twist this whole thing. So your spine will turn like that. Yeah? That's a compensatory mechanism. But this angle is kind of fixed. So that angle can't change, but the whole contraption kind of changes. That's why I made this drawing and I just turned that drawing. Yeah? Now, if you were born with a narrow angle, narrow PI, then there's a limit to the compensation. You can only compensate by about 4 or 5 degrees. And then you reach the limit. Pelvis can't retrograde any further. So that compensatory mechanism can't take the balance or correct the balance any further. Yeah? So that's a narrow PI. Yeah? Somebody who's born like this can't go beyond the horizontal, it can't go that way. You'll fall backwards if you go that way. So the moment you reach this, so the compensatory mechanism only 3 or 4 degrees and that's it. So low PI, that's one of the problems. Yeah? That you don't have a compensatory mechanism available in terms of the retroversion of the pelvis. But if you have a larger PI, you can compensate by the retroversion of the pelvis. So the other mechanism that starts happening is, so say for example, if you are getting a kyphotic deformity in the dorsal spine, what your lumbar spine might do is it becomes more lordotic to bring the plumb line back. If your lumbar spine is getting kyphotic, it's getting straighter. So what your dorsal spine will do is it will reduce its kyphosis. Because it's trying to bring the plumb line back. Yeah, so the compensatory mechanisms are essentially trying to pull the plumb line back. And this happens automatically. It's not like you have to think to do this. The body does it automatically because the man needs to stand. Yeah? And if he needs to stand, then that's the only most effective way of keeping the balance in place. But then if you reach an end of those mechanisms and the plumb line is really going too far forward, then the next thing will happen, your knees will start bending. So that's the only way to bring the plumb line back. So you'll see a lot of people are walking like this. They are actually compensating for the imbalance, the sagittal balance. And that will automatically, reflexively happen. That will put a lot of strain on the hips and the hips will start degenerating. So it's a kind of whole chain of kind of processes of how the balance becomes imbalanced. Right, so how does knowing sagittal balance helps? Because it helps you understand specific degeneration patterns with imbalance. There is a classification of spondylolisthesis which takes sagittal balance into account and the management plan. You can calculate the correction of deformity of the imbalance for surgeons and you can decide how much fusion to do. So one of the big questions surgeons is when they say, okay, a lot of pain, instability, But fuse what? How much to fuse? 1 level, 2 level, 3 level, 4 level, or all of the spine, and that again, analyzing the sagittal balance is useful using a pattern classification, which I will talk about. Sagittal imbalance following previous fusion and correction. So lots of surgeons, when they started off doing these surgeries, all they were doing was fusing the lower lumbar spine. That didn't help because they didn't sort the sagittal balance, and it got worse. Then the adjacent level started degenerating. So if you don't sort the sagittal balance, and if you just fuse 2 levels or 3 levels with no correction of the sagittal balance, the adjacent level will start degenerating. Then you fuse 1 more level, then the level above that will start degenerating. So it will be just a vicious cycle of degeneration after degeneration. And therefore, sagittal balance can also be used to kind of predict the adjacent level degeneration following fusion by actually analyzing the sagittal balance. This is quite an important kind of diagram to analyze the vector forces that happen in the spine. So you can see that's, say for example, this is L5 and then you have the S1 and there's a particular angle at which the L5 S1 is. It could be, this is normal, yeah? So it's kind of nearly 45 degrees. So this angle and this angle are same. Here the angle is a bit more and here the angle is a bit less. So if you imagine this is the weight of the spinal column going through, you can divide it into 2 vectors, anterior vector and a vector going in that direction. This is balanced. So the discs and the facet joints are able to take this force as long as your spine is in this angle. The moment it becomes this way, this vector force becomes stronger than this vector force, and therefore this pulls the vertebrae forward, and so the facets start degenerating. If it goes the other way, then this vector becomes bigger and the forces start going through the disc and the disc start degenerating. So if you are right in the middle, you will be absolutely fine. Few degrees here and your facets will start going. Few degrees there and your discs will start going. So this is, invariably it will start off with either the disc or the facets, but once the degeneration of the disc progresses, then the facets don't have a choice. As the level of the height of the disc goes down, then the facet ligaments, they become closer and then they start degenerating. But that's a secondary phenomenon to the discs getting degenerated. And similarly, vice versa, when this happens, as the facet degenerate, the vertebrae will start moving forward. Then the kind of discs will also start, because they start pulling apart a bit and the disc will start degenerating. But you will notice whenever you see degenerate spine, it's either predominantly discogenic or it's predominantly fascicogenic. So the combination happens in the later stage, yeah? But it's invariably one is leading to the other. Now spondylolisthesis obviously is forward slip of the vertebrae, and you can use sagittal balance to actually classify the spine. So I'll just go to the classification. So that's how you classify spondylolisthesis. It's low grade, high grade, and depending upon the PI. So type 1 is PI less than 45 degrees, type 2 is PI 45 to 60 degrees, type 3 is PI greater than 60. High grade is type 4 and type 5 and type 6. So here the pelvis is balanced. Here the spine is balanced, but the pelvis is not balanced, and here the spine and pelvis both are unbalanced. So type 5 and type 6, they invariably need fixing, and type 6 will also need yanking back. Because so not only just fix the spine, but you also need to pull the spondylolisthesis back. Because all of the others you don't necessarily need to pull them back. These type invariably won't progress, even though they still cause backache, but they won't progress, so they can be left alone. So it's useful to kind of use sagittal balance and the PI angles to assess what kind of spondylolisthesis. So these are the kind of 6 types of spondylolisthesis. So this one needs surgery. This one will need surgery, not only fixation but also pulling back to reduce the retrolisthesis, the spondylolisthesis. Right, now the other advantage of doing sagittal balance is to look at the pattern of what is going wrong. Yeah? And that classification includes cervical kyphosis, thoracic kyphosis, thoracolumbar kyphosis, lumbar kyphosis, and global kyphosis and pelvic kyphosis. So I'll just show you an example of all of these. So this is lumbar kyphosis. So you can see, for sagittal balance you do a whole spine. So you do a spine using either the EOS system, which is like the computed radiograph which goes all the way like that with the patient standing, or you do multiple radiographs and you stitch them up digitally. So once you have the whole spine, you can see the lumbar spine is kyphotic. Yeah? It's lost its lordosis. You can see the dorsal spine is compensating by straightening. It's not bent. Yeah? So that's a compensatory mechanism. And the knees are bent. Because this also reached a limit of its compensation. Then the knees started bending, then that also couldn't compensate. So now all compensatory mechanisms are finished. The spine starts degenerating and a lot of backache. Yeah? So what you need to do is you need to fix the lumbar spine, but you also need to get the sagittal balance back. So you can actually measure how much forward this has gone and how much is the compensatory mechanism. So you add the angle of the plumb line which has gone forward plus the compensatory. So this excess, the reduction of the dorsal kyphosis, you have to measure that, and you have to see how much are the knees bent. And you add that also to it, that gives you the exact figure of what needs to be done to sort this. Now how do you sort it? So obviously you fix the spine, but just fixing the spine is going to no good. If you just fix the spine, it will still stay the same and the sagittal balance is not reduced. So you need to do osteotomy. So you need to do lumbar osteotomies, either Smith-Peterson, or there are 2 or 3 different types of osteotomy. Each osteotomy gives a particular degree. So you get a correction of 10 degrees from Smith-Peterson and you get 30 degrees from another osteotomy. So once you have told the surgeons exactly how much needs to be sorted, then they decide how much osteotomy. So this has been corrected by a osteotomy plus lumbar fixation. Because the problem is only in the lumbar spine. So here the only mechanism he has is pelvic retroversion and bending the knees and cervical lordosis. So because to keep looking straight ahead, so he'll bend his knees and he'll look like this. So he'll create a lordosis in his spine because his dorsal spine and lumbar spine are both deformities. So the whole deformity is extending from there to there. Now this won't get sorted by just doing what we did in the last patient. For this patient, first of all, you need to correct the angle, but then all of this needs to be fixed. So the dorsal and the lumbar spine. So that's where the pattern of the abnormality helps in deciding what surgery and what level would be best. Now this is lower lumbar deformity. So the deformity is only at the lumbar level. So you can see there's loss of lordosis. I've calculated the lordosis there. The total lordosis, lumbar lordosis, is about 70 degrees, out of which 30% of the lordosis is here and the rest of it is here. Yeah? So you can see the lordosis has actually gone down here, but there's okay amount of lordosis in the lumbar spine. So the problem is only in the lower lumbar spine. So what you can do is invariably it's osteoporotic or traumatic fractures which lead to a dorsal lumbar kyphosis, you can see, or adolescent kyphosis, which then later on in life it starts looking like this. So you can see the problem is in the dorsal spine. The lumbar spine has become excessively lordotic. So that's a compensatory mechanism. Yeah? That's not the problem. So the problem is not there, the problem is there. Yeah? So you don't need to do anything there. This is just a compensatory mechanism. The moment you sort this, the body will automatically reduce the lordosis. But you need to straighten that out. So again, we calculate the angle for the surgeons, how much to straighten out, and they'll have to do osteotomies here and fix the whole of the dorsal spine. Thoraco-junction lumbar kyphosis, so that's just, the problem is only there. There's no problem there. This you can see is a compensatory mechanism. This is also a compensatory mechanism. And the problem is just at the thoracolumbar junction. probably from an osteoporotic compression fracture which has led to the kyphosis and the abnormal of the imbalance of the sciatic balance. So all you need to do is sort this here, put a cage to jack up the anterior distance, and that will sort it. Cervical kyphosis. So some patients you notice that's how they kind of walk. They just can't lift their head up. They're looking on the floor because of the very severe cervical kyphosis. Yeah. So that's a deformity. So the body is trying to compensate by increasing the lumbar lordosis because the head can't go up. So using the lumbar spine.
I think what we have just demonstrated tells me why some patients don't do that. We look at the scan, they say there's a bit of bulge here, facet kyphosis, so we just go and fix the area without looking at the angles. And they come back very unhappy. So this is the reason why. And those of you who have seen this will advise your surgeons to look at the angles, balance, and check it properly. Because literally, screws and the rods are just put there to hold, and then a year or two they come back with another level problem. It's common. It's very common. Right, that's fantastic. Any questions?
Thanks so much. This probably has been the highlight for me today because we have quite a lot of low back pain in the country, and management is unsatisfactory. But I think with this, I'm getting an idea. In fact, I'm going to propose to the residents, particularly if you're going to do the fellowship. We start even now. Why is it that we have so much low back pain in the country? And I'm sure you've looked at the number of x-rays people are requesting. Low back pain, that is how we write. Would it be possible, a group of you, or at least individually, to really come up and look into it? These calculations, something else, and I'm sure you should be able to do something like that. Ash, I want to ask, we have quite a lot of back pain. Would you think this is part of the problem? For instance, if you look at globally how people do their farming things, you have people with hoes, implements which they really are virtually vertical whilst digging the ground. But those that we have, maybe 3 feet, and everybody has to keep going down out there. I'm not sure whether this may have any bearing on it.
So, I also don't know what the answer is. In terms of backache, I think it's universal. Like, I've been giving this talk lots of places, and in UK also I talk about sciatic balance. And I ask in the audience normally, how many of you have had low backache? Sometime or the other in your life. And nearly all the hands go up. So unfortunately, I think the human body is designed in such a way that back is going to be a problem because of the intricate balance that it has to undertake. So it may or may not necessarily be occupational. I think it's just the biology of the human body. So it's extremely common in I think all countries. We did a study back in India when I was in India, and we thought the same thing, that maybe excessive work. So in India, in Delhi, in railway stations we have coolies. These are guys who put very heavy weights on their head, their arms and shoulders. And you may have seen, if you've gone to Delhi, the big suitcases, like 3, 4, sometimes even 5 suitcases on their head.
You do the same thing here.
Yeah, so I've seen the ladies with the heavy weights on their head, but these are like really heavy big suitcases. We thought their cervical spines would be knocked up. Yeah, they would be, and we did a study of 100, this thing, we got them to volunteer to do X-rays, and they have such fantastic cervical spines.
Well, I think the muscles were so well developed and they were so used to this thing. So I don't know how it works, but it's not necessarily occupational, right?
Any more?
My question is probably basic, but something I've struggled with, something I've asked my bosses about. And I want your opinion on that. Measuring lumbar lordosis, where how you measure it first of all, and what is normal and what is hyperlordosis. Whether there are angles or just eyeballing it, to tell which is which.
So there is a figure for lumbar lordosis. Normally it is measured by drawing. So you can use the cob angle instrument on any of your machines, and you draw a line parallel to the L1, L2 level disc and the L5, S1 disc. And the angle between these two lines is the total lumbar lordosis. The total lumbar lordosis is divided into two bits. One is the upper lumbar lordosis and the lower lumbar lordosis. The lower lumbar lordosis is L4, L5 and L5, S1. And that's actually the more important one than the upper lumbar lordosis. The total figure is 50 degrees, but there's a kind of variation, so plus minus 10 degrees, out of which 30% of the lordosis is the lower lumbar lordosis, and the rest of it is the upper lumbar lordosis. So you can measure each segment individually, or you can even eyeball it. So once you've been doing it for a long time, then by just by looking at it, you'll be able to say, but when you measure it, you'll see, oh yes, there is hyperlordosis. But the important thing to remember is, hyperlordosis, the problem is not in the lumbar spine. That's just a compensatory mechanism. Yeah? The problem is somewhere else. Most likely the problem is in the dorsal spine. The dorsal spines become more kyphotic, so the lumbar spine is becoming more lordotic. Yeah? So the hyperlordosis in the lumbar spine is not the problem. That's just a compensatory
Device by giving them thrombolysis, which is a drug which is used to dissolve the clots and therefore return the blood supply to that area of the brain. Now, the vast majority of the strokes that we see in the UK are middle cerebral artery territory. So you can see there's a dot sign just here. Now, a high attenuation area within the middle cerebral artery. That's within the first branch of the middle cerebral artery, so M1. If we see a patient that has this type of scan and we know the time of onset, then we're able to treat these patients in two ways. As I say, by giving that actylase, the thrombolysis agent, to dissolve the clot. Now, the other method that we've got is to physically remove the clots, and that's done through a process called thrombectomy. And essentially, we put a catheter into the middle cerebral artery, and we suck out, or we physically remove that clot by pulling it. And there's a little device that can either burrow into the clot to allow us to pull it out, or almost like a vacuum cleaner that we put the catheter tip onto the clot, and then we suck out that area. And these patients have incredible resolution of symptoms if you're able to get to them quick enough. We've had patients that come in with very, very, very severe strokes, so can't move the whole of one side of the body, complete hemiparesis. They walk in, they come in an ambulance about as sick as you can get, and we have them walking out the following day. So this is a procedure which is incredibly important. Now, at West Herts, we're able to extend that period of time by doing a few different types of imaging. I'll explain that as we go along. So, I am going to rush through a few of these because I know we're a little bit pressed for time and this isn't all that interesting. So we're able to quantify how severe a stroke is by using this NIHS stroke score. Essentially, you can Google this. It's a very easy process to calculate how severe that stroke is. Once we have that figure, any treatment that we do to the patient, we're able to compare the initial National Institute of Health stroke score against their post-treatment score. And that's an important measure to work out whether or not we've been of any benefit. So when do we give thrombolysis? So the stroke needs to be reasonably significant. because the drug that we're giving can cause a hemorrhage. So, maybe 2% of the population that we give this drug to will have a negative effect and actually bleed. And the figure is slightly increased when we're talking about thrombectomy, because it's possible to actually put the catheter straight through the middle of the cerebral artery, and that's often fatal. So the patient has to have a significant enough NIH stroke score to warrant us doing this intervention, and there needs to be no contraindications. So if the patient's anticoagulated, it may well be that we're not able to give them another very aggressive anticoagulation on top, but perhaps they're still a candidate for thrombectomy. When we do a thrombectomy, the stroke-like symptoms need to be even more significant than a patient that would be a candidate for thrombolysis. So NIH of 6+, so they're really seriously disabled from this. Under normal circumstances, we need to know the time of onset of the stroke, and it needs to be within 4.5 hours. Again, when you get over 4.5 hours, normally the brain is at significant risk of permanent damage anyway. So if you are able to reperfuse the brain, it's possible that the patient will have a reperfusion injury and bleed, and thus end up in a worse state than they were originally. So what can we do in radiology? Well, we get these patients in as quickly as we physically can, and we do an unenhanced brain scan. And that is the most important piece of information, because we can determine whether or not they have a hemorrhage, or whether or not we can see permanent damage which is already established. Early changes are normally seen within 4 hours. However, some patients' brains will last significantly longer, and it may be that they have a good collateral circulation. If you go to most hospitals in the UK, that's all we do for them. If they're outside of that 4 or 4.5 hour window, we don't do any more. But at West Herts, we have a technique called perfusion scanning, which I'm going to tell you guys a wee bit about. And it's possible that you guys can use CT perfusion, and indeed some of the local hospitals I know have the software. I'm not sure about down here. The Ridge certainly has the software. It has the protocols because I set it up. But it's whether or not you can get the patient there quick enough and then have someone that's prepared to treat the patient on the basis of these images. So, here we go. This is our clot sitting in the middle cerebral artery. We can give thrombolysis to dissolve that, or thrombectomy to physically pull it out. So, have a look at that image. Can anyone tell me what's going on? This is going to be a bit interactive. I know we're just after lunch, but hopefully you guys have seen enough brain scans to be able to show me what the issue is.
I know what is normal and what is abnormal. This is obvious, but
okay.
I'm not sure this one.
So that's the one, that's the middle cerebral artery.
Yeah.
The calcification that you see in the choroid plexus is normal. Yeah. So we can see that that is a first branch of the middle cerebral artery clot. We can also see, if we compare the two sides of the brain, we can see that we've got edema, early edema forming on that side. We've lost the sulfur pattern. So, all of this is really significant. Normally, if you can see a reduction in density of the brain, things are already too late. But early changes like this, actually it's definitely possible to reperfuse this brain, either by giving the drug to dissolve the clot, or by physically pulling it out. When we get to about 6 to 8 hours, we do notice that reduction in density here. Okay, so this brain's already trashed. There's nothing that we can do to reperfuse this. So, and this will probably be a lot of the brains that you see if the patient's coming in, 8 to 12 sort of plus hours on. You'll already see this damage. And if we flip through, that's at about 12 hours. That's at 24. That's at 2 days, 4 days, and even older. Okay, so if we've got damage like this, there's nothing we can do to the brain. Okay? So I'm going to run through a few differential diagnoses because hopefully you guys will be able to pick most of these up. And again, because it is after lunch, I'm going to ask you to point out what's going on. So have a look at this image and I'll pick on radiologists. So what's going on here?
collections throughout. There's also hyperdensity in the region of the folks is thickened here. So extensive frontoparietal subdural collection here and then the folks region as well. So it's an acute subdural collection.
Right. Anything else?
It's causing placement and displacement of the underlying brain parenchyma.
Right, sorry.
Then, mass effects. Yes, mass effects.
We've got a mass effect as well.
There.
So you can see that we've had a head injury on this side. On this side here. And this is our coup injury. We've also got a contra-coup injury on there. Can you see that? Yeah, it's a little bit subtle and it's the wrong window really. So we've got a little bit of subdural blood on the opposite side there. So certainly in the UK, this patient will be going for neurosurgery. You can keep on with that because you're So is this an acute bleed or chronic? Okay. And how do you know that?
The density.
Okay. And so what is it within that area of the brain that's giving us that density? Why is the blood that dense? What are you imaging that's giving you that density?
So at this level, it's the cells, the red cell, and the red blood cells.
And within the red blood cells?
The iron.
Okay, so it's the hemoglobin. Great. So when we get to several weeks old, and this is the same patient, what's going on here? So yeah, this is a subacute or sort of a few weeks old, and you can see that these are quite difficult to spot sometimes, and actually depending on the correct the compression algorithm that you use to send this to your external reporters, it can make it very difficult to see. So this is why certainly in the UK we will always send our images in a DICOM format because you're able to modify them much better. If you start to JPEG the images, you lose that resolution and potentially you risk missing quite large hemorrhages. And I've seen it done. In the UK, sometimes for the sake of speed, a member of the accident emergency staff will take a picture on his phone and send it across to the neurosurgeons. But there's, the image has been compressed, first off because they're looking at it on a non-diagnostic screen, and secondly because they've taken a photo. Then there's a compression algorithm in WhatsApp as well, so by the time it reaches the other end, they might not be able to see what's going on. So it's just very important that when you are looking at these images, you're doing so in the correct format.
Nick, you gave IV contrast.
No.
Did you give IV?
No IV contrast on this. You can see that we've got a little bit of acute blood still within the falx. I think there's a little bit of residual hemorrhage. Yeah. And so this is actually a different placement, clearly. So when we get into the several weeks down the line, the density reduces even more. But it doesn't mean to say that you don't end up with an increasing amount of edema. And in this case, a couple of weeks down the line, the patient's got significant edema. This patient needed to go for neurosurgery as well. They were reasonably young. There's an awful lot of compression there. So this is a reasonably recent unenhanced CT brain that we did. This was taken during the middle of COVID in the UK. Can anyone see what's going on or any suggestions?
There is this hyperdense collection along the midline. You see it's there. So, because of where, especially this one is, we know that the sagittal sinus is there, right? So it could represent a thrombus within the sagittal sinus.
Yeah, so this is a CVSD, so cerebral venous sinus thrombosis. And we saw this in patients that have been vaccinated, and we also saw this in patients that had COVID. In reality, the numbers weren't huge, and if you think we're probably scanning 60 or 70 grains a day, we had 4 patients that had CVST, 2 of them had been vaccinated, and 2 of them just had COVID. It's another one of those diagnoses that we need to sort of chuck in, but we don't commonly see. We do see a few a year, and actually we can spot these on the borderline analysis as well. But obviously the gold standard is go ahead and obviously to deal with it, and we'll really pinch it for you.
So looking at an enhanced axial CT scan of the brain as well, we see hyperdense densities within the tubercellular systems, in the ambient and interpedancular systems, as well as some SOSA as well. I mean, these are represent acute subarachnoid hemorrhage. Yeah, okay. Also hyperdensity within the fourth ventricles, maybe some intraventricular extension of it.
I think that we probably will pause the program now, or you want us to continue? Where is, yes, where do you plan this room? Yeah, it will be here, there. Yes, and you projected here, so all of us cannot go in there, so one batch can go in, the 2 batches can sit here and watch, and then take turns. Most of them are sound birds. A few will be reviewed without any CT guided. Any questions? We want to start on time. Probably 8:30. And we hope to finish 8:30 tomorrow. Traffic. Friday we will still decide what is left behind. We take what we do on Friday. Any additional points to make? So we need a patient room where they will sit and wait. Yeah, maybe some of them may have given tea, maybe a waiting for too long. Or kinky, if you waited extra hour.
Are there potential injections?
Yes. Yeah, probably about 8 or 10.
So we might need a
kind of a table. Yes. You need a table or a bed or so the patient can lie on. Everything here. Excellent. Okay. You have some candle.
Yeah.
We have some candle for.
Yeah, in fact we got everything. So
you got everything.
Apart from the table, we can probably have everything.
Thanks for coming. See you in the morning.
Right. By giving them thrombolysis, which is a drug which is used to dissolve the clots and therefore return the blood supply to that area of the brain. Now, the vast majority of the strokes that we see in the UK are middle cerebral artery territory. So you can see there's a dot sign just here. Now, a high attenuation area within the middle cerebral artery, that's within the first branch of the middle cerebral artery, so M1. If we see a patient that has this type of scan and we know the time of onset, then we're able to treat these patients in 2 ways. As I say, by giving that actylase, the thrombolysis agent, to dissolve the clot. Now, the other method that we've got is to physically remove the clots, and that's done through a process called thrombectomy. And essentially, we put a catheter into the middle cerebral artery, and we suck out, or we physically remove that clot by pulling it. And there's a little device that can either burrow into the clot to allow us to pull it out, or almost like a vacuum cleaner that we put the catheter tip onto the clot, and then we suck out that area. And these patients have incredible resolution of symptoms if you're able to get to them quick enough. We've had patients that come in with very, very, very severe strokes, so can't move the whole of one side of the body, complete hemiparesis. They come in an ambulance about as sick as you can get, and we have them walking out the following day. So this is a procedure which is incredibly important. Now, at West Herts, we're able to extend that period of time by doing a few different types of imaging. I'll explain that as we go along. So, I am going to rush through a few of these because I know we're a little bit pressed for time and this isn't all that interesting. So we're able to quantify how severe a stroke is by using this NIHS stroke score. Essentially, you can Google this. It's a very easy process to calculate how severe that stroke is. Once we have that figure, any treatment that we do to the patient, we're able to compare the initial National Institute of Health stroke score against their post-treatment score. And that's an important measure to work out whether or not we've been of any benefit. So when do we give thrombolysis? So the stroke needs to be reasonably significant because the drug that we're giving can cause a hemorrhage. So maybe 2% of the population that we give this drug to will have a negative effect and actually bleed. And the figure is slightly increased when we're talking about thrombectomy because it's possible to actually put the catheter straight through the middle of the cerebral artery, and that's often fatal. So the patient has to have a significant enough NIH stroke score to warrant us doing this intervention, and there needs to be no contraindications. So if the patient's anticoagulated, it may well be that we're not able to give them another very aggressive anticoagulation on top, but perhaps they're still a candidate for thrombectomy. When we do a thrombectomy, the stroke-like symptoms need to be even more significant than a patient that would be a candidate for thrombolysis. So NIH of 6+, so they're really seriously disabled from this. Under normal circumstances, we need to know the time of onset of the stroke, and it needs to be within 4.5 hours. Again, when you get over 4.5 hours, normally the brain is at significant risk of permanent damage anyway. So if you are able to reperfuse the brain, it's possible that the patient will have a reperfusion injury and bleed, and thus end up in a worse state than they were originally. So what can we do in radiology? Well, we get these patients in as quickly as we physically can, and we do an unenhanced brain scan. And that is the most important piece of information because we can determine whether or not they have a hemorrhage or whether or not we can see permanent damage which is already established. Early changes are normally seen within 4 hours. However, some patients' brains will last significantly longer, and it may be that they have a good collateral circulation. If you go to most hospitals in the UK, that's all we do for them. If they're outside of that 4 or 4.5 hour window, we don't do any more. But at West Herts, we have a technique called perfusion scanning, which I'm going to tell you guys a wee bit about. And it's possible that you guys can use CT perfusion, and indeed some of the local hospitals I know have the software. I'm not sure about down here. The Ridge certainly has the software. It has the protocols because I set it up. But it's whether or not you can get the patient there quick enough and then have someone that's prepared to treat the patient on the basis of these these images. So, here we go. This is our clot sitting in the middle cerebral artery. We can give thrombolysis to dissolve that, or thrombectomy to physically pull it out. I'll jump ahead here. So, have a look at that image. Can anyone tell me what's going on? This is going to be a bit interactive. I know we're just after lunch, but hopefully you guys have seen enough brain scans to be able to show me what the issue is.
There is a plot.
What would you like to point out?
I know what is normal and what is abnormal. This is obvious, but
Okay.
I'm not sure this one.
So that's the one, that's the middle cerebral artery.
Yeah.
The calcification that you see in the choroid plexus is normal.
Yeah.
So we can see that that is a first branch of the middle cerebral artery clot. We can also see, if we compare the two sides of the brain, we can see that we've got edema, early edema forming on that side. We've lost the sulfur pattern. So, all of this is really significant. Normally, if you can see a reduction in density of the brain, things are already too late. But early changes like this, actually it's definitely possible to reperfuse this brain, either by giving the drug to dissolve the clot or by physically pulling it out. When we get to about 6 to 8 hours, we do notice that reduction in density here. Okay, so this brain's already trashed. There's nothing that we can do to reperfuse this. So, and this will probably be a lot of the brains that you see if the patient's coming in, 8 to 12 sort of plus hours on. You'll already see this damage. And if we flip through, that's at about 12 hours. That's at 24. That's at 2 days, 4 days, and even older. Okay, so if we've got damage like this, there's nothing we can do to the brain. Okay? So I'm going to run through a few differential diagnoses because hopefully you guys will be able to pick most of these up. And again, because it is after lunch, I'm going to ask you to point out what's going on. So have a look at this image and I'll pick on radiologists. So what's going on here?
non-enhanced ATLCT scan of the brain. Central surface body that we can see we have an extra ACL, hyperdense collection, subdural. There's also hyperdensity in the region of the forks is sticking here. So extensive frontal parietal subdural collection here and then the forks region as well. So it's an acute subdural collection.
Right. Anything else?
It's causing placement and displacement of the underlying brain parenchyma.
Right, so.
Mass effects. Yes, mass effects.
We've got a mass effect as well.
There.
So you can see that we've had a head injury on this side. On this side here. And this is our coup injury. We've also got a contra coup injury on there. Can you see that? Yeah, it's a little bit subtle and it's the wrong window really. But we've got a little bit of subdural blood on the opposite side there. So certainly in the UK, this patient will be going for neurosurgery. You can keep on with that because you're So is this an acute bleed or chronic? Okay. And how do you know that?
The density.
Okay. And so what is it within that area of the brain that's giving us that density? Why is the blood that dense? What are you imaging that's giving you that density?
So at this level, it's the cells, the red cell, and the red blood cells.
And within the red blood cells?
The iron.
Okay, so it's the hemoglobin. Great. So when we get to several weeks old, and this is the same patient, what's going on here? So yeah, this is a subacute or sort of a few weeks old, and you can see that these are quite difficult to spot sometimes, and actually depending on the compression algorithm that you use to send this to your external reporters, it can make it very difficult to see. So this is why certainly in the UK we will always send our images in a DICOM format, because you're able to modify them much better. If you start to JPEG the images, you lose that resolution, and potentially you risk missing quite large hemorrhages. And I've seen it done. In the UK, sometimes for the sake of speed, a member of the accident emergency staff will take a picture on his phone and send it across to the neurosurgeons. But there's, the image has been compressed, first off because they're looking at it on a non-diagnostic screen, and secondly because they've taken a photo. Then there's a compression algorithm in WhatsApp as well, so by the time it reaches the other end, they might not be able to see what's going on. So it's just very important that when you are looking at these images, you're doing so in the correct format.
Nick, you gave IV contrast.
No.
Did you give IV?
No IV contrast in this. You can see that we've got a little bit of acute blood still within the falx. I think there's a little bit of residual hemorrhage. Yeah. And so this is actually a different placement, clearly. So when we get into the several weeks down the line, the density reduces even more. But it doesn't mean to say that you don't end up with an increasing amount of edema. And in this case, a couple of weeks down the line, the patient's got significant edema. This patient needed to go for neurosurgery as well. They were reasonably young. There's an awful lot of compression there. So this is a reasonably recent unenhanced CT brain that we did. This was taken during the middle of COVID in the UK. Can anyone see what's going on or any suggestions?
Because of where, especially this one is, we know that the sagittal sinus is there, right? So it could represent a thrombus within the sagittal sinus.
Yeah, so this is a CVSD, so cerebral venous sinus thrombosis. And we saw this in patients that have been vaccinated, and we also saw this in patients that had COVID. In reality, the numbers weren't huge, and if you think we're probably scanning 60 or 70 brains a day, we had 4 patients that had CVST. 2 of them had been vaccinated, and 2 of them just had COVID. But it's another one of those diagnoses that we need to sort of chuck in. But we don't commonly see. We do see a few a year, and actually we can spot these on the borderline analysis as well. And obviously the gold standard is go ahead and obviously to do a really good job.
So looking at unenhanced axial CT scan of the brain as well, we see hyperdense densities within the tubercellular systems, in the ambient and interpeduncular systems, as well as some sulci as well. I mean, these are represent acute subarachnoid hemorrhage. Yeah. Okay. Also hyperdensity within the fourth ventricles, maybe some intraventricular extension of the bleed.
Yeah. Not a lot to add to that.
I think that we probably pause the program now, or you want us to continue? Where is, yes, where do you plan? This room. Yeah, it will be here, there. Yes, and you projected here, so all of us cannot go in there, so one batch can go in, the two batches can sit here and watch, and then take turns. Most of them are sound birds. A few will be reviewed without any CT guided. Any questions? We want to start on time. Probably 8:30. And we hope to finish 8:30 tomorrow. Traffic. Friday we'll still decide what is left behind. We take what we do on Friday. Any additional points to make? So we need a patient room where they will sit and wait. Yeah, maybe some of them may have given tea, maybe a waiting for too long. Or kinky, if we waited extra hour.
Are there potential injections?
Yes. Yeah, probably about 8 or 10.
So we might need a
kind of a table.
or something.
Yes. You need a table or a bed or so the patient can lie on. Everything here. Excellent. Okay. You have some candle.
Yeah.
We have some candle for.
Yeah, in fact, we got everything. So
You got everything.
apart from the table, we can probably have it.
Thanks for coming. See you in the morning. Bye-bye. Not everybody wants to have a question.
19?
You choose this color yourself.
It's a shampoo I use.
Gertrude, do you mind if I talk aloud for the benefit of the students as I scan you? Right, so for shoulder scanning, that's a pretty nice position. There are two ways of doing it. Doing it from the back of the patient or with the patient facing you and doing it from the front. The other way around, I find it's harder on your shoulder. Yeah. This way it's slightly higher. Easier on your shoulder because if you're doing lots of scans, you're doing about 10-15 scans. By the end of it, your shoulder starts aching. So if you're doing it this way, it's very easy on your shoulder. So first position is palm facing up, just like that, and a little bit of the, I think I'll just speak up.
The others in the room, they're trying to listen. And
right, okay. Is it working?
Yeah, it's working.
It's working. Can you guys hear us? Yeah, it's working.
I just need to bring it
Can everybody see?
So that's the first thing that transfers axial to the front of the shoulder. And you can see the bicipital groove. Yeah, that's the bicipital groove there. And that little structure there is the long head of biceps. And you can see there's quite a bit of fluid along the long. So straight away it's telling me she has some trouble. The fluid in the long head of biceps invariably will happen due to three reasons. One is there is inflammation of the biceps tendon itself. Two, there is trouble in the glenohumeral articulation because the glenohumeral joint communicates with the long head of biceps tendon sheath. So if there is a fusion in the shoulder joint, that will pop out and you'll see it along the long head of biceps. And third is frozen shoulder. So in frozen shoulder, what happens, the capsule becomes very tight, so the normal fluid inside the glenohumeral joint pops out. So you start seeing fluid along the long head. And lastly, if you have a rotator cuff tear, then again you get a reactive fluid in the long head of biceps tendon sheath. So her biceps tendon itself looks okay, but the fact that there's fluid, there's something else going on. So when we go further, we'll try and see what's going on. So I go a little bit more medially, axially, and that's the medial lip of the bicipital groove. So this tendon here is your subscapular. Yeah? And you can see that it's fine, there is no tear, there is no calcification, it's not inflamed. That's your deltoid muscle, which invariably always looks fine, so that's all okay. So over the biceps, with fluid in the tendon sheath, and the subscapular. Yeah. Okay, so now the next step is to try and look at the supraspinatus tendon. I think it would be nice if we had a headphone with a mic.
We have one here.
Please bring it.
Clip on mic.
Yeah, clip on mic.
People can't hear you at all.
Do you have it?
No, I think I the one I put at the back, but it's not working.
It's not working.
So let someone hold it for you.
Hello, testing.
It has to be close to
Right, so Gertrude, now I need your arm going behind you as if you're putting it in your hip pocket. So if you just skid forwards a little bit in the chair, so just skid forwards.
Fantastic.
That's lovely. And then arm behind you. I know this is going to be uncomfortable. See how far you can manage. Okay, that's brilliant. Excellent job. Just hold it there. So now we're heading for the supraspinatus tendon. So you can see the humeral head, the white contour there, and the tendon on the top is the supraspinatus tendon. And that's in a modified coronal position. So I go from the front all the way up to the back. And it looks okay. So it's not torn, there's no calcification. It's a bit swollen. There's a little bit of fluid in the subacromial nephroid dorsal. So I just freeze that there. So can you see that line there? Yeah. Maybe for the benefit of people outside. So that's the subacromial nephroid dorsal. So normally this subacromial nephroid dorsal is paper thin. But you can see it's definitely much thicker than you would expect. And as you come back, that's your infraspinatus tendon. Just need to increase the gain a bit. Maybe drop the frequency a bit. So maybe drop the frequency a bit.
that one.
Yeah. So that's the infraspinatus tendon, and that's again fine. No calcification, no overt tendinosis, no tears. Then I'm heading towards the AC joint. So that's the AC joint, and you can see there's a lot of capsular hypertrophy. So yeah, and you can see the clavicular side and the acromial side and the capsule on the top, and a little bit of the bony irregularity on the edges. So it's clearly problematic. Now, seeing capsular hypertrophy in the ACJ is very common. Everybody after the age of 40. So that doesn't necessarily mean that it's symptomatic. So the important thing is to ask the patient. Now, is this zone where I'm pressing? It's tender, yeah? So it's clearly the AC joint is symptomatic. So I think she should benefit from AC joint injection. Okay, you can relax it back again on your lap. Sorry about this. It's an awkward position. Palm facing up one more time. Now when I ask you, when I say in, I want you to go in all the way like that. Yeah? When I say back in the middle, then I want you to come back in the middle. And when I say out, then I want you to come out as much as you can. Yeah? So we'll start with in the middle there. Is that okay? So again, back again on the long head of biceps and the subscapular. So I'm just assessing the subscapular slightly better in this. I'm trying to see if the long head of biceps subluxates. So normally it sits in the bicipital groove, but occasionally it will pop out. So it could jump medially there. If the subscapular is torn, then it will go into the joint. It will fall into the cranial joint. But if the subscapular is intact, then it will go superficial to the subscapular. And sometimes it might just be a little perched on the bicipital groove. So it's not completely dislocated, but it's just subluxed. So at the moment it's fine. But when I make her move her arm outside with external rotation, it might pop out. So we just want to see if there's any subluxation on dynamic movement. Again, the fluid around the long head of biceps, that's nicely seen. Yeah. Okay, good. Now can I have you take your arm in, all the way in, please? That's lovely. And back in the middle. And all the way out, please.
This stays like that.
Yeah. Okay, back in the middle again. Yeah, okay, that's perfect. And one more time out, please. That's brilliant. Excellent job. So the subscapular is fine. The long head of biceps is not popping out, so that is fine. And back in the middle again. Thank you.
Right, so she has a bit of bursitis and the ACJ is symptomatic. So I think she'll probably benefit from 2 injections, one in the subacute bursa and the other one in the ACJ. So it will unfortunately need kind of 2 separate needles, but it's quick and fast, so we shouldn't do that. So Gertrude, I think you benefit from 2 injections in your shoulder. So you have a bit of inflammation in your bursa, which explains the pain kind of going down the arm, why also sometimes you might be getting pain in the night when you move on to that side. And then you have trouble in this joint here on the top. Yeah? So with these steroids, you can calm the inflammation and hopefully that should settle things for you. Good news is that you haven't torn anything, all your tendons are intact. Yeah? So hopefully this should do the trick. Physio after this should also be helpful. But leave physio for a week to 10 days. Let this bed in first, then after that, get some physio as well as natural health, yeah, with the exercises. Just for 48 hours, it can flare up a little. It can be a bit sore for 48 hours. So don't get worried. Just take paracetamol, ibuprofen, whatever suits you. Then this should start kicking in by day 3, day 4. And the effect keeps coming in for about 4 weeks. Okay? So it's not like a switch where suddenly everything will become better. But gradually it gets better over 4 to 6 weeks. Yeah? And then maybe if you can see for Paul in about 4 to 6 weeks just to see how this is going on. Yeah? Are you happy with the plan? Okay, brilliant. So for the injection, I'll get you lying down. I'll start with the local anesthetic for both of them. The local does sting a little, just like a bee sting. Once it starts taking effect, it should be done. Have you had a bee sting? So here's your chance to find out what a bee sting is.
Right, we're going to get you onto this.
So let's just first get the jelly off.
Any questions? Any of you with a shoulder problem?
Okay, so you can use the step there. So head there, feet on the other end. Just flat on your back.
I've had the injection before. Yeah.
So with injections, have you done any injections under Axon? Okay, so just very briefly to explain how we can manage to keep seeing the needle. So there are essentially 2 techniques. So obviously, imagine there's a blade coming out of this thing. So when you're cutting in, what you're seeing is a slice, yeah? And you can keep imagining it's a blade, yeah? So if you put the probe in like that, that's what you're scanning in the application. So to be able to see the needle, you have to be in the plane of that blade. So your needle will come from the side. And obviously on the probe, there's a mark which tells you which side. So that little mark tells me that is this side, yeah? So if my probe's like this, and I'm putting my needle in there like this, then it's in plane, yeah? So you'll see my needle coming from here. If I put it from the other side, you'll see my needle coming in from there. Yeah? So you have to be kind of absolutely sure that, because sometimes you forget where your mark is, and you're expecting the needle to come from there, but it's actually coming from there. And you keep looking, where's my needle, where's my needle? The needle's actually coming from the other side. Yeah? So if the plane is slightly, off from the blade, you won't see the needle. So if the needle's a bit like this, you won't see it. If the needle's a bit like this, you won't see it. It has to be absolutely in the plane. So to begin with, when you practice, just keep the probe straight, because if you keep it at an angle, then your needle also has to kind of take that same angle. So if you keep it absolutely straight, just practice maybe even on the breast or something, and keep seeing your needle that way. Then angle the probe a bit. Now, if my probe's like this, it's the slice is there, yeah? So the plane is there. So the needle has to be in the same plane. Yeah? So I won't see it if I put my needle like this. But the other technique is to come perpendicular to the slice. So if you come perpendicular to the slice, and they quite often anesthetists do it, I never do it because you don't see the needle very well. So that's to kind of put in lines and things, yeah? So if you see a vein and then you know the vein is in line, so you come in from there, you don't see the needle, don't see the needle, don't see the needle, and when it comes in line, you see it as a dot. Yeah? And then if it's in the vein, then you know it's in the right place, and then you just take the cannula out and then push it. So anesthetists like doing this because this is a bit tricky. Your angle has to be absolutely same. So here the angle doesn't matter, but at some point the needle will come in this line. But it will be a dot, it won't be a line. Here you can actually see the line, so you know where the tip is. Here you don't know where the tip is. It It could be further or it could be back, so you're not sure where the pin is. Right, so now we're going to do 2 injections, the bursa first and then we'll do the AC joint. So give me a Dual-Lock 5 and Dual-Lock 2 cc. Give me 2 cc's. Then we have a few. So orange needle, 2 orange needles, and 1 maybe a white needle just to draw, because the drawing up needle, so the red one's got a filter in it, so cannot go through it. Just show me the red one, does it have a filter? Yeah, that has a filter in it, so the cannot go through it. So we do the white needle now. The risk with the white needle is I might put the needle.
Consent for
So, and give me 1 more cc. White needle, 2 oranges. Yeah. So Gertrude, I'm going to just pop some sterile tissue under your shoulders. If you just lift it up for me, you can put it back down. And I need your arm by your side. And I need your palm facing up when I come to it. For the moment, just relax it. Maybe if you move a little bit to the edge there, so there's a bit more space to park your arm. That's it. And I'm just cleaning the area, so I'm going to feel some folds, alpha coming out. Sorry, this is a bit cold. White needle. Only one white needle just to draw. Yeah. And is that it? Yeah. So you can do this one. That's also European one also. So, yeah, normally for the anesthetic, I'll use 1% lidocaine or lignocaine, and keep holding it, just give me a bit more. And when you're in the bursa or in the AC joint, I inject a combination, so it's a combination of lignocaine and Kenalog. Keep holding. The AC joint has very little space in it, so I use very little lignocaine because the space are there. So this is for the bursa. And give me 2 Kenalogs. So Kenalog is triamcinolone, which is a long-acting steroid. It's very particulate, so it gets absorbed slowly. So it's pretty good for musculoskeletal users because it nearly acts like a slow release. Because it's particulate, so it doesn't get absorbed that quickly. It has a half-life of about 3 to 4 weeks, so it hangs around for a long time, yeah? So therefore it acts kind of slowly. The other one, obviously, you can also use is did I get it wrong? Little bit left.
So how many mils of Kenalog?
So 1 ml Kenalog, which contains 40 milligrams of triamcinolone, and 1 ml of lignocaine. So mix it. So it's like a cocktail, yeah. So it's a cocktail of Kenalog and lignocaine. Yeah. Now this one is for the AC joint. So I've used 0.5 mils of lignocaine because there isn't enough space. My AC joint is a bit degenerate, so it's more lax. So it might take, so if it's a younger patient, I might even reduce that, or sometimes even not even put any lignocaine. So the lignocaine that I use to get my needle to the point, that's the little bit that I'll inject.
But it's still 50-50%. The proportion is always 50% local anesthetic to 50% steroid. Is that correct?
No, not necessarily. So you could, for example, I was saying if the AC joint or CMC joint, which is such a small joint, then if you use lignocaine, you're wasting that space on lignocaine, which will just get absorbed and it won't do anything. So it's best to put as much Kenalog as you can put in. So like PIP joints, DIP joints, they're really small joints. Yeah? Even 1 ml of lignocaine Kenalog also finds trouble going in. So sometimes you end up only injecting half. So if you put lignocaine in there, then you're wasting that space on lignocaine rather than Kenalog, which is the drug which is actually doing the job. Yeah?
The advantage of lidocaine is that after injecting the patient, a few minutes can ask the patient questions. And the patient could say, oh, the pain is gone.
So it's a test, yeah? It's like a diagnostic test. So sometimes we'll just inject anesthetic, that's it, for a hip joint, but that's purely for as a test. It's not to kind of long-term relief. And then you give them a pain diary. So Chirocaine, which is the other anesthetic that we have, which is levobupivacaine, that's long-acting. That has a half-life of about 8 hours. Yeah? So we can use that to kind of do a test to see how well the pain is settled. And if the pain settled, then we know that's where the pain is coming from. So injections serve either a diagnostic purpose or a therapeutic purpose. So here it's more therapeutic. Yeah? So we're not that concerned how it will work straight away, but we hope that it will work over a period of time. So this is where it's not completely aseptic. It's just as because one I'm touching the code which is not sterile, but we don't really need to. And have a bit of this sterile jelly, just all the very because we don't have that much of it. So I mean leave that on these sides so that it's going to be
more gel.
So I don't know if you have sterile jelly.
Yeah, we do.
Good.
There's some here.
Right, so you're just going to feel some cold jelly coming on, and can I have your palm facing up now? That's thank you. So pleural head, supraspinatus tendon, and that's the bursa. So that's the space we need to be in. So my needle will come in from there, and I'm hoping to kind of get into that space. Once I'm in the space, the fluid kind of just flows in the bursa. So it will be one sharp scratch and then the little stinging sensation. Sorry about this, just the burning of the local, this testimony, just like the keys thing. Sorry, really so that's my needle coming now. So it will come through the bursa. And I can feel the lignocaine just flowing in that space. Yes? So I'm moving the right place. So just undo the syringe. And that's the one we are injecting in the bursa. You okay? You're doing really well. Good job. The needle can kind of sometimes puff out here. So I'm just making sure that my needle is still in the right place.
Can everyone see the screen?
You can feel it flowing quite nicely, and then you see the air. Can you feel a little bit of the air filling that space? So you don't see the fluid, but the space isn't that big. But then when the air goes, you can see it's all along the bursa. So you know you're in the right place. All done. Wasn't too bad? It was nothing? Yeah, see? So that's one done. Now I'm heading for the second spot, which is the AC joint. Yeah? Is that okay? Same routine again. I'll start with the local, which will sting a little, then it shouldn't be too bad. make sure you get the air out of the syringe, because if you inject air, you stop seeing on some, you lose your kind of window of
This
that's I'm cutting through it transversely. Yeah? I'm not going through the joints. You can see through both the acromion and the clavicle. But I need to get into the joint, so it's hard to get into the joint like this, because you get stuck in there. So what I do is I come the other way. So I actually I'm slicing through the joint. Yeah? So, and then I might come from here like this into the joint. So, and this here is a little bit of, you normally have crystals in the AC joint, which gives you that little bright space. That's actually fluid. Yeah? You might think it's bone, it's not bone. So that's bone, that's joint, and that's bone. Yeah? So I need to be in that plane, yeah? And that's my target, like a whitish area there, and then you will see the steroid filling that space. So now I need to come from here, so I can't do it like this. So what do I need to do? I need to change hands. So you need to be ambidextrous, yeah? So I need to scan with the left, and I need to inject with the right, yeah? Right, so now that's the back of the probe. So actually, the way I've held the probe, I'll be coming from here. So just to test, see, I'll press the skin a bit here. Can you see my finger there? Yeah. So I'm not coming from there, I'm actually coming from here. So it'll be one sharp scratch, and then the little stinging sensation. Sorry about this. Well done, okay. Good job. Just the burning of the local again. Just on the edge of the joint, and I'm hitting that bone, so I know I'm more laterally, yes? So I need to just hit it more and then I'll go through the joint. Yes, I mean, yeah. And then I'm injecting the fluid, you can see the little bit of the anesthetic that's gone in there. Now because this joint's inflamed when you inject, the anesthetic takes the pain sensation away, but it doesn't take the pressure sensation away. So it doesn't block pressure. So you still feel a bit of the discomfort from the pressure in the joint. So you're doing really well, Patrick. Excellent job. Now I'm going to inject in the joint. So it's an odd sensation of the pressure building in the joint. Yeah, you're doing really well. You okay? More pressure, and that's all done. That was a bit painful, wasn't it? Because it doesn't take the pressure sensation. When the bursa, it just glides. Yeah? But if you inject in the tendon, then the patient goes through the roof. So that's why. So there are lots of blind injections when people do this. Oh, it was so painful. It was so painful.
You see that too,
Wasn't
the
too
many
bad?
surgeons, eh? Only blind.
So you did really well. Excellent job. All done. All finished. Yeah? You okay? Excellent. Now we'll give you a sticking plaster. You okay with plasters? You're not allergic to plaster, are you? You won't believe it, some people are. When I ask people, most people laugh. Are you serious? People, give me one.
What do you do there?
Well, then we become cosmophore or don't do anything, so just keep it rest for a little. All done. Excellent job. So now we'll just let you come off. Are you feeling okay? Okay, so do one thing, we can help you up. You can hold on to my elbow. Just sit on the edge. Just sit on the edge and relax your feet. Get your bearings. Sometimes they get a vasovagal, yeah? And then they stand up and go, ooh, and then pop. That's why I do it lying down, because you can do it sitting as well. But 1 out of 10 sitting injections, the patient will be on the floor. So then you are kind of, for in the NHS, a lot of people work.
I have a question. Do you ever find a lot of fluid in the joint such that you would have to aspirate before you introduce?
Yeah, so it's not AC joints because they are small joints. Sometimes even AC joint might have, if it's infected or something, then you might aspirate. But knee joints, invariably there will be a lot of fluid, and it's useful to aspirate the fluid because the synovial fluid also has chemicals which create more inflammation. And the pressure itself causes pain. So aspirating, so if it's a knee joint, there's a lot of effusion, we'll first aspirate it to dryness as much as we can, and then inject the steroid. Hip joint effusion invariably isn't that much because it's a very tight joint. If it develops effusion, it invariably leaks into the psoas tendon sheath. So you will never find massive amounts of fluid in the hip joint, but in the knee joint, you get very large amounts of fluid. So that's probably one joint where you will aspirate before you inject. Shoulder joint, again, you hardly ever get massive amounts of fluid. So you just inject, you don't need to aspirate.
Fantastic. So,
Feeling okay? Okay, brilliant. So we'll let you change behind the screen, and then you'll be all free to go. Wasn't too bad, was it?
No.
And thank you so much.
Guys, good to hear
All of these students are going to benefit from this new volunteering.
Okay, so should we just get the microphone closer, or is it because you didn't get the context? Now it's your turn. Can we swap? So we'll get the patient ready, we'll do the consent.
She needs something
And then we'll
to check.
call. Okay.
No, we'll do that later. I'm one of the patients as well.
Oh.
We will sort you, don't worry.
I'm getting
the next group.
So I think this is a bit tedious.
Yes.
Can we get a phone?
Yeah.
Or a clip-on?
Someone clip on now, because it's better.
Because it's slightly hard when both my hands are
Crossing
busy.
and at the same time. It's a lot more pretty proper job. Thank you.
And if there isn't a patient, then we can get people to scan. So who is offered to volunteer. He's an actively heavy work. He's thin and skinny. You'd see everything. And then I can demonstrate fitting us now.
Shall we do that now? Because I think that
Yeah. No, you will. Nice to meet you. I like your hair. Very nice. Have you had anything else done for it so far? Any X-rays? Right, so what we'll do is we'll scan you. So I'll pop some jelly, we'll have a look, see what it shows up. And if there's something that an injection will help with, then I'll discuss it with you, and then we'll, if you agree, then we'll go ahead. Is that okay? Just a bit of jelly coming on now.
So for everyone outside, we're doing a left hip ultrasound of a 45-year-old lady with a history of groin pain. We're scanning now, and then we'll let you know what our findings are, okay? And towards the end, if you have any questions to ask, just call me. I'll come and give you the microphone. You can ask.
Get to your hip now, so you just pull one bit up and one bit down a bit. Is that okay? Stick some tissue in your pants so the jelly doesn't go everywhere. Is that all right? And just a bit of the cold jelly coming on now. And I'll just be talking aloud for the benefit of the students. Is that okay?
That's fine.
Right, so hip ultrasound, you can see the tendons very nicely around the hip, and that's one of the things that we are trying to assess. We can see if there's any excess fluid in the hip joint to assess if there's anything intra-articularly going on. We can't see the cartilage. We can see a bit of the labrum, but we can't see all of the labrum. Yeah? We can't see any of the ligaments, so the iliofemoral ligament and the ligament teres, we can't see that, so that the MR would pick up. But from what she's describing, it might be a tendon problem. And if it is a tendon problem, then we can potentially even inject it to try and calm the inflammation. But let's have a look and then we'll see. So first slice is oblique axial to the neck of the femur. So that's your acetabulum there, that's the femoral head, that's the neck of the femur, that's the capsule. So the first thing that I can straight away see that there isn't a significant hip joint effusion. If there was effusion, the capsule would have gone like that, there was no fluid there. So it doesn't look like it's an articular problem, because any articular problem would give rise to a bit of effusion. So that more or less kind of rules out that it's an articular problem. Then we can look at all the tendons. So that's your iliopsoas tendon. You can look at it in axial. So the psoas and the iliacus muscle belly, and that's the tendon, that right thing there. And as you come down, the tendon kind of goes in front of the joint. So you're looking for any fluid in the tendon sheath, and that looks fine as well. Then you can look at the rectus femoris. So the rectus femoris is this tendon here. So that's the anterior inferior iliac spine. That's the rectus straight head, and the reflected head comes from there. So if you tilt a bit, you can see the reflected head. So that's just coming on the side there. And that's your rectus femoris tendon. So that looks fine. There's no calcification, no inflammation. So it doesn't look like it's a rectus problem either.
It's direct head and indirect head.
Also called the straight head and the reflected head. The cortical surface looks fine. Obviously, because of Sheila's history, we are trying to make sure that nothing gets in. So it looks all nice and smooth, so I can't see anything ominous going on there. So for the hip, the sector probe is better because it's quite deep in. You can use that probe as well, but chances are the absorption of the samples should be so much that you won't see much. But you can sometimes swap between the two if you want to see something closer. So like if you're looking at the sartorius, then that may be better. So I'll work that probe for the sartorius. Most machines have preset programs which are kind of designed for the best kind of resolution, but you can alter these manually as well, and you can save your own protocols as well. So I'm just using the one which is on the machine. So for the sartorius, you would have to go a bit higher up. So it's the anterior superior leg spine. So that's your anterior superior leg spine there, and that's your sartorius just taking off there. If you come in the front there, so that's sartorius there. This one here. You can see that muscle belly is fine. The insertion of the sartorius is okay. But you can also the vessel there in between the flat constellation. And as you come over the sartorius, it travels laterally. So it's a very small nerve, so it's there. You see that? Just on top of the sartorius. And that nerve can sometimes get trapped in the inguinal region, and it can give you burning like pain on the lateral aspect of the femur. So what's that called? Meningia peristaltica.
So the nerve's not swollen and her pain doesn't sound like meningia peristaltica in any case. So, but that's again something you can inject if you think that's the case. So sarcoidosis is fine. Now we go outside to look at the hip abductors.
Can you guys hear everything okay? Are you benefiting? Should we continue bringing the microphone closer?
Is that okay?
You can see your video. Do you want us to zoom in? Zoom in on the screen. Okay, can we zoom in on the screen for them to see? Because if you can see there, they can't see the screen. If you can zoom in, please. Thank you.
Of the machine.
Of the machine.
So on the lateral aspect, you can start with the greater trochanter. So that's your greater trochanter, that white bony thing there. And if you look at it on axial, it's nearly like a head. Yeah. So on the anti-aspect of the head, so you can see my probe mark is there, that marks there. So this is anterior, this is posterior. So this tendon anterior to the head is your gluteus minimus. And the one behind the head and on top of the head is your gluteus medius. Right, so I think that's where her problem is. But yes. Sheila, is this a bit sore where I am? Is this a bit sore where I'm pressing? So you can see there's a bit of fluid in the subgluteus medius bursa. Just a little spot there. Yeah, so in all probability she has what's called trochanteric pain syndrome. So it's the gluteus medius and the gluteus minimus tendons, because they come at a very awkward angle. They have tendency to kind of rub against the gluteal trochanter, and then there are a couple of bursas. So you have the trochanteric bursa, subgluteus medius bursa, and the subgluteus minimus bursa. There are three bursas, two tendons, and the ITB goes, and the gluteus maximus goes over the trochanter but doesn't insert on the trochanter. So it's a very common problem in women because the female pelvis is bigger than the male pelvis, so the angle is very awkward. Once it gets triggered off, it just has a tendency to go into a vicious cycle because things are swollen every time she does something. She's walking, climbing stairs, running, rubs, swells. So a steroid injection is very useful because it can kind of calm the inflammation. This gives her a window of opportunity where things are not swollen, it's not running, if it's not running, it might also. Right, so you heard all that, Sheila? Good.
Why is it common in women?
Because the female pelvis is bigger, so the angle at which the tendon, so it's a bad angle. Sorry. Right, so I think you have what's known as trochanteric pain syndrome. That will clearly explain why when you lay on that side of the night it gets sore and you probably have to wake up and you have someone on the other side. So chances are you're probably sleeping on your right side, and when you accidentally go on your left, then it just gets so bursa gets kind of inflamed. So one of the things that will help is the injection of steroid in the bursa. That will bring the swelling down and just gives you a chance when things are not swollen, it might settle down. So not only will it settle the pain, but it gives a chance for it to recover as well. Sometimes, yes, it settles the pain, and 4 months, 6 months, or a year down the line, you say, oh, it's come back again. Can repeat it. If it keeps coming back, then there are surgical options as well, but that's invariably the last one. But quite often the steroids will do that. Physio is useful as well. The whole theory is to kind of make the tendons a bit more supple. So stretching exercises to stretch your ITB. So I'll write it down for you. Google it. See if you can see a professional physio and then learn the exercises. But then once you learn the exercises, once this is all settled, so leave it for a week to 10 days, let this all bed in there. And after that, ramp up the exercises gently, so bit by bit, hopefully, it becomes more supple than it was. So, what does your work entail?
Working. Is that your work or that's the exercise you normally do? Okay, so leave that for a couple of days. Even after that, for a week to 10 days, I think leave the aggressive walking, carry on doing your normal work. Then after that, start ramping it up. So do a little bit if that's holding. So happy with all that? Right, so for the injection, I'll start with the local anesthetic. Sting a little just like the bead sting. Once it starts taking effect, it should be done. And I can keep watching in the machine to make sure that my needle is going in the right place. Once I'm in the right place, inject the stuff and that should be. Just for 48 hours, it can play around. So it can be actually a bit worse before it starts getting better. That's a steroid flare. Doesn't happen to everybody. But if it does, don't get worried. Just take any painkiller, paracetamol, ibuprofen, whatever suits you. Just go for that. Hopefully this will start kicking in by day 3, day 4. Leave exercises, heavy stuff for a week to 10 days. Then after that, ramp up the physio and the exercises as well. And quick and keep all posted in all 4 to 6 weeks. Happy with the plan? Yeah. Brilliant. So give us a minute now. We'll just set up everything and then we'll be all set. I'll just get the jelly off in the meantime so that you don't keep feeling wet while we are getting everything ready. And we'll keep you covered in the meantime. Long and one vitamin for 12.
No, the issue is this one. That's why I came on this side. For the other people to see on that side. So I'm filming this.
Let's start with the ligament. Yeah. So I'm loading 2 catalogs because there are 2 bursas there. So we'll be injecting the trochanteric bursa and the subgluteus medius bursa. Both these bursas are in line, so it's the same needle. So once I reach the trochanteric bursa, I've injected the catalog, half of it, then I'll inject the rest of the half in the subgluteus medius bursa. So I'm loading 2 catalogs in one syringe with a little bit of the local anesthetic. And obviously we'll use local to first numb the area and then get to the area.
Is the trochanteric bursa superficial to the subgluteus medius bursa? You said they're aligned, so it's just one. Okay.
Sorry, what was that?
Is the trochanteric bursa aligned? Is it more superficial than the subgluteus medius bursa? So it's aligned.
So it's trochanteric bursa, subgluteus medius bursa, subgluteus minimus bursa. The subgluteus minimus bursa invariably doesn't create trouble, so it's the trochanteric and the subgluteus minimus. And the tendon in trouble is also the gluteus medius tendon mostly. So once you have, if you inject the 2 bursas that I'm talking about, then you have steroid on top of the tendon and you have steroid under the tendon. So it just bathes the tendon on either side.
Any questions from the room? Any questions?
Right, so Sheila, I'm again going to get to your hips and I'm going to stick some sterile tissue now in your hands. Is that okay? And I'll clean the area to begin with. So you're going to feel some cold alcohol coming on. Clean the probe as well. So even though we have used the this thing, but bit of the alcohol is pretty good, and a bit of the jelly. So always get the air out, because if you inject air, then you stop seeing the plates. So just you lose your anatomy.
It's a novice mistake. I've made that many times.
Right, so that's the greater trochanter, and that's your gluteus maximus. Yeah? And just below that line is the gluteus, the trochanteric bursa, and then one step deeper here is the subgluteus gluteus bursa. So I need to come in at that white line there, and then I'll go one step deeper, roughly in that dark area there. So a little trajectory would be roughly in that direction. That's a long way in, but it's a sector probe, so the orange needle won't reach all the way. So we start with the orange needle just to anesthetize, and we change to the longer needle. So should I do one sharp scratch, and there is a stinging sensation? Sorry about this. Just the one more bigger one, this has a little, just like this thing. You can see the needle roughly here, and it doesn't matter even if you don't see the orange needle, because it's the green needle which is more important. So I'm just waiting for the anesthetic to start taking effect now.
The other tip is leave your needle inside in order not to lose your position. Don't take it off. It might be tempting to remove it or keep it. It will help you next time, because you will remember roughly what the angle was.
Just a bit more of the pushing now. So now we just on the gluteus maximus. So she feel it as I go through. So you're just going to feel this as I go through. So you put this, and that's why I'm going in the first person. You okay, Sheila? You're doing really well. Good job. You can see the steroid going in that plane there. I can see the steroid. Now you're just going to feel it one more time. So that's why we do that. This is fake for you. So the sector probe, it's obviously not as bright as when you use the and you just feel it one more time as I told you.
Yeah, now I do.
Sorry about this.
You want the light off so that they can appreciate it all.
Well done.
You're done.
You okay? Yeah. So you did really well. Good job.
All right.
I can see you're very seasoned with needles. So we'll just give you a sticking plaster now. You okay, plasters? You want surgical plaster?
Yeah.
So the one tendon that I didn't demonstrate is the adductor tendons, which are slightly deeper in the groin, so it's slightly more private. So we'll leave that for this patient. Another patient you might show.
You will volunteer.
Right, so that's all done. We'll just take the tissues off. Sorry.
Any questions?
I'll give you some tissue in case you can still feel some jelly lurking in places.
We should ideally first make sure that it's nothing bony. So Paul did organize the X-ray, and the X-ray is apparently normal. I haven't obviously seen it, but I'm depending on Paul telling me that the X-rays were normal. She obviously does have a history which we have to be kind of a bit more careful, but from where her pain is, it classically fits with protracted pain syndrome. So unfortunately, it's a very common condition, and it's quite common in middle-aged, young and middle-aged women. And from where her pain was, it fit quite nicely with where the problem is. So now the injection will serve as a test as well. If this takes the pain away, then we know that's where it's coming from. If it doesn't, or if the pain is getting worse, then we might still need to do more stuff. So we might go MRI to make sure there's nothing sinister going on there. But I don't foresee anything sinister.
Another question?
Only the ankle. This has been going on for how long now?
I was wondering from seeing the trace what the problem is. Because the MRI, by then it was just x-rayed and it wasn't showing any fluid or something. So according to my mom, a herbalist type, a little fluid was coming out. So the food ceased. That was from baby. So growing up, they didn't notice any deformity. I grew up, and then I think from 18, they realized my walking was not straight, and the bone or the leg was as equal as the left one. So it was everyday pains. So I was just on painkillers.
And have you recently had surgery on it now?
Yes, I have. I met with Purata for office and then recommended to one doctor at St. Joseph Medical Hospital. On the surgery, I think he didn't go well. He didn't put in any metal after removing the little lump. So there is a hole, so when I stand for long, it's got swollen and
Right, so let's have a look. So let's get you lying down. So I'll just need you, it's your right leg. So head there, feet on the other, and just flat on your back to begin with. So if you want to go flat on your back to begin with, let's start with the ankle the other way, yeah? And I'll turn you around as well, but let's start with you flat on your back. So looking up. Perfect. So we've pieced a little bit of a story as to what's going on. So I'll try and kind of summarize, may not have got all of it. She's had trouble with her ankle since she was a child. Yeah? And she says that there was some discharge. At that time they were only x-rays, so they weren't sure what it was. And then recently she's had surgery, so the surgeon went in and kind of explored to see what was going on. And I think he probably found chronic osteomyelitis. And it looks like on the MR they've taken a little bit of the fibula away. There's still a lot of scarring there. It's possible there is still some infection going on there. But we'll have a look at the ankle. But a second problem is she's discovered a lump on the back of her thigh, which sounds like unconnected to the ankle. We'll have a look at that as well. So when did you find this lump behind the thigh? How long ago? Some years ago.
but I wasn't touching it. It's recently that it occurs to me when I hold it. I feel it on the ankle.
Right. Okay. And what do you feel? You feel pain, or you can feel a shock like?
You feel like
electric shock like pain.
It's not shock. You just like what you are pressing. You are feeling the pain down there.
Okay. Right. So we'll start with your ankle first. Then I'll get you to turn around, and then we'll have a look at the.
there are any questions in the meantime in the room, then let me know. Okay?
So with the ankle, we can see the anatomy of the ankle really well. So just take that. We can see all of the tendons around the ankle. We can see nearly all of the ligaments around the ankle. We can look for joint diffusion. We can look at the bony surfaces. So the tendons that we can see, do you know what all tendons we'll see around the ankle? Can anybody name them?
Okay, so the tibial fibula, then we have the tibio-talar ligament, then you have the then you have okay, so between the talus and fibula, talus and tibia, then calcaneus and tibia as well.
Right, so he's talking about the ligaments here, and yes, we can see all of these ligaments, but we can see all of the tendons as well. So just quickly, I'll recap the tendons and the ligaments. So the tendons in the front, there are three tendons. So there's tibialis anterior, which goes and inserts into the cuneiform there. There's extensor hallucis, which goes into the big toe, and that's what extends the big toe. And there's extensor digitorum, which supplies all of the other toes.
Tom, Dick, and Harry.
No, Tom, Harry, and Dick.
Tom, Harry, and Dick.
So Tom, Dick, and Harry are on the inside, yes.
And very, Tom, Dick, and very
nervous Harry.
Very nervous Harry.
So, yeah, so that's the acronym to remember the tendons on the inside of the ankle. So you have the tibialis posterior, which is Tom. Okay. Then you have flexor digitorum, which is Dick. And you have flexor hallucis, which goes all the way down to the big toe. And you have the artery and nerve in between Dick and Harry. So you have Tom, Dick, and a very nervous Harry. So artery, nerve, ligament. At the back, obviously, you have the Achilles tendon, which is there. And on the outside, you have the two peroneal tendons, the peroneus longus and the peroneus brevis. So those are all of the tendons around the ankle. In terms of the ligaments, obviously, there's a joint between the tibia and the fibula at the lower end. That's the inferior tibiofibular syndesmosis. And there are two ligaments holding it. So you have the anterior inferior tibiofibular ligament and the posterior inferior tibiofibular ligament. So it goes from the tibia to the fibula like that, yeah. And then there is one at the back, in the same location, better seen on the MR. But you can see the anterior inferior tibiofibular ligament on ultrasound as well. You also have a syndesmotic ligament, which is in between the two bones. It's like a vertical ligament which holds the two bones. That you can't see on ultrasound, but you can see that on the MRI. Then laterally you have the ATFL, which is the anterior tibiofibular ligament, fibulocalcaneal ligament, or the calcaneofibular ligament, which goes from the fibula to the calcaneum, and the posterior talofibular ligament. So there are three ligaments on the lateral aspect. And you have the deltoid ligament on the inside. Deltoid ligament's got three parts to it. So he was right. You have the tibiocalcaneal, tibiotalar, and the tibionavicular components. And then you have the spring ligament, which is on the inside here, which is between the navicular and the talus. So those are essentially the main ligaments. There are lots of few other smaller ligaments as well, which are better seen on the MRI. So I'll try and demonstrate as much of the anatomy of the ankle. Then we'll have a look at what's going on with, on the lateral aspect with the soft tissues, and then we'll go and have a look at the femur as well. So this will be, I think, a good one just for anatomy.
Remember that Tom hates Dick for the anterior.
So show you just a bit of the jelly coming on now, yeah? Sorry, this is a bit cold. So that's your tibialis anterior tendon there, yeah? And you can trace it all the way going and attaching it to the cuneiform there. So that's the tibialis anterior. The next tendon there is your extensor hallucis. So that's your extensor hallucis. And keep watching that one there. and it goes all the way into the big toe. So that's your extensor hallucis, and that's gone into the big toe there. I can show it longitudinally. And then you have the extensor digitorum, which is this one here. And that will kind of split into lots of small tendons. So keep watching that tendon there. Can you see it's splitting into tendons? And those are, all of them are respectively then going into each of the toes. In between you have the tibialis anterior artery and you have the deep peroneal nerve. So I'll just show you the deep peroneal nerve. So there's the nerve just sitting on top of the artery. You see a little fibula kind of structure there, just by the side of the artery.
Yeah.
So the deep peroneal nerve can sometimes get trapped with osteophytes in front of the ankle or in the midfoot. And because the deep peroneal nerve supplies the first web space, the patient gets pain in the first web space. Sorry?
I said it bent my toe, so the patient was down to straighten it, and now it can't. So that's what
Can straighten her toe.
So
initially this bone was curved like this.
Yeah.
So the doctor has to cut it to clean, to straighten it. After straightening it.
Right. When was that?
That was the operation I had about 5 years ago.
Oh, okay. Yes, I releases. Okay. And now are you able to pull it back
No,
up?
now it can't go.
So they probably
This
fused
is
that
just straight. He did a surgery here.
Let's have a look. So that you can see the first MTP joint, so that's not fused, so it doesn't look like it's fusion surgery she's had, but she may have had something else done. So those are the hallux sesamoids, the two sesamoid bones, and that's your flexor hallucis longus tendon in the middle. So that looks fine as well. So I'm not sure what they have done, but it's possible they've interphalangeal joint has been fused. So that joint space is gone. So they've actually fused the interphalangeal joint. I don't know why they've done that, but that was probably just to straighten the toe. But I can't foresee that having to do anything with the stuff on the outside.
So this one's also.
The MTP joint is fine. So that's the head of the first metatarsal. That's the proximal phalanx. And that's the step at the proximal. So the joint space is gone. A little bit of a bump there, but it's possible they've put a little screw there or something which is fused. But you won't be able to see it on ultrasound because the sound waves just can't get across. Okay, so now just, Shelly, can I have you turn from outside? That's normal. So I'll just show the tendons on the inside of the ankle. So that's your tibialis posterior. Just behind it is the flexor digitorum. Then you have the nerve, artery nerve vein there. And the flexor hallucis is just at the back there. So Tom, Dick, very nervous. Can you see the pulsations there? And the tibialis posterior nerve there as well. So that's the nerve. It's next to the artery. Nerves always have that kind of fibular pattern to it, so you can see it on longitudinally as well. So that's the tibialis posterior nerve.
Where is Harry?
And sometimes you'll have ganglion cysts or lumps sitting there that can cause tarsal tunnel syndrome. So like carpal tunnel, you also have tarsal tunnel. So immediately you can also see the deltoid ligament. So that's the deltoid ligament. So that's your tibia there. So that's your tibiocalcaneal component. And at the back, so that's the tibiotalar component. The tibionacular component is slightly harder to see. Now can I have you go the other way? Yeah, then just leave it on this. Yeah. So keep that one there only. No, go on the side only.
The line on your side, yeah.
And move this. No, the other. Do it the other way. This will become more uncomfortable for you. So leave this foot there. Yes, that's right. Leave this one here, and maybe you can give it a pillow or something. Something about can you roll up a gown maybe.
Hold that.
Okay. Yeah, okay, that's right. That's right. Okay, you can relax that. Is that okay? Yeah. So obviously on this side she has quite a bit of surgery and trouble, so the anatomy is going to be a bit distorted on this side. So that's your peroneal tendons, yeah? That's peroneus brevis, that's peroneus longus. So peroneus brevis is closer to the fibula and longus is slightly behind the fibula. So those are the two tendons there, peroneus brevis, peroneus longus. And as I keep coming along, you can see one of the tendons will go into the base of the fibula, peroneus brevis. So just the two tendons sitting there, brevis, longus. That's at the level of the, and the brevis becomes quite thin there and it's attached there. So I'll just show the brevis and longitudinal. So that's the brevis. Brevis, that's peroneus longus. Peroneus longus goes through a peroneal tunnel in the cuboid and then all the way across and then inserts on the other side. So that's peroneus brevis, that's peroneus longus, that's the back of the fibula, that's your peroneal retaniculum. Now she has some stuff there, so that looks maybe like might be a screw or something. Yeah, it's looking metallic. Or is it, I don't know, maybe a fragment of bone or something. I think it's looking like a screw, it's looking like a screw which is coming out there. Then she has a little pocket there, so she has some fluid there. So lots of small pockets of fluid. So that's the Achilles tendon at the back in the cross section. So where that curve comes, the contact, the probe doesn't kind of make contact. Yeah? So you can put a big blob of jelly which kind of fills the gap. So that's the Achilles tendon there. That's the blob of jelly which is helping. That fat, the triangular fat is the cago fat. You have a little bursa there known as the retrocalcaneal bursa. And then there's a bursa on the top which is the subcutaneous bursa. So this is quite a common site for insertional tendinopathy of the Achilles tendon. So her Achilles tendon is quite good. You can see that's all fine. Achilles tendon. Reduce the depth a bit. So this muscle here is the soleus. And normally it looks much darker, but I think because of her problem, she's lost a lot of bulk and it's all become quite fatty. Yeah. So there's a lot of fatty atrophy of the soldiers. Okay, now let's just see where those connections are going. So, little pockets, heading there, heading there. Let's trace the fibula. You can see again pockets of connection, just tracking through the tissues. There is a fibula, fibula, fibula.
This is the
And then it's fibulas, but of the cortex is missing there, so it's dug out a little bit of the bone, but it's not a whole. Right, so you can see the track is heading towards the fibula. So there's a bit of fluid there, so I'll just squeeze it a bit. Can you see the echoes are compressing in it? Yeah. So it's nearly like there's pus sitting in there. And it's definitely heading into the back of the fibula there. So it's, I think it's chronic osteomyelitis from the fibula. The other thing is, what was that little bright screw, or was it maybe it was a bony fragment, like a sequestrum or something. Maybe it looks like there's a bit of calcium there. Maybe a little bony fragment.
Yeah, that's what we saw in the MR.
I think there's some bony fragments with most likely discharged sequestral fragments. So do you still get a discharge from there?
No, I've never seen.
Just a bit of jelly coming out.
Sorry, I have a question.
Yeah.
Yeah, can you ask the client whether after the surgery they took the bone, whatever they removed, for histopathology?
Did they send a bit of the bone to histopathology? Are you aware of them sending bone for analysis? They haven't told you what the analysis showed. Okay, the patient says no.
Because I am thinking more of, since this thing started, since she was a child, I'm thinking more of a tropical ulcer.
Yeah.
And they, I mean, I hope she doesn't understand, they are more linked with SEC later in life. So,
yeah, that's a very good thought, in fact. That's a possibility.
I'm hoping they sent it for pathology, whatever they took out.
So, as far as the patient knows, they haven't sent anything. But we probably will have to dig out a little bit more of a history to find out what's going on.
The problem is when they take a specimen, give it to the patient, I think it's expensive. Understand? The story is that nothing was taken.
So again, there's a bit of classification there. There's a bit of calcium there actually. What would cause calcification? It's something probably with the how about filariasis? Does it cause calcification?
Not that I know of, just fluid.
Can anyone think of any tropical infectious diseases that would cause calcification in soft tissues? We're just brainstorming. Because we found calcifications in 2 different locations, in the ankle, and now that we're looking at the mass in the posterior aspect of the thigh, we can also see calcifications in the soft tissue.
So these tropical ulcers, they are actually quite poorly understood, and mostly they find a host of a whole lot of infectious agents when they take the discharge samples.
So it's not just one organism, it's a host of them, so they are very difficult to manage.
So it's again a little bit of scarring in the soft tissue. You can say it's puckered, and then there are some bright areas which look like calcification. And it doesn't seem to be going into the muscle, so it's just in the subcutaneous plane. It's away from the nerve, it's got nothing to do with the nerve. But there's a little bit of that scarring. So
You don't think it's a nerve?
No, it's not.
And so, probably excision biopsy.
Yeah.
Have you had a biopsy done in your life?
Has some blister-like things on the skin.
Traditional, right? Did you go for traditional treatment?
No.
So, no, this particular one.
No.
You haven't had anything done to your body?
So, something because right on top of where the problem is, there is a little blistering lesion on the
We have
skin.
found some kind of crowd. We have one more fire.
Translation.
Translation is.
Oh. So we can see skin lesions overlying where the lump is. I don't know what it is.
So as you put pressure, she feels it radiating down the leg. Makes it sound as if it's in the room, isn't it?
Yeah.
I think the flow was unable to go through some of the things.
If a fluid is blood flow coming out.
Are you writing another book?
So the scarring under the skin is just in the subcutaneous plane. It's got a bit of calcium in it, it's got a bit of scarring, and then she has this blister. So I don't know what it is, but I think that needs to be biopsied. But the sciatic nerve is actually free, so it's not nothing to do with the sciatic nerve.
Dr. Bagan is going to demonstrate anatomy now.
So in the back of the thigh, you have the hamstring muscles. So you have 3 hamstring muscles. Yeah, that's right. So biceps femoris goes that way. The semi-tendinosus is tendinous at the bottom and it's membranous on the top. Semi-membranosus is membranous at the bottom and tendinous at the top. So the bulky muscle here is the semi-membranosus and the semi-tendinosus. So you can recognize that by the kind of size, and then you can trace them all the way up. And then obviously you have the biceps femoris on the outside, and then you have the adductor magnus on the inside. So that's your semi-membranosus, and that's your semi-tendinosus. So that's just a little tendinous muscle. So you see it there, it's a bit more muscly, and then as you come down, then it's just a tendon. And that's your semi-membranosus. You can trace the semi-membranosus. So there's the semi-tendinosus, and it will go and insert into the, and go along with the best hamstring muscle. And the semi-membranosus will insert in the back of the tibia. So that's your semi-membranosus, muscle, and then that's your middle metatarsal. So semi-membranosus getting smaller, it's become a tendon. That's the tendon there, and that's where it's inserting into the back of the tibia. So one of the ways to find the sciatic nerve is to find the common peroneal nerve. So common peroneal nerve is on the outside of the tibia there. So let's just find that first. So it's there. Can you see that little structure there? It's called the fibular pattern. So I'll go up a bit. So it's there. And I'll go down a bit. So it's there. And then it's going around the fibula head. It's just there. And then it goes down. So nerves quite often you have to go back and forth because you keep losing them, you need to keep finding them again. Right? So it's there. So just there. And I'm just trying to think that's the nerve. And now if you trace it back, the trouble is this road you lose this thing, so it's going there and then oops.
That's also calcified.
That's also what
Yeah.
it's
Is it connected to this?
It's a angina or something, isn't it?
Soft tissue?
Kipple-Tronoi?
Yeah, we have
The leg isn't that big, isn't it? Kipple-Tronoi, the leg becomes much larger. So she's got another lesion there. That's quite deep. Which is a bit similar. You see, and that's also got calcium in it. And there's some kind of spreading lesion which is going through the tissue, so that can't be chronic osteomyelitis.
Is it connected to
The fascia is self-limiting and it's suddenly older and it goes away on its own, so this can't hang around from childhood. It's some kind of, I think, vascular malformation.
Why
You need some thinking, come on.
Yeah, why are you thinking vascular?
CT, do we?
Yeah.
That's a good idea as well because it shows classification and how extensive it is.
Yeah.
Or CT as well. We can do the CT today, can't we?
Yeah.
Let's do the CT and see what it shows. I'm thinking the fact that this calcification, it's probably a meningitis lesion, vascular lesion which is constant.
Chronic.
So some kind of infantile angio which is probably still carrying on.
But the fact that it's just in one thing, not elsewhere.
This leg is a bit smaller than the other one.
This one is more bulky, but likely
So Kipple-Tronoi will give you a bigger leg, it won't give you a smaller leg. So it's not Kipple-Tronoi. So it's not a venous malformation, it's more like a arterial.
The triple fashion.
So, Shirley, we're still not sure what's going on, but it looks like this might all be connected. And that's probably the reason why when you kind of touch this bit, you still feel it going down the whole leg. Apart from that lump, which you can feel, there are a few more lumpy things that are deeper in the leg. But they all look the same. And first I was thinking this might be infection. And it's possible, yes, there might be a little bit of superimposed infection because people have gone in and done surgery. But it all looks the same. So it's some kind of congenital malformation, most likely vascular, which you were born with. But let's get more information to see how extensive it is. And then we might get closer to it. It's possible we might take a little sample, send it off to the lab for testing. That might tell us 100,000 more.
Yeah, I'm just thinking the clinical picture also will fit osteomyelitis.
Yeah, because she did say she had a discharge when she was a child, but she hasn't had any discharge because of a long time. But obviously, some of the pockets of fluid that we're seeing because she's had surgery, so it's possible those are post-op. But it does look like something is happening in the fibula, but it's possible that vascular malformation is actually going into the fibula. So let's have a look at the MR one more time just to get a bit more information on that.
How was underlying bone here in this area? Did we check the bone that's underlying this area?
The femur is hard to see, but the surface looks fine.
The surface looks
Possible,
fine.
yeah, but if you're doing the CT, then we'll see.
Yeah, we'll see.
Right, okay, so we just get the jelly off now, and I'll give you some tissue. You can also give yourself a wipe in case you get.
Very good. We get into interesting cases.
No,
Great. I know you'll be interested.
So I want to take water from my back. I have to pull it, then it chokes up. You're supposed to pull it.
So Mensa is an engineer. He works in the Okosombo Dam, and he works these big valves. How many of you have seen that dam?
So you all do enjoy the light today. It's very bad. At least you should come and see what we are doing over there.
Okay.
It was built by update. So I'm inviting all of you to come to Okosombo.
So will you give us a tour if we come?
Yeah. Yeah.
Last time we used to take a lot of permissions to get in.
But because of the trans-Togoland, now they have no strict come.
The last time I went there, I couldn't enter.
You never say that. You say, if you do a good job on me, I'll tell you.
I'll talk to that, I'll talk to them, then they will allow you to come. So I'll be expecting you.
Right, so Mensa, for the first bit, palm facing up, and pop some jelly and we'll have a look. Is that okay?
Yes,
Right, so in fact I know what he's got even before I started scanning. So for a good radiologist, you have to be a good clinician. And to be a good clinician, you need to know lots of pathologies. And despite knowing lots of pathologies, there will always be some cases which you go, oh my God, what the hell is this? Like the previous one. So, but this one, his problem you can see is extreme limitation. So I'll just demonstrate once the amount of limitation that he has. So Mensa, do you want me to just palm facing up on this side? So move it out here. Keep the arm next to your body and then move it out. Yeah, bend it. We'll do the same thing on this side. Keep it next to it. Can you see the difference in the... You go to the roof. Okay, now palm facing down and up, and the other one. So yeah, and obviously if I ask him to bend his back, he won't be able to get it bent this back. So extreme limitation. So limitation obviously can be because of tendon problems, but they won't give you that severe limitation. And tendon problem won't give you that severe pain as well. You can straight away see he's in a lot of pain. And so this kind of pain and this kind of limitation happens in a condition called frozen shoulder. It's also called adhesive capsulitis. So that's the technical name. Frozen shoulder is a kind of non-technical name. So I'll just first describe the pathology, then we'll have a look at it. So with frozen shoulder, the problem is not with the tendons. The problem is with the capsule of the joint. So if you imagine your shoulder joint, it's the cup at the ball, yes, so glenoid and the humeral head. The capsule comes from the edge of the humeral head along with the labrum, and then envelops the humeral head and then attaches around the neck, the surgical neck. So that's what forms the joint space. That's what gets into trouble with frozen shoulder. Nobody knows why frozen shoulder happens. It's more common in men or women. It's more common in women. Yeah. You said women. Yeah. So it's more common in women, but men get it as well. It's more common in diabetics. Are you diabetic, Mensa? Blood sugar?
No, my sugar is high, but I'm not there. My sugar level has gone up, but I'm not diabetic.
So, how does that happen? Why is your sugar
when I checked for the first time, they say it has gone to 30 point something, but it came to 6. And now it's going up again, so it goes.
Oh,
okay, so So I should admit it.
You are there.
No.
So, Mensa, first of all, you need to go to your doctors to sort your blood sugars.
Okay.
So, you're denying it, but I think you're right. So, men get frozen shoulder very rarely, but the time when they do get it, they're invariably diabetic. I've had so many patients, I've diagnosed diabetes by diagnosing frozen shoulder. Well, you say, oh, my blood sugar's been fine. I say, go and check it, and they check it, and their blood sugars are wrong. So, see, I didn't know he was diabetic. He doesn't look diabetic, then he looks skinny. But then still. So with frozen shoulder, once the inflammation, so it's inflammation of the capsule, once the inflammation gets started off, it just kind of has its own lifespan. If somebody can put a camera into his shoulder at the moment, which surgeons can do, it will be like strawberry. It's red hot. Yeah. It goes through stages. There's the inflammatory stage where the capsule becomes very red and hot, gives you a lot of pain, especially night pain. Now I haven't asked him, but I'll ask him now. So he's already nodding, but let me first tell you the pain and then we'll ask him whether he has that pain. If you roll onto that side, it will start hurting like mad. Yeah? And it will wake you up in the night. He'll say, why is it taking in the middle of the night? And then he'll try to put lots of pillows there to get it comfortable, and he just can't get it comfortable. Mensa, is that right? The other pain is sudden jerking movements. Yeah? So it will be something even simple like getting the card over or getting your jacket on or just stretching. And because the capsule is so inflamed, it gives you a shock-like pain going down the arm. You nearly get tears in your eyes. Do you get that kind of pain also? Huh? Yeah. So whenever it's sudden jerking movements, but with frozen shoulder they get so nervous they never move their arm. Yeah.
Can I ask one question?
Yeah.
One more item. Can I ask you a question? Yeah. When they saw that my sugar level has gone up, they gave me Gabos meds. So it came down to 6, like I was saying. And then I traveled enough to do some work there, and the medicine got finished. Within 2-3 days before I sit down, I lose no weight. Is that diabetic or I don't know? Why? So my question is, was the medicine managing it or it was treating me? Because the medicine I've been drinking for some time.
Medicine for diabetes? Yeah, so when the blood sugars go up, the frozen shoulder gets worse. So, but if it's possible when they started you on that, when the blood sugar came down, the frozen shoulder inflammation also came down a bit. Yeah? But we can, don't worry, we will sort your pain. Okay. Yeah. And we'll tell you what to do to sort the shoulder, and then you need to sort your blood sugars as well. So there are 3 things to be sorted. So once then the inflammation starts getting a bit better. Graphically, if you see inflammation shoots up, 2 to 3 months, it's really bad. Then it starts getting a bit better, but then the stiffness starts coming in. The capsule starts getting tighter and tighter and tighter. And external rotation is very limited. You can't get it up, can't get it behind your back, so he won't be able to kind of comb his hair. He doesn't need to comb his hair. So can't get his jacket on, so all those kind of movements. Yeah. And behind the back is also really very painful. Then the 3rd stage is when it starts releasing. And frozen shoulder can go on for nearly 2.5 to 3 years. How long has it been going on, Mensa?
Come again.
How long has it been going on, this pain?
This one, somewhere May.
What?
May, since May.
4 months. The month of
May.
May.
4 months. So now his inflammatory stage is actually getting a bit better. The stiffness is picking up.
Yes.
But if he leaves it, it'll go on for another 2 years. So there are things we can do to try and expedite the recovery. So let's have a look and see. So with frozen shoulder, you don't see anything. Yeah, everything looks normal. But that's the diagnosis. Because if it looks normal, then it's probably frozen shoulder. The only thing that you see 2 things. So one, you see excess fluid in the long head of biceps, because the capsule gets really tight, and therefore the fluid inside the shoulder joint pops out into the long head of biceps. That's just reactionary to the capsule getting tight. And the other thing you see is a little bit of inflammation in the rotator cuff interval. Do you know what the rotator cuff interval is? So rotator cuff interval is the interval between the subscapular and the supraspinatus. And normally what sits there? So yeah, there's probably small vessels. So the long head of biceps travels between the two. So that's what kind of sits in the rotator cuff interval. So you get inflammation just in the rotator cuff interval, the soft tissues around the rotator cuff. And that's hard to see on ultrasound, but you can see that on MRI. But because he's nice and skinny, we'll probably be able to see it. The third couple of signs that I have seen, they haven't been reported in any books. So don't quote them in the exams and things, because one is where the capsule inserts just medial to the subscapular, you get a little bit of bony change because the capsule gets very inflamed and it takes a little bit of the bone, so it resorbs a bit of the bone. So you get a little dent-like appearance just medial to this capsule. And you can see fluid in the shoulder joint as well, and that fluid shows white specks, nearly like crystals. So I don't know, nobody's ever tested it, but we should probably take the fluid and test it for crystals. Possibly it's got something to do with crystals. But very similar to gout, you can see small specks inside the FME. So let's have that.
I missed the other sign, so you said there are two signs. What was the second one? I missed that.
So inflammation in the rotator cuff interval, and on MR you'll see edema and thickening of the capsule, especially the inferior glenohumeral ligament. And the two other signs is excess fluid in the long head of biceps and echogenic specks.
Questions?
So that's the bicipital groove there, the front of the humerus. That's the long head of biceps. And you can see there's excess fluid in the long head of biceps. You see that? So I'm tracing the biceps, so that's in the bicipital groove, biceps sitting there. And because it's thin, just like when you see there's a little notch in the bone. So that's again where the capsule is inserted. So we have a bit of tendinosis as well. So he has a bit of trouble in the supraspinatus tendon, but I'll just come to it. Vincent, now I need your arm going behind you, as if you're putting it in. So move forwards a bit. And we can again test his limitation of the back. So bring this back, touch this. Yeah. He's quite flexible. How far up can you go? How far up? Yeah. As well. Like that. How far up can you go? Yeah. So it's quite flexible. Okay, now with the, that's fine. With the right. So he just won't be able to do it. He also superimposed to that he has inflammation in the supraspinatus tendon. Sometimes that can be reactive to the frozen shoulder because the capsule is so inflamed it starts inflaming the tendon as well. But you can see there's a little bit of bony change at the footprint. So he does have supraspinatus tendinosis as well. So I think he benefit from injection in the bursa and in the glenohumeral joint. So the glenohumeral joint injection will sort the frozen shoulder, and hopefully the injection in the bursa will sort the supraspinatus tendon. So that's the infraspinatus tendon and diagonal. So that's the tendon, and it's much more swollen than normal. And obviously we can look at few normals, and then you'll realize that's the long head of biceps, and that's oblique sagittal slice. So subscapular is here, long head of biceps, and supraspinatus. So you can see very heterogeneous. The tendon should normally look nice and smooth like that. Yeah? But here you can see it's very heterogeneous. There's cortical bony change in the footprint as well. So that's your glenoid margin, that's your humerus, that's the posterior labrum. It doesn't have that much fluid, but just look really carefully when you see the little bright specks, like that speck there. So that's the specks that I was talking about. If there was more fluid, then you would have probably seen it more easily.
Would you expect to see some fluid at the initial stage?
Yeah, that's right. The AC joint shows a bit of capsular hypertrophy, which is normal. So, like most people, it will look like that. Yeah? So that's okay. So that's not his problem. So his problem is supraspinatus tendinosis plus frozen shoulder. Right. So you can relax your back. Sorry about this. We'll talk about that. So and like I said, nobody knows why it happens, but it. Once it gets triggered off, it just has its own lifespan. Quite often, frozen shoulder gets triggered off with minor trauma. And quite often the trauma is something like the dog pulled the leash, I was putting my suitcase somewhere up, or in your case, pulling something from the back. Yeah? So, and the trauma is minor compared to the amount of pain that it gives afterwards. Yeah? So you might not even remember what you did, but then sometimes when you think, oh yes, I pulled that thing, and then from there on, the pain just gets really bad and bad and bad and wakes you up in the night. So you've got one frozen shoulder. Two, you also have a little bit of inflammation in the tendon, which I think might be pre-existing, or it's possible it's got a bit worse because of the frozen shoulder. Yeah? So you will benefit from two injections. One around the tendon in the front to calm the inflammation around the tendon in the bursa, and one from the back inside the shoulder joint to calm the frozen shoulder. So the steroids will settle the inflammation and settle the pain. But there are two things going on there. One is the inflammation, which is what's causing the pain. But the other thing is the capsules become very stiff. That's why you just can't move it. So for that, you will have to do a lot of physio. You have to work it. But the trouble is, because it is in a lot of pain at the moment, you can't work it. Even if you do this, you can't because it will hurt. Yeah. So once the pain settles and the inflammation settles, it will still be stiff. But then by the more you use it, quicker and faster it will come back. Yeah? So you'll also have to work very hard to get this back. And the third thing that we need to sort, which is very important, if you don't sort that, this won't get sorted, is your blood sugars. So you need to really see your doctor. Are you under anybody for me? I'm sorry, that fellow can. Yeah? But you need to see a diabetic specialist, or a doctor who deals with diabetes. Yeah? And don't kind of keep ignoring, don't think that no, it's not diabetes, it just went up temporarily or something. Because chances are the fact that it's going up and down, that means there is, maybe it is not that bad in creating, but if you control it now, it will cause much less damage. And it's just immunity tablets that will do the trick for you, because you're not fat or overweight or anything. So are you happy to have the injections? Yeah? So two injections, one in the bursa in the front and one at the back. For both of the injections, I'll start with the local anesthetic. So there will be one sharp scratch, little bit of the stinging of the local. Once the local starts taking effect, it shouldn't be too bad. Just for 48 hours, it can flare up a little. So it can be more so, it can be more painful than it is just for 2 days. Yeah. If it does flare up, don't get worried. Just take paracetamol, ibuprofen, whatever you can get from the counter. Yeah. Then this will start kicking in by day 3, day 4. Leave exercises for a week to 10 days. Don't do anything. Yeah. So just carry on in your normal work and don't do any exercise. Let this bed in. Let this all start kicking in. Then after that, ramp up the exercises. See if physio can really guide you with the shoulder movements to get it moving again. Yeah. So happy? So. That's it. Excellent. So let's get started. So for the injection, I'll get you lying down here. So we'll just move the bed this side. And one last thing. You have to get us into the dam.
Any questions in the room?
The one other thing we can do for frozen shoulder, which I don't know whether we could potentially do it,
is what's known as hydrodilatation. Have you guys heard of hydrodilatation? So because the capsules become very tight, so one of the things that we can do is inject a lot of fluid to kind of distend the capsule to stretch it, yeah, and that gives a starting point. So with hydrodilatation, the amount of stretching that we can cause is nearly 3 to 4 weeks of physio. And then they still need physio after that, but it just gives them a good starting point.
So we can do one more thing, Minsa. When I'm injecting at the back from the shoulder, you can do what's known as hydrodilatation. So imagine your shoulder joints like a balloon. The balloons become very tight, but normally the shoulder joint is very lax. That's why the shoulder can move so much. Whereas the hip can't. The hip joint, the balloon is very tight normally. But with frozen shoulder, that's what happens. Your shoulder joints become like a hip joint. So you just can't move it. So what we can do is once I'm in there, I can pump it up, kind of stretch it. Yeah? It gives you a starting point. You still need physio also after that. And that will expedite the recovery very fast. Are you happy to have the hydrodilatation as well? So for the hydrodilatation, once I'm in there, it's the same thing. I keep on injecting fluid, so it gets a little tight, like a balloon, yeah? So we'll keep putting fluid till you start saying, oh, it's getting very tight, yeah? And then you will stop. Happy with that? Okay.
I have a question. You mentioned that the natural shoulder disease progresses over 2 years.
Yeah, it can go to even 3 years.
So does that mean at the end of the 3 years, the pain resolves and the patient becomes fine?
Yeah, so it eventually recovers. But if you don't do the exercises, sometimes the stiffness might be left forever. Because the capsule becomes so tight and you haven't worked on it, and therefore, so the pain goes away, the inflammation goes away. Stiffness also comes back to quite a large extent, but if you don't do the exercise, you get it. But the whole thing can last for 3 years. So this is just expediting the recovery. So we are shortening the whole course.
So that he can do physio. And then it can recur when...
If you get frozen shoulder in one shoulder, months or years down the line, you can get it in the other one as well. And next time when it happens, it doesn't come back to the same one. But if it happens on your left one, then you know what it is, yeah? So go to the doctor's quickly and then you solve.
But normally it doesn't happen again in the same side. Okay. Any other questions? And what sort of fluid will you inject?
After this, I think we might have a connecting tube in the back. Connecting tube.
Oh, yes.
A tap and a three-way tap and a connecting tube. So I think connecting tube I saw in the back.
I saw it, I think, with the tap.
You saw the tap also? So I need two 5 cc's, one 10 cc, and one 50 cc. I'll do this in this. One laundry, I got one orange. You have normal saline and do you also call them lollipops? You call them lollipops? No, not this one. Not this one. Yeah, that one. And was there a three-way tap? Like that? Is that detachable?
I think it is detachable. Or maybe you can attach it.
No, that won't attach.
It won't attach. Shall we try?
Yeah, okay. I think it's won't fit on
You don't think it would? Have you seen, do we have to isolate from their own?
Yeah, that's what we want. But I can't.
I don't think I've seen it.
But they might have.
Yeah, do you have to just need this that we can connect or let's respond to this? Yeah.
pop some sterile tissue under your shoulders if you get it up, and you can pop it back down. Round on the side, arm facing up. Just clean the area. So for the first injection, I will get you to roll you out. Once we have done this, then I'll pop it on the other side, and I'll get you lying on your tummy. Yeah? So the second one we will do with you on your tummy. Okay, do you want to give me local?
When you are done, in 2 weeks' time, go and see Gertrude. You know Gertrude? Yes. Physiotherapist. This is a note. So you want the capsule to stretch because it's really tight and you use it fully to go in.
Did I give you the tube? Did I give you the tube? It's the tube itself. You have the tube, okay. And it's not just normal saline?
Yeah, that's just normal
Just
saline.
normal.
Start off with the bursal while the tap is coming in. So what we have loaded is lignocaine, 1%. That's to get my needle into the area of interest. Yeah.
So that will just, as I'm guiding my needle, you keep injecting a little bit. Then once you are in the bursa, combination of lignocaine and Kenalog, so 1 cc, 1% lignocaine, and 1 cc of Kenalog, which contains 40 milligrams of triamcinolone.
It contains how many milligrams?
40 milligrams of. So triamcinolone is a long-acting steroid. Yeah? it's quite a useful one to use for musculoskeletal indications. Because it's particulate and it kind of absorbs very slowly, so it has a half-life of about 3 to 4 weeks. And that's levobupivacaine or chirocaine. That's a longer-acting anesthetic. That will go into the shoulder joint. Because the shoulder joint is a bigger joint, so you need a bit of fluid to kind of spread it everywhere. And finally, we will do hydrodilatation with 50 to 60 cc of normal saline. Only with frozen shoulder, they can't take more than 30 or 40 cc. That's so tight. We'll see how.
So the 50 cc of the normal saline,
That's like for everybody or?
So no, it's variable. So some people can even inject up to 100 ml. But with frozen shoulder, when you're doing hydrodilation, if it's in the acute stage or the adhesive stage, invariably not more than 30 or 40 will go. And then you load up 50 because it's possible more might go. So keep it ready. And invariably 60 cc is enough to kind of give it a good whack.
For the supraspinatus, to target the supraspinatus, we're going to be injecting in the subacromial bursa.
Yeah.
Any questions from the room? You're injecting a long-acting local anesthetic because presumably with the hydrodilatation it's going to cause pain afterwards.
Yeah,
so we want to come in for a few hours.
But even if we weren't doing hydrodilatation, I would have still used chirocaine for the shoulder joint.
Yeah. Are we putting steroids as well in the shoulder joint? Or the capsulitis in
So
addition?
that will go levo plus Kenalog.
Yeah.
So one Kenalog there, one Kenalog there.
Okay. And it's also 50-50 for the capsulitis?
So no, this is 10 cc levo, 1 cc Kenalog.
Do you sometimes give more than 1 cc Kenalog?
So yeah, you can give about 80 milligrams as well in a joint, a large joint, sometimes even 120 milligrams depending upon. But for frozen shoulder, there have been lots of studies comparing 40 milligrams and 80 milligrams, and the results are same. So why give unnecessarily? Right, so I'm just cleaning your shoulder one more time. And just having a look again, so a bit more of the sterile jelly coming out. Can I have a little bit of the sterile jelly? So that's your humeral head, that's the supraspinatus, and that's the bursa, that little dark space there. So my needle is going to come from there and then into the bursa here. So just the orange needle is enough quite often to reach the bursa. Sometimes somebody who's really muscular or has a lot of fat, then the orange needle might not reach. And then you start off with the orange needle, but then you might change to a green needle to kind of reach the bursa. Yeah, so there's a bit of fluid in the bursa. And sometimes when the frozen shoulder is really bad, the inflammation actually oozes out of the rotator cuff interval and then causes bursitis. So the bursitis is secondary to the frozen shoulder. I think that's probably what's happening in this case. One nice trick is to take the cable out of the way, is to put the cable by your wrist outside the distance so that it doesn't interfere with the So it will be one sharp scratch and then a little stinging sensation. Sorry about this, one side. Just the burning of the local, just sting a little, just like the bee sting. Okay, that's where needle area. In the bursa now. Sometimes you have to just find the space. So you just go back and forth and you keep injecting till you hit no resistance. So think how I hit no resistance. And the fluid is running in quite smoothly. So even though you're using vision, you still have to use a little bit of your feel, because the bursa, so the bursa has got two layers. Yeah? Superficial layer and a deep layer, and in between there's a space. But these layers, they are like onion peels. So it's not like one single tissue. Yeah. So it's got lots of small layers. So if you inject in there, it just splits up the layers, yeah, and the actual space gets squashed out. So it's nearly like those disco bags, you know, the shopping bags with polythene where it's stick and you're trying to find the space between the bags, yeah.
So you feel like you're actually.
So when you're injecting, you feel that fluid kind of just. You okay, Vincent?
So if it runs freely, you know you're in the
You're in the right
otherwise.
space, yeah. You can see these steroids kind of finishing off with the syringe, and it's just gliding into the space. You can't even see it going. But it's filling the space. And you see that space is lifting up a bit, and there's a bit of fluid. Can you see the fluid now?
Yeah.
And that's the air filling up the space. So if you can scan, see it's all gone along the bursa. With just outlining the bursa. So that's one done. You okay, man, sir? Robert, your process? You're okay? No. You're not. He's wondering whether people are allergic. I don't see whether. Okay, so that's one bit done. Second bit, we'll just get you off the couch very briefly.
So if you go posteriorly for the
Yeah. So if you just, okay, that's good. So is that okay? So again, I'm cleaning the area, so I'm going to feel some cold alcohol coming on. I might need a chair for this. Normally for scanning, it's useful to have a chair which can adjust up and down.
For the next one.
But that's fine. This is okay. So the reason we go into the glenohumeral joint from the posterior aspect is there's a much larger window for us to enter. So that's the humeral head. That's the glenoid there. I think the tone isn't, the penetration isn't enough to see it, but the capsule is going from there to there. Yeah? So if I reach anywhere from there to there, I'll be in the joint. So that's the infraspinatus, that's deltoid. So I will go through subcutaneous tissue, deltoid, through infraspinatus, and then we have to end up there. Yeah? So with the frozen shoulder, you have to be very sure you are in the right place because you will be injecting a lot of saline. Yeah? If you're not in the shoulder joint and you inject it in the muscles and tissues, that will cause damage.
Yeah, this is infraspinatus, the tiny amount. Not transverse.
So this whole is the infraspinatus muscle belly, not the tendon, but the muscle.
Yeah, of the muscle. We need to do it.
So it will be one sharp scratch and very little stinging sensation. Sorry about this. Just the burning of the local, just a sting a little, just like a bee sting. Can you see my needle coming in from there? So I'm just going to tilt it a bit more so I'm more immediately towards the joint. So just more local, but I won't use this needle to go in because the orange needle finds it hard to kind of penetrate the capsule. So just give me more local along the path.
And you'll keep your needle to remember.
Yeah, I'll leave it so that I can see these spots. So with fairer skin, it's slightly easy to see where you went in. With dark skin, once you take the needle off, you can't see where you went in. And if you don't go in the same spot, it's painful. Yeah. So because normally you should. Yeah, blebs are very painful. So that's if you're doing a biopsy, and even with a biopsy, I don't do a bleb because if you go right through the same hole, so in fact you can see some, on CT when we do local anesthesia. Yeah. Even if you don't do the bleb, as you inject, it spreads in a circular fashion. So my local hair will be in about that big a circle. Yeah.
Without doing a bleb?
But without giving a bleb. But if you give a bleb, then it will be a much bigger circle. But I don't need to anesthetize all of that. Right? I just need that one hole to be anesthetized.
Dr. Zamir loves his bleb. He makes me do 2 centimeters spray.
But the bleb hurts because when you're infiltrating under the skin, that hurts more than just at one point. But that's a personal thing. Most people do the bleb. I don't.
Did you do the bleb?
I don't.
They don't use any local. They just instead of poking.
Straight to the point.
So one sharp scratch.
And so you just feel this as I go through the capsule. Sorry about this. You see the capsule lifting down here.
You okay? You're doing really well. Good job. This is the short sign of frozen shoulder. So normally, so the shoulder can take up to 100 mils of fluid and nothing comes out. But my 5 mils also, which I've injected, is pouring out. When the capsule is tight, it jets out. So when you're taking the syringe off, you first move away just to make sure that it doesn't come straight on you. Don't worry, Mensa, that's just my drug pouring out here. It's not blood rolling down your arm. Sometimes patients get worried, what's that fluid running down my arm?
So if we relied on ultrasound imaging alone, we wouldn't have been able to diagnose frozen shoulder. Because there was fluid around the long biceps, but we also have a supraspinatus.
But frozen shoulder is quite often a clinical diagnosis. But the imaging kind of helps. And like in his case, he had 2 things going on. He had tendinosis as well.
Yeah.
So, which could be secondary to the frozen shoulder. Let me remember how this is. This is blocked off. This is fine.
So whichever one. This is good.
You can see the steroid myelin.
Showers of blessing.
It'll get quite tight here, so even the steroid is getting quite tight.
There's a needle that fell.
Yeah.
Or a drop.
Back into the cell because it's under so much pressure. Okay, Mensa, you're going to feel the shoulder now blowing up, yeah? And getting tighter, more tight. You're doing really well, good job. More tight.
Can you feel resistance after that?
Yeah, it's extremely hard. So it's like
resistance.
Yeah.
You okay, Mensa? You're doing really well, good job. He's a tough guy. Most people would have given up by now. You okay? You okay? You okay?
If you're not okay, let us know.
So do you stop when the patient says stop?
If the patient says stops, then I stop. But he's a tough guy, so he's not.
Otherwise, or do you stop when resistance is too much? Or is it resistance that guides you?
No, the pain.
The pain.
Well done.
All done.
Okay.
You did really well. Good job. Could you feel it blowing up? Yeah?
Yeah, I feel it.
Yeah. Was it painful?
Huh?
So we'll just give you one more plaster there.
She's given.
If you have an emergency, somebody with what appears to be acute appendicitis, so it's a private patient, doesn't want anybody to hang around, so the patient will come up here, and some of you can join the CT scan.
Yeah.
Yeah, as we do the ultrasound scan.
Of the appendix,
Yeah.
interesting.
Doesn't want anybody to come in, so. All right, so.
I mean, yeah.
Yeah,
So,
or you want more?
Sit up in your
You guys see a lot of appendicitis?
Yeah.
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 I've seen 2 in the UK in a year.
Yeah, it's like,
Just don't sit down. Let me just position it. Okay, that's lovely. Just. Sir, remind me your name again, please. What do you prefer being called? What do you prefer being called?
Nana.
Nana. Nana is fine?
Yes.
Is Nana okay? So, I've just not seen that previous shot. So, what's the first thing we look for?
The microphone never.
Okay, so do you want to keep the shot? Up behind. So, Nana, we just need your palm facing up, so on your lap, just like that. Is that okay? And the pain's been going on for how long now?
Like a year.
A year. Did he do something which triggered it off?
He had a stroke.
He had a stroke. Which side was the stroke?
The left side.
Same side?
Yes.
And did he fall when he had the stroke? So what was affected? Was the arm affected or the leg?
The left side was
the whole left side, including the leg.
The leg, yeah.
And he
has
recovered
a
quite
big-
well, did he? And what, has he been using a walking stick?
He has a stick.
So which arm does he hold it in?
For the right.
In the right
The
arm?
left, he doesn't do anything with the left.
Okay.
Yeah. We're now a little able to grab. Yeah. Before he couldn't even make a fist.
Right. So
It's
some
coming
of
up.
his weakness might be stroke, not necessarily a mechanical problem in the shoulder. So the pain started straight away after the stroke?
After the stroke.
And show me with your other hand where you feel it. Where's the pain? Just there. Does it go down there? No. When you lift, yeah. And where do you feel it when you lift? At the back as well. So palm facing up again. So first axially through the front of the shoulder. Yeah. And see where your mark is on the probe. Yeah. So and there's the mark there. So yeah. So that might be slightly more easier to handle. So where's the long of biceps?
Show me the long of biceps. Is there on your picture? Yeah, that's good. So that's the long of biceps and axial, and then a little groove of bone underneath it is the biceps groove. Yeah? So just scroll up a bit, go up slightly, just keep sliding up, keep sliding up. Yeah. So that's now the complete bicep groove. Yeah. And so can you see the biceps sitting in the groove now? Yeah. So it merges kind of imperceptibly. So just there is your transverse ligament which holds the biceps. That's the biceps groove and that's the biceps. So keep going up, a bit further up. Yeah, further up. So now you can see now the biceps is turning into the shoulder. Yeah. So it's there and you will start losing it. So as you go up, that's the subscapular.
So keep going up, a bit higher up, a bit higher up. So oops, did you see it went that way? Can you see the little white line? Yeah, so that little white line there. So that's the biceps, but because it's gone deeper in, the drop off of echo, so you can't see it. But that's where the biceps is. So go back again. So now you can see where the biceps was heading here. So that's the kind of intra-articular part. Then you don't see as it goes into the glenoid, that's too deep in. So there's a little bit of excess fluid along the biceps. So when you go back down again, so that dark little halo around it. So there's a bit of fluid around it. So that means something's going on, but it could be from the shoulder joint, it could be the supraspinatus. So now go a bit more medially. So you can see the subscapular and go up, actually up. So that's your subscapular tendon there, yeah? So that looks fine. That's what it should look like. Later on when we come back, we'll ask him to move a little bit and we'll do some dynamic movements as well. But now let's go for the supraspinatus. So that's the biceps and the subscapular done, yeah? You could see the biceps in the long axis as well. So get the biceps again in the center of your image. Yeah, and then turn it 90 degrees now so that you can see the biceps in the long axis. Yeah, keep going. So because it's a very thin tendon, you'll keep slipping on either side. But if you hold your hand still nicely, you can see it. So you are, I think, slightly on the edge of the tendon. So yeah, so a little bit is there, but you're still not cutting it in its entire length. Yeah, yeah. Oh, yeah.
90 degrees.
So, and keep rotating till you see a kind of longitudinal tendon. So you're still cutting it obliquely, yeah, so the tendon is a bit there. Yeah, keep rotating so you get it like so there. So you see there's the tendon. Yes. Okay, so that's good. Right, Nana, can we now have your hand go a bit like this? So just move forwards in the chair a bit. You can skip forwards a little bit. Okay, that's lovely. This is going to be a bit uncomfortable. Yeah, move forward a bit more, so there's a bit more space. Yeah, okay, that's lovely. Just hang on there. So now you have to be a bit fast because it's going to be a bit uncomfortable for you there. So now oblique axial. So that's the way to go a bit like this. Like that. And slide it from front to back like that. So that's, can you see the bone there? So there's the greater tuberosity and the humeral head, the round bit, the more medial. So that's the footprint where the tendon is, come medially. Just like this. So that's the footprint of the supraspinatus tendon. Yeah? So the tendon is coming there, and that's it there. That's the humeral head. So the capsule finishes there. So the intra-articular part is there. So the tendon is on outside all the greater tuberosity. The greater tuberosity can sometimes be a bit bumpy, as you can see it's a bit bumpy there. So it's probably a little bit of calcium kind of forming that little speck. Yeah. So now that, remember this orientation and go from the front all the way to the back like this. Yeah. Yeah, so that's a very good picture, excellent. So that's the kind of supraspinatus tendon, and as you keep sliding back, then you'll see the, so the supraspinatus and infraspinatus, they merge imperceptibly. So the infraspinatus below the spinous muscle, the muscle is there, but as the tendon comes up here, the supraspinatus comes from the top, and both of them merge into one tendon. So actually when they are inserting into the bone, they are fused into one into the other. But you can actually essentially say where the supraspinatus is finishing and where the infraspinatus is. But essentially they become one structure. Yeah, okay, yeah, that's brilliant. So once you've seen the supraspinatus and infraspinatus, then go on the AC joint. And just on top of the AC joint. Yeah. So you can see there's a bit of hypertrophy and capsular hypertrophy, a bit of degeneration there. But yeah, it doesn't look like he's symptomatic there. Just push it a bit and ask him if he's tender there. Nana, is that so? Where he's pressing? Is that painful where he's pressing?
Yeah.
Area.
Not particularly.
We're area. Now we are.
It's pushing on the top.
This one is not developed.
Yeah.
Okay.
So see, the AC joint looks degenerated, but it's not tender, so it's not symptomatic. So there's no point injecting the AC joint. Yeah? You know, go back all the way here like this. You might drop the frequency.
So I think a bit more like this. Yeah? Just show you the needle. Again, the probe, because it's an 8 megahertz probe, there's a drop off of the sound, but that's the back of the humerus there, and that's the kind of glenoid. So you can see there's not much joint effusion in the glenoid joint. There's no marginal osteophytosis, so I don't think he's got significant degeneration. So his problem seems to be the supraspinatus tendon, which clearly here shows tendinosis, and there's no clear-cut tear, but there's a lot of bony change on the footprint. And I'll just quickly see his cohort process. Can I have you all go back again on your lab? There is tenderness in the bone there, so let's check what's happening. So that's the coracoid process. So the coracobrachialis and the short head of the biceps, they insert. So I think he has a bit of tendinosis in the long head of biceps. So that's probably what's giving that pain in the feet. So bursal and long head. News is not too bad at all. You haven't torn anything. All your tendons are intact. Yeah. You have a little bit of arthritis in this joint on the top. That's nothing to worry. Yeah. We all get it. Yours is probably better than mine. Your shoulder joint looks very good as well. So that's also probably better than mine. But you do have a bit of inflammation in one of the tendons in the front there, which is what's probably giving you this discomfort there. Yeah? And you have a little bit of inflammation in the bursa on the top, which is why you're probably getting a bit of pain and discomfort getting things off shelves. So obviously some of your limitation might be the stroke. Because of the stroke, there might be a bit of weakness and things, yeah? But there is a little bit of inflammation there as well, which we can settle the pain, yeah? You will benefit from 2 injections. One in the bursa to calm the inflammation, and then one in the long head of biceps tendon in the front. For the injections, we'll get you lying down. We will start with the local anesthetic. The local will sting a little, just like a bee sting, then it shouldn't be too bad at all. Just for 48 hours, which is for a couple of days, it can sometimes flare up a little, so it can be a bit more sore. The pain can be a bit more, just for 2 days, yeah? It doesn't happen in everyone, but if it does, don't get worried. Just take paracetamol, ibuprofen, whatever suits you, yeah? Any painkiller should do, yeah? And then hopefully this will start kicking in by day 3, day 4. And the effect will keep coming in for about 4 to 6 weeks.
How long would it take that they came to subsidize?
So 4 weeks.
4 weeks?
Yeah, total 4 weeks, yeah. But it's quite possible by day 4, day 5, or by 1 week you'll say, oh, feels good, yeah. So it's a bit variable, but all of the effect will take 4 weeks to come in.
Okay.
So it'll get better, yeah, like that.
So in 4 weeks, that will be the best?
Yes. So yeah, in 4 weeks it will be probably the best. Yeah. But sometimes even in a week you might say it's really good. Yeah. And then obviously keep working. I'm sure he's exercising with physio and things to get his movement back, or he's not doing.
Because of the pain, he doesn't.
Oh, okay.
So maybe when. So
leave it for a week.
Yeah.
Then after that, then if the pain's all nicely settled, then he can ramp up his exercises for the from stroke point of view as well.
Okay.
So happy with all that? Very happy, yeah? Happy to go ahead?
Go ahead.
Okay, brilliant. These are not Radiologists. Do you have Radiologists too? So you will use it. stuffed that bag. So much stuff you didn't even think what you were getting. How old is your father?
83 in November.
Yeah, I'll just, if I need to take it, yeah, I can. So now we just pop a little bit of sterile tissue under your shoulders. If you just lift your shoulder up a bit, so yeah, just lift it up a bit. That's lovely, good. Stuff it in. But you can pop it back down, that's lovely. And arm by your side, arm by your side, and palm facing up. Okay, that's lovely. So we're just cleaning the area. You're going to feel some cold alcohol coming on.
Left. No, I'm right-handed, I think. I have to scan with my right hand because I'm on.
So scan with your right hand. Take this cable behind you so that it's not dangling. That's very important to get your orientation right, otherwise the needle is coming from the wrong direction and where is the needle, where is the needle? So what are you going for first?
Can I go for
No, go for the bursa first. Let's put the mark on this. Now you coming back, you just above the chin in that space. So that's just the dental so maybe supraspinatus finishes. The top one, that's a very bright line, so you're just heading for that line.
Those are virtual spaces.
Yeah,
We
so
just
so
have to
yeah.
see.
So coming to this place. So this place. Yeah.
So that's the outline of the person.
So just like this. So you have to inject with the left hand.
Just make it happen with this.
And then you go back a bit. Yeah, that's it. That's good. That's it.
And then inward.
Just one sharp scratch, and then a little bit of the stimming of the local. Different machines show the needle differently. Some show them very nicely, some don't. There are some special needles. So you can see your movement, but you still can't see the needle. Because you have to have visualization of the needle thing.
Yeah.
So go more vertical so that you're heading towards the tendon. Yeah, okay. Even sometimes you through the muscle, a little bit into the tendon. Yeah, and then now inject it and see what it feels like. So you need to open the seal in the wall of the muscle, and that's fine. That's just, yeah, not
Still in the wall.
Okay, so is it flowing quite smoothly?
Yes.
Yeah, it's quite smooth. So you're in the right space. So you can see the muscle space.
Yeah.
So that's it. That's enough to come up. And then all you need let go of the floor. That's not going outside this much. Sometimes it splurts. It will get in your eye. You're not allergic to plaster, are you?
No.
All finished?
Thank you.
Wasn't too bad?
Not too bad.
She's very good. Paula? Right, so in your own time, no rush.
Yeah, okay.
We can help you.
See if it froze. Froze down.
But sit on the edge, get your bearings. Don't jump off straight away. Both half, 3/4, all of the width of the tendon. Yeah? A full thickness tear is when it goes all the way from the top surface to the bottom surface, so the bursal surface to the articular surface. So it's like a hole in the tendon. Yeah? And again, it could be 1/4, half, 3/4, or all of the tendon torn from the uterus. A full thickness tear because the muscles, like a rubber band, it pulls the tendon back. So this won't heal. There is a partial thickness tear because the tendon still in place can heal. So a partial thickness tear we might still inject and hope that things might heal and it might do the job. But a full thickness tear is essentially a kind of surgical job for the surgeons to go and fix. So he does have a small full thickness tear which the steroid will settle the pain, but it won't sort his problem. It will come back again. So, but let's have a look at the other. Now, John, can I have your arm go behind you somewhat? And sorry, it's a very awkward position, but hopefully this won't be long. So he's got a tear in the front end of the supraspinatus system. Just trying to make out if it's a full thickness tear or a partial thickness.
I think it's near full thickness because there are just some of the fibers here and left. But that's all body tissue which is inflammation.
You did a good job.
Quite thick and inflamed. AC joint is okay. So I think that's a near full, but it's still partial.
So small full thickness tear, superior margin of subscapular, and near full thickness tear, anterior footprint. Could inject just to give him pain relief, but it will come back. So he needs to see.
Shoulder.
You can relax your arm back. So does he want the injection to buy time so that it can help? But he wants to do the. So John, the injection will take your pain away, but it's quite possible it will come back, yeah, because you've got a little tear. Yeah, if it comes back, then you probably have to see a surgeon who can go in and sort it. Yeah, are you happy to have the injection for the time being to buy you time? Yeah. Okay. Right. Okay. So let's just get the jelly off. And for the injection, I'll get you lying down. I'll start with the open. It will sting a little, just like the bee sting, then it should be clean. Yeah. So, John, we need your head on there, feet on the other end, just flat on your back.
You want his feet, his head here?
Left shoulder, yeah. That's it. So, we pop the pillow on this side. Leave your shoes, that's fine, don't worry, we'll change the shape.
What's the money going up? Somebody's trying to contact me.
When feeling the air, it's going to feel some cold crawl coming forward. And I'll have a look with some sterile jelly now, so we'll feel some cold.
Jerry coming out. Always get the air out because if you inject the air in tissues, that will destroy or something. You will see. So I have to get more or less that same picture here. So that's the space. The space is the subaqueous dorsal space, which connects with the space in front of the subscapular, supraspinatus, and infraspinatus. So it's like one sheet-like space. So once I'm in that space, it's spread everywhere. So it will be one sharp scratch and then the little stinging sensation. Just the body of the open, just the stinging. It was in the bursa and the apple just glides very smoothly into the bursa. So even though my needle is not in the right place, sometimes the needle can pin cushion. So I think it's really off, I took my hand off because I pushed it away. The muscle force will just pull back. Not necessarily, don't just put the syringe and inject without looking because it's possible the needle is popped out. So can you see it's actually popped out back here? It's just come out of the bursal space. You know, that pin cushion. So now I'm back in again and I'm just injecting this slow. It's going in. And finally you see the air which then comes from it. And as I pull my needle out, you'll see it coming out as well. Hold on. You okay? No, same person. Because they are. Yeah, the biceps. Right, so if you're feeling fine, then you can hop off. Yeah. And all free to get dressed and go. Just for a day or so, it can be a bit more sore. Yes, it can be a bit more painful than it is. If it happens, don't get worried. Just take paracetamol. This will start kicking in by day 3, day 4. And then hopefully all of the effect will come in 4 weeks. This should definitely settle your pain, but it's quite possible it will bounce back. Yes, we'll be fine for 3 months, 4 months, 6 months, maybe a year, then it will come back. If it comes back, then you need to see a surgeon. Yeah?
You have a nice dress. Lovely dress.
Do the dress first, then the brow next. One at a time. Good. Okay, perfect. That's the way. But now just sitting there.
Quite severe. Okay, so she has shoulder pain, potentially also sometimes. Important thing about doing this kind is to find out whether the tendons are intact or not. You decide the specific treatment you can give to the patient. So Dr. Ash will give you a bit more information.
So when you see osteoarthritis, apart from the osteoarthritis which you can see in the reduction in the joint space or margin osteoarthritis, you look at the acromial space and that should normally be more than 5 millimeters. If it's less than 5 millimeters, then it means that the rotator cuff may be torn as well. So sometimes you get osteoarthritis in the glenohumeral joint because of rotator cuff tears. Right? So that's known as cuff arthropathy. Okay. So the cuff leads to the osteoarthritis, and there's a grading for that. It goes from stage 1, stage 2 to stage 5. So the cuff tears, the moment the cuff tears, the humerus starts rising up, yeah, because there's nothing to hold the humerus down, yeah, and then it starts hitting the acromion. The acromion starts acetabolizing, so it forms a little cup-like thing, the undersurface of the acromion. So that's stage 4, yeah, when the acetabolization. And stage 3, and then stage 4 you start getting osteoarthritis of the glenohumeral joint. So if it's a cuff arthropathy, then the treatment is a reverse shoulder replacement. Okay. You know what a reverse shoulder is?
Okay. So you have the ball sitting in the cup. It's a normal joint. Instead, you get the ball in the so-called cup and create a different cup to receive it.
No, you get the ball.
So the head, you create a cup on the head. Okay. And create a ball on the cup. It's reverse.
So the normal joint is a cup and a ball, yeah? But with the reverse shoulder replacement, they fix a ball here.
Okay.
So the ball is here, and they put a cup in the humerus. So it's the other way around. Yeah? The reason for doing that is it pushes the axis of the shoulder out. Yeah? So normally the center of the rotation is somewhere there. Yeah? And when the center of the rotation is there, when I move my arm up, the deltoid can pull it up to there, but the deltoid can't pull it any further up because the shoulder humerus is too close to the glenoid. Yeah? So then you need the supraspinatus to get it up like that. Yeah? But if your supraspinatus is torn, then if you put a normal shoulder replacement, he still won't be able to get his arm up because the deltoid doesn't have enough leverage. So by putting the ball in the glenoid, you push the joint out. Yeah? Okay. So now the deltoid can push the arm up. Okay. Wow. So you get a shoulder replacement and the arm goes up because the deltoid is doing the job of the supraspinatus. So it's useful to kind of know that is it just osteoarthritis, in which case you will need a TSR, which is the normal cup and ball. Yeah. But if it's the cuff is gone, then she needs a reverse TSR.
You don't do the normal shoulder joint, and you get the reverse shoulder joint, it's going to go with but it's good to know.
So just looking at the X-ray, I don't think a cuff is torn because the acromial space is preserved. Yeah? So it's probably just osteoarthritis. In which
the gap is not bad here.
So in which case we can just inject the glenohumeral joint to give us some pain relief. Yes. But again, that won't be long lasting because it will come back again. But it will buy her time. So at some point then she will, if it gives her a year or so, then we can keep repeating. So next time when we come, then we can do her again.
Is that there's just OA? Is that the case if there's just OA? So you would, even if it's just OA, rotator cuff is fine?
Yeah, if the rotator cuff is fine, and if it's just osteoarthritis, either she can live with it, or she gets a total shoulder replacement.
So in the meantime, would you inject?
Yeah, when inject just to give a pain relief.
So if the head, you find out the head is right under the arch, the cuff is gone.
Right, so Elizabeth, I'll need your palm facing up, and I'll pop some geline, we'll have a look. Is that okay? So your shoulder's been giving trouble for how long now?
5 years.
5 years. Does it make noises? Creak, creak, creak? No noises.
Well,
is that for impingement?
No, crutches. The noise from the head on the cup. But sometimes they don't actually understand. And you have to demonstrate to them, they say, is that what you're talking about? Yeah. I get that noise.
So you can see there's a lot of fluid along the bicep. So clearly something's happening. And like we said, it could be the tendon itself, which looks fine. It could be a rotator cuff problem. It could be adhesive capsular. She's too old for frozen shoulder. Frozen shoulder is 40s and 50s. Or it could be trouble in the shoulder joint. So from the X-ray, we already know she has trouble in the. So it's the arthritis in the shoulder which is creating excess fluid, which is then popping into the. So the subscapular is just about seen, so I can't see it very well. So I might get her to kind of move her arm out. Now, Elizabeth, can I have your palm facing up, but a bit out like that? That's lovely. You can see subscapular is okay. Even here you can see there is osteophytes. The humerus is kind of very bumpy. Okay, back again. And now can I have your hand poked behind you? So if you just, so you can see the supraspinatus tendon is okay. Yeah? It's not torn, it's there. And no calcification. The AC joint shows more radiative changes, which is expected. And you can have a look at the shoulder joint at the back. So if the depth is a problem, then reduce the frequency. Yeah. So most of these probes are multi-frequency. So if you're trying to see something deep and the probe isn't reaching, then you can reduce the frequency, but the resolution drops. So see, even reducing the frequency, I'm still not getting past the muscles to see the joint very well. So you can swap the probe, so you can use the sector probe. time I can actually up the frequency, so gone up to 5 megahertz. Can put the focus up as well. So you can see a lot of osteophytes at the back. So quite an athletic shoulder. So two options: we can inject a joint with steroids to calm the synovitis and the inflammation, or we can also inject the suprascapular nerve. So the pain is being transmitted through the suprascapular nerve in the shoulder. So you can block the nerve, and that's just blocking the pain kind of passing through. So when you have a bad shoulder, those are kind of two options you have. I think let's inject her shoulder and back shoulder. So we'll have to get her working on her back and then come from there to the shoulder.
Is the nerve a bit more complex?
The nerve is also the nerve is just sitting there. You come from there like that. You can do that with a same. But because I can see there's a bit of joint effusion there, so it's in the shoulder's joint to try and calm the inflammation in the joint. Yeah? This won't reverse the arthritis. This won't take the arthritis away. Right? So the arthritis can only be sorted by a shoulder replacement. But this can buy you time. So this can reduce your pain. Is it very painful? Does it wake you in the night?
Yeah.
Yeah. So that can settle with the injection. So the pain will go down, but your limitation won't improve. So you still won't be able to get it behind your back. Can you get things off shelves? No. So chances are the limitation will stay, but the pain will go. Are you happy to have the injection?
Yes.
Yes? Okay. So I'll start with the local anesthetic, which will sting a little, just like a bee sting. Once it starts taking effect, it shouldn't be too bad. So happy to go ahead?
Yes.
Okay, good. Now just for a couple of days, for 2 days, it can sometimes be a bit more painful.
Yeah.
If it does flare up, don't get worried. Just take paracetamol and that will settle. Then this should start kicking in by day 3, day 4. So happy with the plan? Okay, good. So I think we'll get her lying on her. Are you able to lie on your tummy?
Yes.
Yeah? Okay, so we'll get you on her tummy so we can leave the pillow outside. So yeah, you can pop this on the. Hopefully this won't be long. Okay. So just cleaning the area. I'm going to feel some cold alcohol coming on. So how many languages does Ghana have?
Many. So many.
Double figures or triple figures?
Oh, triple.
What?
Yeah.
Triple?
Yeah.
Yes.
More than hundreds.
If you go to the north,
Alone.
Wait, languages or dialects?
No, languages.
languages.
Not dialects.
No, languages. Languages.
And which is the one which most people would understand?
Ashanti. Ashanti. No,
Ashanti.
Yeah. The Ashanti language, that's Chi.
Tree.
Yes.
Is there one called Ga?
Yes, yeah, in Accra here for the guns.
Ga.
Yeah.
It's like Ga.
So that's the back of the uterus. The glenoid is somewhere there. So that's all joint. That's actually fusion in the joint. So that's infraspiratus. So you can see the infraspiratus got lifted up because of the joint effusion. So we just need to come, and that quite a good patient to kind of see where the capsule inserts. So the capsule inserts a long way. So when you're entering the glenoid from the back, you can be here, and you're still in. So there's a kind of large area or trajectory available for you to get into the joint. So it will be one sharp scratch and then the little stinging. So sorry about this. Just the burning of the local, just a sting a little, just like a bee sting. Just waiting for the anesthetic to start taking effect. So that's when we do it. You can see it is quite low down there. But you can see my angle is quite low. So if I can so I'm not going to go into the joint with this needle because this needle is orange needle, it's not big enough to reach. So just sterilizing so that when we use the bigger needle, it did really well, excellent job. Just a bit more of the pushing now. Can you see my needle? And now through the joint. The patient just feels it as you go through the joint. You see the local kind of this gurgling in here. And give it a bit more looking between the fingers and the knees. In the right place. Filling up the joint. So all done. Is you okay? Okay, so any which way you can put pressure on it if you want, but don't fall off, yeah? Be careful. We've got 6 people looking after you on the other side.
You can see on ultrasound as well. So let's have a look and see how bad the knee looks.
There are 4 patients.
So that's the quadriceps tendon, and that's inserted in the patella there. So the quadriceps tendon itself looks okay. You can see there's a little bit of a joint diffusion just there laterally. There's some osteophytosis coming from the lateral edge of the patella. And those little bumpy things there, that's synovial. So that's kind of synovitis. So not much of a fusion, but clearly there's some loose bodies, and there's one there. You can look at the lateral joint line. So that's right. So marginal osteophytosis. So that's the tibia there, that's the femur. You can see it's got kind of lifted up a bit. Marginal osteophyte there as well. You can see the peripheral part of the lateral meniscus. So she has reasonable OA in the lateral compartment. And quite a lot of OA in the medial compartment. So again, marginal osteophytes. The joint space is completely gone. So the lateral space is still preserved, but here the meniscus is extruded out. So it's lying kind of partly outside the joint. So when on the X-ray you say the joint space going down, it's a combination of the cartilage varying and the meniscus moving out. So as the cartilage varies, the meniscus elements they degenerate and the meniscus just shifts out. And that's why the space becomes.
Show me the meniscus.
So that bit will be there.
Okay.
So it's kind of
Is that how
general.
they normally look, or is it because our background? Is that how they normally look?
They
You
don't
know, like
strike
if they're,
back.
no, obviously
Yeah.
if they are.
Queued up.
Is it desiccated or is this how it normally looks?
No,
Is it
no,
considered
so-
desiccated?
It's some
Same thing in Nigeria, so you can choose to focus on one consultant and then some specialty. So I consulted only the MS. Is there a solution of that? After she became she's like specialized and before she started working. That was specialized. Yeah, she really wants to. Yes, it could be positive. I just wanted to see. No, that's essentially.
do that every day. It's not number. Like 80%, 70% of what you do, when you're regular work, will still be done. Still be done on call. And then 70% of what you do is daytime. It's focusing on that specific.
As the bed can't go up, I'll have to go down here. So one sharp scratch and then the little stinging sensation. Sorry about this. Just the burning of the local, this does sting a little, just like the bee sting. And that's my needle take here. But again, I won't attempt to get in using this needle because it's too short and but the shorter the needle, once you let go, it pin cushions more. So it will keep bouncing in and out of the joint. Just a bit more of the pushing now. And you will just feel this as I go through the joint. Sorry about this. If there's a lot of fluid, you can aspirate it as well. So in the knee, it also there is fluid. So I can kind of show that if I suck, I can actually get fluid out there.
Yeah.
That's the knee joint. That's one done. You okay? Good job. Just the burning of the local. We've given her the maximum of the local that we can give in one go. This one, even the long green might be a bit short. If it is, then we might have to use a black number puncture, but we'll see. Just a bit more of the pushing now. You just feel this.
Something's happening.
No. Don't tell me, you can use to view the too much. Okay.
Right, so Joyce, I'm going to pop some jelly and we'll have a look. Is that okay? So for the first bit, we need your palm facing up. You just rotate the back and just a bit of the jelly. So when did the right shoulder start playing out?
About how many years you said? 10?
10 years.
Oh, 3 years. What do you do for a living? Oh, clothing. You make them?
See, longer biceps. More swollen than you would normally expect. The subscapular in the superior footprint. So there's a bit of problem in the subscapular as well, but we try to move our arm to see that better. And again, the longer bicep, you can see longitudinally as well. So I think there's definitely a bit of tendinosis there, but it's intact, it's not torn. Sometimes the longer biceps will rupture. When it ruptures, it gets pulled back into the arm. So you get clinically you get that Popeye appearance where the
You've seen one before?
I've seen one before.
None of you? Oh no. That's good. They come with their tennis ball there.
yeah. So the like the cartoon character Popeye.
Yeah, Popeye,
So
yeah.
his biceps like that. So
again, a lot of tendinosis in the supraspinatus tendon. You can see there's cortical bony change at the footprint. There's a small articular surface partial thickness there. So that little black thing is a kind of hole in the tendon, which you can see from the sag orientation as well. So you can see there's a little gap there and the fluid kind of. The subacromial bursa is thickened. AC joint shows detailed changes. Joyce, is this tendon where I am? This particular spot?
Area.
Yes. And that's the infraspinatus tendon, so that looks like that. So that's the AC joint, yeah? And so that's the clavicle, that's the acromion. And as I come behind the AC joint, let's see what's that little bump there? There's that little bony bump. Any idea what that is?
It's still bony.
It's still bony, some hypertrophy. I don't know why. What inserts?
It's an exostosis.
Oh.
It's a small exostosis coming off.
Yeah.
You can actually see the cartilage cap on it.
Yeah, that's why it's low density.
That's the giveaway that it's an exostosis.
I've never seen one in the equipment. It's usually in long bones.
So that's probably incidental.
Okay.
Right, so you can relax your arm back. Sorry about this, Joyce. I'll just get the there, and that's creating a lot of inflammation. So the injection in the bursa and in this joint on the top might help calm the inflammation. Are you happy to have the injection? Yes. So for the injection, we'll get you lying down on the couch and start with the local. So it will be one sharp scratch, a little bit of the stinging of the local. Once the local starts taking effect, it shouldn't be too bad. But it will be two separate injections. One in the bursa and one in the AC joint.
That's me.
We don't do that.
So you've seen a lot of them. They come. They come. But they are more like incidental findings. Incidental. Yeah, but that's not really why they just see the constitutions or going up like ascending.
Okay. And you don't screen them for cancer? You don't follow them?
Oh, well, yes, we do. Like once we see that today.
So again, same thing. Get your bursa in line with the growth. So that's the humeral head, that's the supraspinatus. I'll come in somewhere from there, and we need to get into that space, yeah, in black space. There will be one sharp scratch, and then there will be stinging. So like this, just the volume of the doorway, just sting a little.
Embarrassing all shoelaces I know in this country.
So now you can see how small that bursal space is, yeah? And imagine, do you think anybody can hit it blindly?
No, sorry.
Sorry for
Sorry.
Well, you know, we have X-ray hands.
So now I'm in the right space. So you can see the air then fills up the whole space. So that's one done. So we're injecting the AC joint as well because that was symptomatic. So again, first find the AC joint axially. So again, that's the abdomen, that's the clavicle. the capsule, but it will be hard to come like this because the capsule is kind of up to there, so to get into the space is a bit hard. So if I turn my probe 90 degrees to that, then I see the AC joint as an American football. Yeah? Now this is the joint space. Invariably, AC joint has a little bit of crystals which kind of give you that. So this looks like it's bone, it's not bone, it's just the space with crystals in it. So that's right, this slice is right through the joint. And then if I go a bit to the left, the acronym, and if I go a bit more medially, the clavicle. So that's the slice I need to be in. But sometimes the AC joint isn't a straight line, it's hardly ever a straight line, it's always a bit like that. Yeah? So it's possible my probe might not be absolutely straight. A bit like that. And if it's a bit like that, then my needle also needs to be in that same way. But if my needle is like that, then I won't get it. So it has to be a bit like that. So, and for injections, you immediately need to become ambidextrous. Because now I can't inject with my left hand. There's no way I can go like that. So I'll have to hold the probe with the feel a lot of pressure there, Joyce. More pressure, more pressure. Doing really well. It's a bit tight in there. More pressure, more pressure. All done. You okay? You alright?
Nothing.
It's lucky you survived. Because that's where your main artery is.
It's getting close to the computer.
So you get a gunshot. It was shot in the groin, very close to where his femoral artery is. When was this? How long ago was this?
Almost 4 nights.
Did they manage to catch him? Yeah? Is he in jail?
Yeah.
Yeah? So the reason we are doing this scan is to make sure there are no signs of infection. Because Paul is trying to give you a new hip. Before he goes in, he has to be absolutely sure that there are no signs of infection. Don't want to prefer So that's the hip joint, that's the capsule, the femoral head, the acetabular. So you can clearly see there is no effusion. That's a big sign. That has a bit of arthritis, you can see the margin wants to form. That's where his intercostal fracture is, you can see where the cortical state. The bullet went in from there, did it come out?
It didn't come out, it was somewhere here. So we
Did
took
they
it
take it
out.
out? So I think it must have ricocheted off the big bones or something in there.
And then I had a couple of those, so they injected me.
No collections. Still quite a big cortical stem. Yeah, shows the cities show. Okay, so that's all done. We'll just get the jelly off. So good news is nothing to say there's any infection there. So hopefully one can start. Just get the jelly off. I'll give you some more tissue in case you can feel this.
It's just that it's not mandated.
That's the jelly in the
to make sure everyone's okay.
If it's indicated, you can find that. Sophie, so if you will call me home about it.
Okay, so you will come back before or you
I will call again. You have my number. What's up? Thanks for your patience.
Don't sit down.
Why? You came to talk to me. You didn't come to me.
That was not possible.
You know why I go to the all the time? Just to
You do?
I do. In theater.
Right, so you do have deconvenienced sinusitis. So I'll show you as well. So that's actually through your first extensor compartment. So those are the two tendons which set in the first compartment. That's your extensor pollicis brevis, the pollicis rhamphus. Just there, they only pass through a little tunnel here, and that's where they can kind of get infected. Historically, it used to be washing clothes here, but now nobody washes clothes. They're washing here. Now the commonest cause is actually having small children lifting them. Yes, when your thumb kind of goes in that direction. In fact, I got it as well when my son was roughly the same age. I used to hold him like this, and I used to use my thumb to stabilize him so that he was looking that way rather than that way, and triggered off. So you can see the tendon sheets of that black hair. So that should be paper thin. So it's affecting only one of the tendons, your extensor pollicis brevis. Sometimes the whole sheet also gets inflamed. So it's not too bad. It might settle once obviously your child is a bit bigger and he's walking around and you're not able to lift him that much. You could still keep using that splint that you're using. But we can inject this as well, and that can settle down quite quickly. You've had one. Did it help? Right. Yeah. So it can sometimes obviously bounce back if you're still kind of doing the activities. So if it keeps coming back, then there's a surgical option as well, where surgeons can go and kind of release the tendon sheet. But majority of the time, either it will settle with time, splint, conservative, or injection. Hardly anyone ever needs surgery. Yours doesn't look too bad. So when it becomes very stenosing, when it becomes very thick and this thing, then the injections won't help. And this one, I think injection should help. But if it's already getting better, then we can wait and watch. But if it's not getting better and you think it's kind of come to a standstill, the injection might kind of push it in the right direction. The risk of the injection is these injections are quite superficial. So sometimes they can cause lipodystrophy and leukodystrophy. So you can get a little whitish patch. When you lose the pigment, if it does happen, it's cosmetic, couple of days in the sun and it will come back. If you get lipodystrophy where some of the fat gets absorbed from the skin, that can take longer to come back, but over a couple of years it will. So it will be one sharp scratch and then the little stain. Since I saw about this, just the burning of the growth, just a stain a little. Just feel this as I go through the yeah. The space in that tendon sheet is very tight. So if you can't get in, you can go behind the tendon. Yeah? So if I come from the top, then it's very hard to go behind the tendon.
Oh, I see. Okay. So you want to do similar to what we did earlier, so lift it up. You want to inject underneath.
No, there isn't space to actually lift it up. The tendon quite often swivels, so when I put my tendon, you will see it rotates. And when the little hub looks like as if it's in the tendon, but as I inject, the fluid will go in the tendon sheet. Can you see it's filling the All done, performance? Wasn't prepared for it?
Well, it will be deeper.
But that's where it kind of comes out of it. It might be
Like a kilowatt, yeah.
Scott.
Yeah.
Which side was the laboratory? Left?
It is the central.
Okay. There's a track there. I haven't seen a collection yet, but I'll have to use the other phone to look deeper.
Yes, ma'am. New device. Open up to the red man. Wash it up. Right. MRS. And I'll have to look at detail here. Okay, gotcha. The scan will be on our system.
The postdoc here?
Yes, yes.
Is it like a hemostatic?
Yes.
How much do you expect? Like some
more, I guess it was. And then the
that was the second time.
I only went to once.
You did the original surgery?
Them turn into larvae, and the larvae travel to the liver. They can essentially travel to anybody in the to any organ in the body, but they mostly go to the liver in 70% of the cases. They then lead to cysts that are fluid-filled, and these cysts may form daughter cysts, and then the daughter cysts can be associated with inflammatory granulomatous or fibrous reaction around them. But this is the active stage. Then they degenerate, and then they calcify. So we'll look at the evolution in a bit and how it's treated according to the stage.
Presentation obviously depends on the organ that's affected, so you'll see focal signs that are mainly due to mass effect. And obviously the number of the cysts and how large they are, their size, also dictates symptoms. In 3/4 of the cases, there are no symptoms at all. In the liver, obviously, right upper quadrant pain is usually the key presentation. Ultrasound is actually the modality of choice for abdominal cystic echinococosis. So it helps diagnose because some of these findings are actually typical for it. What else looks cystic and has a lot of cysts within it? You know it's echinococosis, especially if the patient comes from a sheep farming population. Secondly, it helps you stage the cyst, and by staging the cyst, you know how to treat it. You'll help the clinicians decide on how to treat it, because we mentioned there are active stages, and then there are intermediate stages, and then there's a degenerate state. After it degenerates, they're less likely to go in and aspirate. So I'll discuss clinical findings in a bit, but for now, just remember the stages. So in CE1, so this is the WHO classification that's used worldwide. So in the initial stages, it's essentially a big hypoechoic cyst, which can be treated with PER, which essentially I think means it's percutaneous aspiration, and then you inject treatment, and then you re-aspirate. So they go in because this is the active stage. The second stage, you don't need to do any percutaneous treatment, it's just treated, it's essentially treated medically, and then in the later stages, it's degenerating, so you just wait and watch. So by diagnosing and telling the clinician what stage the patient is at, you're helping them, you're guiding treatment. So the protocol, again, there's a protocol that's been designed in some areas of East Africa and South America where this is endemic. So the protocol is called FACE, Focus Assessment with Sonography for Echinococosis, and the 4 standard images of the liver are obtained, the usual stuff: epigastric, sagittal, epigastric, so transverse epigastric, sagittal epigastric, subcostal, and then intercostal. Ultrasound findings, we'll discuss the stages of the WHO classification. So type 1, according to Garvey, forget about Garvey, let's just focus on one page. Thank you. So CE1 basically shows a univesicular anechoic cystic lesion. The way you can differentiate this from a simple cyst is by looking for a double line sign. So if you can see two lines in the wall, it's more likely to be echinococosis and it's likely to be a simple cyst. I'm not sure if you can appreciate it, however to zoom in here, but take my word for it. If you focus on the wall, you'll see 2 lines. If you can appreciate, there are 1, 2 lines, okay? CE2, the next stage, shows a multiseptated, can you appreciate the septa here? Rosette-like honeycomb cyst. And then the third stage is when membranes start to detach, and then you get this view, this sign that's called the water lily sign, because septations start to actually degenerate. So you know the cyst is degenerating. And then the next stage is when the cyst starts developing daughter vesicles, so you can see plenty vesicles in a solid matrix. So it looks like an ovary with a stroma and follicles. Just remember that. CE4 is when the cyst is heterogeneous, so hypoechoic or hyperechoic, and there are no daughter vesicles. And then the last stage is when that's it. There's no more cyst, it's just calcified walls with a degenerating cyst. Any questions on echinococosis? No? So next thing is amoebic liver abscess. A liver abscess, which again, I'm told you guys have seen a fair amount of. I've never seen one. So if you have anything to add, feel free to pitch in. So it's endemic worldwide, especially in tropical countries, so Africa, South America, and some parts of Asia. The agent is Amoeba histolytica. The route of infection is orophycal, obviously. It goes to the colon, causes colitis, but in 10% of the cases it enters the bloodstream. And the organ that it most frequently goes to is the liver, by contiguity through the portal vein. And that's why it usually goes to the posterior aspect of the right lobe, because it's more contiguous. The presentation, if it's in the liver, is right upper quadrant pain, and then you get fever. So diagnosis is made based on an array of things. So there's a history of possible exposure, there's clinical findings, sonographic findings, and if you can obtain a stool sample and send it to the lab, and if you can do serology, this is more likely to aid in your diagnosis. Treatment is through antibiotics, and sometimes we might aspirate a bit of the cyst. Aspect of the right. The way you differentiate it from a pyogenic abscess is that it's hypoechoic, it's usually not anechoic, it's round, and it's homogeneous. And it doesn't have a clear capsule. So look out for these things. And there's no gas. There are no gas bubbles within it. Obviously, not every pyogenic abscess has gas bubbles, but if you see gas, it's more likely to be pyogenic. So this is how you can help your clinician. Sometimes you might see hyperechoic areas that represent debris at the center of the periphery, but it's usually homogeneous. So if you see these findings, raise the possibility of mimic abscess to your clinician. Differentials again are pyogenic abscess, so you see gas. It has an irregular shape. It's not homogeneous, regular, and they're multiple. If it's abscess, and it's because it's abscess, pyogenic abscess is more likely to be multiple. Another differential is brucella. It comes with central calcification. Again, interrogation helps the patient, if the patient is a farmer or there's a history of them drinking pasteurized milk, and think of brucella abscess. And then finally, always bear in mind, and you guys told me yesterday, cancer is very permanent here, a lot of cancer. So always bear in mind the non-infectious lesion could be a necrotic tumor. So this is an example of an anembic liver abscess posteriorly. So location number one, it's posterior in the right lobe, it's homogeneous, it contains some debris, and it's hypoechoic, and it's regular shaped. In contrast, this is a pyogenic liver abscess. See how its walls are irregular? They're not regular. It contains gas bubbles, and you can see artifact here. And it's anechoic with some hypoechoic areas, so it's not homogeneous. Okay? And look at the wall. There is a wall, whereas here, the wall isn't as clear here. Any questions? Schistosomiasis next. It's endemic in areas where there is where people get in contact with fresh water, so areas in Africa, Latin America, and Asia. The agent is a waterborne helminthic infection called schistosoma. Worms basically enter the bloodstream, the venous circulation through the skin. Enters venous circulation, lay eggs, and then the eggs then travel to the GU tract or to the GI tract, and they get trapped there. And that's how they cause fibrosis, because the body is reacting. So they cause a high burden, high mortality, mainly because of how the body reacts to the eggs. So it's the fibrosis and the inflammation around the eggs that actually causes problems. Morbidity is very high, and it persists even after the eggs are no longer detectable in the stool and the urine. That's why it's very important to detect it early, before the patient reaches the stage of fibrosis and inflammation. And that's where the role of the radiologist is, to pick it up early. So we'll discuss intestinal schistosomiasis first. There are two different agents, Monsoni and Japonicum, I think. Monsoni is more frequent in Africa, Japonicum in Asia. As we mentioned, if it goes to the GI tract, the worms mature in the portal vein. So most of the signs will be around the portal vein. Bear that in mind. That's why it's important to know parasitology. That's where first and second year medical knowledge goes in. So adult worms mature in the portal vein, and the eggs get entrapped in tissues, bowel wall, but essentially periportal area, and it causes inflammation and fibrosis. So you will see signs of fibrotic liver, but it will be periportal. Clinical symptoms, usual stuff: abdominal pain, GI bleeding, malabsorption if it's in the bowel wall, hepatosplenomegaly, and fever. So diagnosis is obtained by taking a stool sample and finding eggs, but sometimes larvae are not secreting many eggs, and you won't see any eggs in the stool. That's why you need an area again of tools for you to make the diagnosis. PCR testing is also helpful, but it's costly in many parts of the world and it's not accessible. And in terms of what clinicians can do, it's treated medically, and then endoscopy is done when the patient reaches portal hypertension, because that's how mortality happens: periportal fibrosis, and then generalized liver fibrosis, and then the patient develops portal hypertension, and then you get esophageal varices, and then they bleed. So that's how it's deadly. How POCUS can help? It helps by, again, you can just use the usual standardized liver views and identify reversible fibrotic changes. So if it's periportal, you know it's early. If it's generalized liver fibrosis, you haven't detected it early enough, and your patient is they'll develop portal hypertension and they will bleed. So try and identify fibrotic changes and know where they are, know your anatomy. At this stage, they can give antihelmintic treatment and do ultrasound follow-up. Follow-up of the fibrosis. If POCUS identifies this, you're helping your clinician, telling them that, okay, these are early stages, this is how I want you to treat the patient. But if there is generalized fibrosis, then you know the patient is at imminent risk of bleeding, especially if you see signs of portal hypertension, which I'm sure you guys know. Then you're basically telling your clinicians, hey, treat, but start thinking of doing endoscopic sclerotherapy and anticipate esophageal leads. So what you can see on ultrasound is increasingly wide periportal liver fibrosis, which shows as echogenic rings, streaks around the portal venous branches. We'll see an example in a bit. And then the usual signs of portal hypertension. So dilated portal vein, dilated splenic vein, collateral portosystemic vessels, gastric, periumbilical, splenorenal veins, and enlarged caudate lobe, which is the sign of cirrhosis, splenomegaly, ascites, and hepatofecal circulation when you light up your Doppler. Can you guys appreciate the fibrosis around the portal vein? So this is the portal vein for first years. There's fibrosis around it. So it shows as bright hypercoic streaks, depending on whether you're axial or sagittal. If you're sagittal, it streaks. If not, otherwise, if it's transverse, then it shows as a ring. Urogenital schistosomiasis, again, it's seen within the same population. It just depends on where your eggs are going. If they go to the liver, you see the liver. If it goes to the GU, you'll see the GU, because the agents are different. The agent in urogenital schistosomiasis is Schistosoma hematobium. So same story, adult worms mature in the vesical plexus, and they lay eggs, and then the eggs get trapped, and they lead to fibrosis of the bladder and ureters. And because the ureter is a duct, if eggs get trapped, and the body reacts by causing inflammation and fibrosis, your ureter will get blocked, and that will lead to obstruction, and then with time, kidney failure. The other risk is obviously squamous cell carcinoma. It's associated with high morbidity, especially in children, by leading to kidney failure. Clinically, the usual stuff: hematuria, UTI symptoms, dyspareunia, infertility, fever, eosinophilia, and anemia. Diagnosis is made by detecting eggs in the urine, but as I've mentioned earlier, not all of them detect a large amount of eggs that you can detect. So ultrasound is also helpful, and it's treated medically. The key thing is, we've discussed this yesterday, if you see a polyp in the bladder and you've raised the possibility of schistosomiasis, follow up the patient, make sure you've bottled them up. If the polyp doesn't reduce in size despite adequate medical treatment, suspect cancer and raise that possibility to the clinician. Because clinically you can differentiate, the symptoms are the same. They all bleed, they all have UTI symptoms. Protocol is essentially straightforward. You do in the right quadrant, right upper quadrant or flank view to look at the kidneys, and you do in a pelvic view to look at your urinary bladder. Findings are irregular thickened bladder wall, and the bladder obviously needs to be adequately distended for you to comment on that. If it's not distended, you can't comment on the thickness of the wall. Secondly, you might see polyps or masses in the bladder, or mass-like fibrosis. And then if it's advanced, you'll see upper urinary tract dilatation. So hydroureter and hydronephrosis. So as you can see here, this is a thickened, irregular urinary bladder wall and hydronephrosis. Any questions on schistosomiasis? Okay. Viral hemorrhagic fevers. Told that you guys don't see much of these. It's mainly Nigeria. Yeah. Never seen any myself. So there are different types. There is a variety of viruses, dengue, Ebola, and Crimean Congo hemorrhagic fever are the most common ones. And it's seen in many parts of the world. So America, Africa, and Asia. The presentation is fever, muscle pain, headache, abdominal symptoms, hemorrhagic phenomena, and then it leads to shock and death because it causes plasma leakage. It's important to know the clinical findings and know the pathophysiology to anticipate what you can see on ultrasound. So we're basically looking for fluid because we know it leads to death by causing plasma leakage. So watch out for fluid in the pleural space, fluid in the peritoneum, and fluid in the pericardium. Diagnosis is done microbiologically, but there is a lot that ultrasound can help. You can essentially help in two ways. In ITU, it can help with volume status assessment. Because isolation is required in these patients, ITU doctors can't do much physical assessment. That's why ultrasound is helpful. And they can just do a fluid assessment by looking at the IVC and seeing how distended it is, looking at the LV function, so left ventricle, and pulmonary edema, so they know whether they're giving too much fluid to the patient or too little fluid. So it helps guide treatment in ITU. So you're looking for effusions, pericardial pleural ascites, and the other sign is gallbladder wall thickening, subcapsular hepatic fluid collections. Again, the mechanism is plasma leakage. So this is an example of gallbladder wall thickening. And if, again, that's why clinical history is important, it's not cholecystitis. It's hemorrhagic fever. And there's free fluid around the spleen. Lymphatic filariasis, I'm told you guys have seen many of these, I've never seen one. It's endemic in some areas in Africa, Asia, and Latin America. The agent is Wucheria bancrofti, which is a worm. It's transmitted through mosquito bite. It's a very disfiguring, disabling disease because it leads to elephantiasis. That just means your legs are very wide, you look like an elephant. And they can also lead to a huge hydrocele that's debilitating, and patients are essentially disabled and they can't walk. They're sitting in a wheelchair because of how huge their scrotum is. Again, it's important to know the pathophysiology because you know that it destroys the lymphatic system and it causes lymphoceles, and that's why you know you're looking for fluid along the lymphatic vessels and you're looking for fluid in the scrotum. Diagnosis is made microbiologically, and again, ultrasound is very helpful because you're guiding clinicians decide their approach to treatment. If the hydrocele is hyperechoic and complex, the surgeon is more likely to dismiss it to scrotal surgery straight away. But if it's echo-free and you're basically telling them there's low risk of necrosis and inflammation in the scrotum, they're more likely to treat medically with doxycycline. It's mainly helpful in looking for pathology in male patients in the scrotum, because if it's in the lower limbs, it's easy. So you'll see dilatation of inguinal lymphatic vessels, which is referred to as lymphostil. Another sign that you can see is filarial dent sign, which essentially is moving worms in supratesticular lymphatic vessels. But this is not a specific sign, because megasperm in patients who have had a vasectomy can also have this sign. So always bear in mind your clinical and epidemiological findings. The hydrocele can be echo-free, or it can be hyperechoic, and assess the skin, so scrotal skin thickness. Is it thickened, is it not thickened? The reason this is important is because you're telling the clinician how severe you think this is. So if hydrocele is large volume, and if it's echoic and scrotal skin is thickened, the patient is more at risk of developing scrotal inflammation and necrosis. So not only are you diagnosing, but you're also telling your clinician how severe you think things are. So in this example, there is just fluid that's anechoic, so you know this is not high risk. In this example, look at the scroll skin and how thick it is here compared to this one. It's very thickened. Even though the fluid looks anechoic, raise the possibility of a high grade risk associated filariasis. So a recent study actually showed that 56% of examined males in an endemic area in Ghana presented with hydroceles of variable degree. 9% showed echoic fluid, which suggests that a considerable proportion of patients are at risk of testicular inflammation and necrosis. So it's something to bear in mind. And you can do a very brief scroll ultrasound. I always say that my favorite ultrasound is scrotal, because it's straightforward, the skin, there's no overlying gas, the patient is not obese, it's just skin and testicle. Very satisfying. Then you can see it. I think this is my last one. Leishmaniasis. I think I've seen some of this. This is at least one disease that this is where I'm from. It's actually quite common. So it's common in North and East Africa and India. The agent is called Leishmania. It's mosquito. It's mosquito-borne. I think it's called phlebotomus something. Does anyone remember? Phlebotomus something. Clinical presentation is important to know because it will guide you. And we're physicians essentially, so we need to know what the patient presents like. So fever, abdominal pain, hepatosplenomegaly, but the main thing is pancytopenia, because it affects the reticuloendothelial system and it leads to pancytopenia. That's where your hematology knowledge comes in. Diagnosis is done by direct visualization of Leishman de novo bodies and blood cells, so you need blood. Treatment is medical. So how can ultrasound help? So you'll see hepatosplenomegaly, because we know that it causes problems in the reticuloendothelial system, and part of that is the spleen, remember, the liver, and then lymph nodes. So expect to see abdominal lymphadenopathy, expect to see hepatosplenomegaly and splenic lesions. Remember, we've discussed TB, and we've discussed that we can also see lymphadenopathy, and we can also see splenic nodules. So extrapulmonary TB is a very important differential, and that's why you need clinical presentation. You need to know your epidemiology. If your patient has HIV, think of TB first. If not, think of leishmaniasis. And remember to look at your bloods. Do they have pancytopenia? Do they not have it? So POCUS helps with diagnosis and differential of extrapulmonary TB. Also, they have pulmonary TB. They're short of breath. Okay, it's more likely to be TB. We're done. Practice cases to test whether you guys are attentive. Okay, 35-year-old patient who comes from a tropical area, background of HIV, giveaway, weight loss, fatigue, and UC ascites. What do you think this is? Yeah? TB. Answer? Yeah, it is TB. Remember these findings just to refresh your knowledge. Hypercolic lymph nodes, access in the spleen, the liver, and you're looking for fluid because it leads to an exudate. Access case number 2, 35-year-old, tropical area, abdominal pain, fever, blood, show pancytopenia, giveaway. You see splenomegaly and splenic lesions. What is this? Well done. Number 3, 40-year-old, lives close to a river, giveaway. Abdominal pain, GI bleed, fever. What do you see on ultrasound? Can you all appreciate the portal fibrosis? See how there are hyperecholic streaks surrounding the portal vein. What's the diagnosis? Thank you. Thank you. And let's just refresh our memory. So leishmaniasis, again, we said hepatosplenomegaly, abdominal lymphadenopathy are suspicious. We also see them in extrapulmonary TB. And so do splenic lesions. And then schistosomiasis. So we said increasingly wide periportal fibrosis starts in the periportal region and then it goes outwardly. And then signs of hypertension, portal hypertension. Case number 4, just one more to go. 45-year-old, comes from a tropical area, scroll swelling, and then ultrasound shows cold wall thickening, hydrocele, and suprascrotal fluid. Can you see this lymphocele? It's easy, but tell me what's the grade. Is it high grade or low grade? Huh? Yeah, the skin is thick. So here I told you. I gave you the answer. Thick. The suprascrotal. Is it high grade? First of all, what's the diagnosis? Yes. Is it high grade or is it low grade? Well done. Okay, last case. We're done. Well done, guys. 60-year-old, he again lives close to a river. That's a giveaway. Hematuria, has a focal, yeah, correct. Bladder wall thickening. So diagnosis is easy. I'm sure you guys know it. But what should you do with a patient? Follow up. Well done. Okay, you guys are paying attention. Thank you. Any questions? Anything to add? Thank you.
Any questions? Biases, liver, whatever. Where else do we find kind of amoebic liver? Abscess is one. Where can we find amoebic collection in our environment? Cecal mass in young patients. Think of amoebola. Okay, right, good. What's the next line?
So just find out if the patient
is ready.
If not, then we do the
surgical residence, but it will be a good recap. It's essentially in 2 parts. The first part is the principles of ultrasound, because I thought if the surgeons have to start doing ultrasound, they need to understand the physics of how ultrasound works. So this might be something which you already know about, but it will be a good revision. And the second part is ultrasound in acute situation where a patient comes in shock or hypotension. And this is again a point of care kind of ultrasound where the surgeons can actually do the ultrasound. But it's very useful to kind of understand these principles which are now coming as point of care ultrasounds for radiologists as well. Because they are going to be in competition with you, so you guys have to be even better than them. Yeah? And it's quite possible you're in a smaller hospital where there aren't CT scans and there aren't modalities. And again, you might be in the situation where the surgeons can be in, and you've asked somebody to kind of examine a patient with ultrasound for shock or hypertension. And if you know the protocols which the surgeons know as well, then you can very quickly do exactly what we teach surgeons. Right, so just recapping the physics of ultrasound, principles, technique, examples of scanning in hyperactive situation, and also intervention. So this is how the talk will eventually move through. So ultrasound, you know, the
essential piece of kit which produces the ultrasound is a piezoelectric crystal. Essentially, piezoelectric phenomena is where if you mechanically compress the crystal, it produces electricity, and vice versa. So if you take a piezoelectric crystal like a quartz crystal and you hit it with a hammer, it produces a current. And vice versa, if you put a current to a quartz crystal or a piezoelectric crystal, it actually compresses. And that's the kind of technology that we use to produce sounds. So what we can do is take these crystals and we can pulse them with electricity, and they pulsate. And the moment they pulsate, they act like a drum. And the drum then what produces these sound waves. And you can, so each crystal will have its own natural frequency, but you can actually make it run a bit above or below by pulsing it at the frequency that you want to make it pulse. And that's why you see these multi-frequency probes these days. But there is one natural frequency of the probe, which is probably the middle figure. So say for example, a probe goes from 5 to 8 megahertz. Then probably the 6 megahertz is the natural frequency of the crystal, but then we can make it go at 5 and we can make it go at 8. But 6 is probably where it will work best. Yeah. So always remember that the best resolution would be at its natural resonant frequency. So be more real-time ultrasound, essentially the way it creates the images, that we have a line of ultrasound waves kind of passing through. So you get one line of information, so we pulse the sound and then we wait for the sound to kind of keep bouncing back from various surfaces. And as the sound comes back, the computer keeps storing that information. Then it fires a second line, then it fires a third line, a fourth line, a fifth line, and nearly up to about 256 lines. Once 256 lines are done, one frame is created. And then once one frame is created, the second frame is created, and so on. So the sound waves travel really fast in tissues, yeah? So do you know at what speed sound travels in tissues? Yeah? How much? Yeah, that's right. So it's about 1500 meters per second. And what speed does it travel in air? Like when I'm talking, how quickly can you hear it? So it travels about 32 meters per second, yeah. So it travels much faster in tissue. And that's advantageous for us, because if it travels that fast, all of this that I was describing, that one frame, we can create nearly 30 to 40 frames in 1 second. And therefore the picture looks like real time. So because you have 30 frames being thrown on the screen, even though they are static images, but because they are thrown at such a rapid rate, it looks like real time. So if the aorta is pulsating, you will actually see it pulsating. So anything which pulsates faster than, or if frames are thrown faster than 25 frames per second, it looks like real time. If it's slower than 25 frames per second, then you can actually see that it's kind of slow, and you can see the static images. The eye can kind of appreciate that there are static images being thrown at a rapid rate. So therefore, that's again a parameter that you can control, the frame rate. And the frame rate obviously is dependent upon how wide your field of view is. So if you want a faster frame rate, you can narrow your field of view. The beams, normally linear array is kind of the commonest probe that you will encounter, or a curvy linear, and this is how the sound waves are kind of produced in it. But they can also bend the beams, and that's how you get the kind of larger field of view, curvy linear image. Now sound interacts with matter, and very similar to light, it has phenomena like reflection, refraction and absorption, and it's useful to kind of know what mechanisms happen as reflection, refraction and absorption happens, and how it affects the image quality. This is quite a nice figure to kind of remember, that sound kind of gets absorbed at nearly 2 decibels per centimeter per megahertz. So for each megahertz frequency, so say for example if it's a 5 megahertz probe, then 10 decibels of sound will get absorbed in each centimeter. By 5 centimeters, 50 decibels is gone, yeah? So, and we'll come to it later why this figure is important. So remember that figure, yeah? 2 decibels per centimeter per megahertz. So how is the image created? So sound kind of bounces, goes into the tissues, it bounces at various interfaces. So sound doesn't bounce if there is no interface. So if it's in one single very homogeneous tissue where there is no difference in the acoustic impedance. The acoustic impedance is how much a piece of tissue occludes the sound waves. And if you encounter two tissues which have difference in acoustic impedance, then sound bounces back. If there is no difference in acoustic impedance, nothing bounces back. So, for example, the bile in the gallbladder. Now, the bile in the gallbladder has a particular acoustic impedance, but the bile layer next in the gallbladder has the same acoustic impedance as the bile before it. So, in bile or inside the gallbladder, in the lumen of the gallbladder, no sound waves bounce back. Yeah? It looks completely dark because nothing's bouncing back. But where the liver surface ends and the gallbladder wall starts, there is a difference in acoustic impedance. So some of the sound will bounce back, some will go forward. Now how much bounces back and how much goes forward is dependent on the difference in the acoustic impedance. And that's where we are able to see images even when a little bit of the sound bounces back, but still some is available to kind of see the structures behind that interface. But if the interface is such where there is a massive difference in acoustic impedance, then all of it will bounce back. And there are kind of a couple of places where that will happen. So lungs, so as you hit air, there's a massive difference in the acoustic impedance of the intercostal muscle and the lung surface. Everything bounces back, you can't see anything. It's not that sound can't travel in air. Sound travels perfectly fine in air. You can hear me. That's the reason you can hear me. But the trouble is the difference in acoustic impedance makes sound bounce back. And those are the kind of limitations. So we can't see beyond bones because again there's a massive difference in the acoustic impedance. So sound kind of bounces off the bone surface and we can't see anything beyond it. Right, so, and that's what then finally the reflection of sounds kind of creates certain things in images. So you obviously know this, that if you have gallstones, the sound bounces back off the gum, there's no sound left beyond to go past the stone surface, and therefore you get a bit of a shadow. Yeah? Now that's obviously a disadvantage because you can't image behind the gallstones, but that's an advantage as well because it tells you that this structure here is got acoustic impedance which is making sound spikes all the way back, so which means that it's most likely stones. Yeah? So there's a disadvantage of these phenomena, but there are advantages as well. One other phenomenon of reflection is duplication artifact. So sometimes you have a lesion in the liver, the sound, and because you have a diaphragm which is nearly acting like a mirror, so sound waves kind of bouncing back, and it creates a reflection. Because the sound bounces this surface, takes a turn there, then bounces back. So the machine thinks that there is another lesion. Similarly, with refraction, you can sometimes get a duplication artifact where you can see two gestational sacs instead of one. This is actually quite a common one to happen, and you have to be wary of it, but you could very easily call it as a twin pregnancy, yeah? And it's actually only one sac. But if you turn side to side, then you see that it's only one sac. So the way the phenomenon is happening is sound refracts. So as the sound wave comes, there's a difference in acoustic impedance. Some reflection happens, but because of the difference in acoustic, there is also a little bit of refraction. So the sound wave kind of bends. So it bends on the start of the cyst, then it bends at the end of the cyst, and then it comes there. So if it hits a lesion here, the sound's kind of traveling like this. But the machine doesn't know that the sounds got bent. Yeah? So the computer doesn't know sounds got bent. So the computer thinks the sounds come this way. So it kind of puts a lesion there, yeah? Because that's how it's kind of finally mapping the information and putting. But then it's possible one of the beams from here has actually got this directly as well. So you see one which is coming directly from here, and you see another one which it puts there. So you see two. So you see two gestational sacs. Yeah? So the thing is, the reason it's happening in the sac is because of this, because this is acting like a cyst, and the sound beam's kind of refracting. So it's kind of refracting and it's bending, and it's hitting this lesion, and it's kind of thinking that there is one lesion there and there is one lesion. Right, sound also gets absorbed, like we said, 2 decibels per centimeter, and obviously different tissues absorb sound slightly differently. That was the average figure. So if you have a cystic lesion, less sound gets absorbed, or it goes through. So the tissues behind the cyst look much brighter. This is called posterior enhancement. Yeah? And again, this detracts from the image at the back because you get this little beam-like thing, and you don't see the anatomy that well because of this artifact, but it's useful as well. Because this tells you that this lesion is a cyst. Because only a cyst would cause posterior enhancement. So it's got fluid in it. Whereas a dark hypoechoic lesion, so sometimes tumors are very strongly compacted. Yeah? The cells are very dense and they look exactly like cysts. Because there is no difference in the acoustic impedance, very similar to fluid. And therefore, sound kind of travels right through without reflecting. But because it's solid, it does get absorbed. So the sound still gets absorbed, but it's not getting reflected. So it can look very dark, but then there isn't a posterior enhancement behind it. So that tells you that the lesion is solid rather than cystic. So sometimes you'll see very dark lesions which really look like cysts, but there's no posterior enhancement. In fact, there's a little bit of drop off, which means that the lesion is solid. So that kind of again helps you discriminate cystic lesions from solid. Right, so now you remember we talked about the 2 decibels per centimeter per megahertz. So most of the machines, when sound starts off from the probe, you have about 120 decibels available with you. You need a minimum of 40 decibels to form a reasonable image. If it drops less than 40 decibels, you won't see anything. So you have how many decibels to play with? We can afford to lose how many decibels? Yeah, 80. Yeah. So you have 120 to begin with, 40 is the minimum you need. So you can afford to lose 80 decibels and you will still see something. And sound gets absorbed at a rate of 2 decibels per centimeter per megahertz. So this can kind of help you calculate if you have a probe which is 5 megahertz. So a 5 megahertz probe at 5 centimeters, how many decibels will be lost? We need somebody with good maths. I can see Dhruv is doing the calculation. So 2 decibels are lost per centimeter per megahertz. The probe that we are using is a 5 megahertz probe. So at 5 centimeters, how many decibels will be lost? So 2 into 5 was 5 centimeters here, and 5 megahertz. How many? So for each megahertz, so for 5 megahertz you will lose, for each centimeter you will lose 10, isn't it? So for 5 centimeters you will lose 50. Yeah? So you've lost 50 decibels. But the sound's having to travel 2 ways. Yeah? So if you're looking at a depth of 5 centimeters, then you have 10 centimeters. So it's lost 100 decibels, yeah, in 5 centimeters. So if you have 120 decibels in 5 centimeters, you will end up having how much? 20 decibels, not good enough. Yes, so a 5 megahertz probe can't go beyond 5 centimeters. So there's, unfortunately because of this, there's a trade-off. So if you have a high frequency probe, we can't image very deep because the sound gets absorbed and not much is left. If you have a low frequency probe, it goes much deeper. But what's the advantage of a high frequency probe? Yeah, so the resolution is much better. So it's in radiology, all of things are trade-off. If you improve one thing, the second thing gets worse. Right, so now coming to resolution, which is the next important thing. So you have a couple of different factors which decide the resolution. So one is lateral resolution, which is we can focus the beam. Yeah, so you have special crystals or you have lenses in front of the crystal which can focus the beam. And you can do that electronically, and you may have noticed on your machines you have a focus point, yeah, and you can alter the focus point, and you can have multiple focus points as well. So that's the lateral resolution. So by focusing, your lateral resolution becomes better. That means the resolution along the slice thickness.
The sector width also affect lateral resolution.
No. So the sector width is this. So you mean the field of view, yeah? So the field of view doesn't affect the lateral resolution. Lateral resolution is just dependent upon the focusing. Okay? Then there is the next resolution, which is the axial resolution, which is the resolution along the axis, so from superficial to deep. And then even in the lateral there are 2. So one is this, can you see, that's why they made this kind of dimension with 3. So I'm talking, when I say lateral, I'm talking about this one, which is the thickness. Thickness is dependent upon focusing. But there's another resolution right to left.
And the right to left resolution is dependent upon the number of lines per frame. So that will depend on your field of view. Because if you reduce the field of view, you can afford to increase the number of lines that you have per frame. You get the same number of frames per second. So either you have to drop the frames per second and have a large field of view and then have more lines. Or if you want the same frames per second, then you drop the field of view. So sometimes it's useful to narrow your field of view to get a better resolution along the right to left axis. Yeah? But the more important resolution is actually the resolution along this axis. That's what essentially decides the image quality. Slice thickness, so get the focus to the plane of your interest. So yesterday, did you notice when we were doing scans, I was asking how to move the focus up and down here? Because I was wanting certain areas to be slightly better. I think leave this bit out. So, right, so now this is the axial resolution. So, ultrasound is pulsed as a 2 or 3 wavelengths as one pulse. Yeah? That's known as a pulse length. So, this pulse length might have 2 or 3 wavelengths kind of one after the other interfaces. Now, if the pulse length is longer than the difference between 2 interfaces, what will happen is as the sound wave bounces back, some of it goes forward, then some of it bounces back. The pulse length of the wave bouncing off the second surface might just get attached to the tail of the first bounced wave. Yeah? So essentially the probe receives this as one pulse. And if it receives it as one pulse, it will not resolve these 2 interfaces. It will just show it as one line. Yeah? So what's the deciding factor? The deciding factor is the pulse length, isn't it? And the pulse length is the number of wavelengths and obviously the wavelength itself. The wavelength is inversely proportional to the frequency. So the higher the frequency, the lower the wavelength. Lower the wavelength, less the pulse length. Yeah? And you need at least 3 wavelengths to create a substantial pulse. So you can't alter that, that's fixed. So you can't say, okay, give me only 1 wavelength. So the only factor that you have in your hand is your frequency. Yeah? And that's why if you have a shorter wavelength, as the pulse bounces off, the machine can still resolve these 2 interfaces as separate structures. Yeah? So the higher the frequency, the better the resolution. So I've just created an example here to kind of demonstrate how focus can help. So you can see there's a stone there in the gallbladder, but the focus is somewhere there. Yeah, so we are focusing our beam on that surface, but if you want to see this better, if I reduce the focus, you can see that the stone is resolved slightly better. Yeah? What I also did was I also reduced the field of view, so there are more lines in this frame compared to this frame. Yeah? So as there are more lines per centimeter, the resolution of the stone becomes slightly better. I think between this and this, I changed the frequency as well, so just to demonstrate that the resolution can get better. So essentially there is a kind of trade-off between field of view versus the number of lines. So again, larger field of view, actually this is a pretty good machine, so the resolution is pretty good even on that. But then if you narrow it, you can see that the CBD is just seen marginally better. So if you're looking for a very small stone, then suddenly narrowing the field of view can help. Yeah? Right, dynamic range is just increasing the contrast between tissues. So you can see you can get an image which looks like this, which is a bit washed out, but you can make it look a bit sharper by increasing the dynamic range. So that's again what most of the protocols do. So when you choose musculoskeletal or soft tissue, they're essentially changing this. But you could manually change this as well. And it's kind of useful to know all of these manual changes, because if you have the time and inclination, you can create your own protocols, like what you like best for shoulder. Let's create that, and you can give it a name. So, Kwame shoulder. Right, so Doppler, I'm sure again you know the principle. It's based on the Christian Doppler principle, which is when sound waves are either produced or being reflected by a moving object, then there is what happens to the sound? So something happens to the sound if an object is moving. So say for example, if a train is coming onto the platform and it's blowing its whistle. So So as it comes into the platform, as an observer on the platform, do I notice a difference in the sound as the train is coming in? Or what happens? So yeah, so as it comes closer, and you may remember this from having stood on a platform. So I'll just try and emulate the sounds. I don't know what a train sound is like. It'll go. So say for example, this train's kind of going in front of you. So what's happening? The frequency of the sound is changing. So as it's approaching you, the frequency is getting. So the frequency is increasing because the waves are getting compressed in a shorter distance. And then as it's traveling away, the waves are getting pulled apart. So the wavelength is increasing. So the frequency is reducing. So you have an increase in frequency as the sound is approaching you, and then there's a shift in frequency. So the shift in frequency is directly proportional to the speed at which the train is coming. So you can, if you can assess the shift in frequency, you can actually say what the speed of the train is. That's exactly how all these cameras in UK. Do you have cameras there? Catching speeding? Yeah. So in UK, I think we have the maximum number of cameras in the world. Yeah? We have a camera every 10 feet. There is a camera there. So all of these cameras are again using Doppler. So they're essentially bouncing sound waves off the car surface, and they get the sound back. And depending upon the difference in the shift of frequency, it tells you what speed the car is going. Yeah? So that's exactly the principle that we use with Doppler as well. So you have sound being produced by the probe, RBC running along the artery, sound hits the RBC and then bounces back and goes back to the probe. Yeah. So now here you can assume, so obviously the sound is being produced by the probe, and the probe's not moving, that's a static object. But when the sound comes and hits the moving RBC, the same phenomena happens. So it can be either the source moving or the listener moving. So here the RBC is the listener, yeah. So even if the listener is moving, so if the train is not moving and if you were running on the platform, same thing would happen, yeah. And then when it bounces back, then the RBC becomes the source. So now it looks like it's reflecting back. So it nearly looks like as if the RBC is producing the sound and then the probe is becoming the receiver, yeah. So the phenomenon is happening how many times? So the Doppler phenomenon is happening twice, yeah. Once there is a shift when the RBC listens to the sound, and then when the probe listens to the sound, there is another shift. So that shift in frequency gets multiplied by 2 because it's happening twice. Yeah? And the shift in frequency is directly proportional to the, obviously the speed of the RBC, which is what we said, yeah? And also the angle at which you are interrogated. So if you were to interrogate the RBC at 90 degrees, there won't be any shift at all because there is no vector in line with the probe. Yeah? So you have to see so the RBC is moving in this direction. If you interrogate at 90 degrees, there is no vector 90 degrees to it. But if you interrogate at an angle, then there is a certain vector in line with the interrogation, and then you will get the Doppler shift. So the ideal Doppler shift would be to actually have the probe in line with the RBC. That's the best, yeah. But obviously you can't have the probe inside the artery. These days they have intra-arterial ultrasounds as well. So the maximum shift would happen if you're in line. But so therefore, being the person who's doing the Doppler, if you know this principle, you should always try and angle your probe as much as you can parallel to the vessel. The better angle you get, and you can obviously do it electronically. So you have the ability to tilt your Doppler box. So tilt it as much as you can to get the maximum angle. You can manually also kind of interrogate the artery in such a fashion that the more the probe kind of skims the artery in line, the better it is. If you keep it absolutely straight, you will get no signal. Yeah. If you keep it straight, what will happen is you will get signal from here and you will get signal from here because you are interrogating like this. So there's an angle there and there's an angle there, but there will be no signal in the middle. Yeah. And the signal also, finally, the machine can also decide which way the RBC is going. Because you remember I said once the train is coming towards you, there is a positive shift and there is a negative shift. So there's either an increase in frequency or there's a reduction in frequency, and that's directly proportional to That decides whether the RBC is flowing in this direction or in that direction. So the machine can actually tell you which way it is flowing. And the way it does it, if you're doing it on color, then you see a color scale, yeah? So red and blue. So red is towards the probe and blue might be away from the probe. But red doesn't necessarily mean artery and blue doesn't mean vein, yeah? So you have to see, and you can flip these things on the machine. So be careful. Somebody else may have come along and flipped the blue and the red, and then you might think the artery is flowing towards your foot in the carotid, whereas it's actually going to be blue. Or vice versa. Sometimes you can have blood flowing towards the foot in a neck artery. When will that happen? Yeah, so vertebral steel, yeah. So in the vertebral artery, the flow might be in the opposite direction. But if you're not looking at your color map properly, you might think it's going in the same direction, but it might be actually going in the opposite direction. The other place where direction of flow is quite useful is portal vein. Yeah? So portal vein, normally the flow is hepatopetal, yeah? But there are situations where the flow might be hepatofugal. So like portal hypertension, schistosomiasis. I was listening. So types of Doppler, you have continuous wave Doppler, pulse Doppler, color Doppler. Continuous wave Doppler is the Doppler that the obstetricians do, yeah? So there is no depth resolution. So it just picks up any signal along the line. So it doesn't tell you where the signal is coming from, but it just tells you there is something moving in the line of where the probe is. And that's very useful for fetal heart. So we don't use pulse Doppler anymore, continuous wave Doppler. But the ones that we use are pulse Doppler and color Doppler. Factors affecting the Doppler signal. So Q factor is the factor probe. So some probes are designed for Doppler. So that's again an important thing to know as a radiologist, because when you buy machines, some machines are actually good for Doppler, and so machines which are good for 2D normal B mode are not good for Doppler, because this Q factor is different for normal 2D scanning and it's different for Doppler scanning. So there are some machines which are designed for Doppler and they are much better than for 2D Doppler. So if your purpose is like only for peripheral arteries and carotids, and that's why you're buying the machine and that's what your subspecialty is, then go for the machine which has a higher Q factor, which will give you much better Doppler signal, but it won't give you as good a normal 2D Doppler. Then obviously the frequency of the probe that you use, the angle of the probe, and the pulse repetition frequency. So do you guys know what pulse repetition frequency is? PRF? So with pulse Doppler, the reason we call it pulse Doppler is you pulse the Doppler signal. Yeah? And the reason you need to pulse it is because the shift in frequency is being calculated by interrogating the sound that is coming. Yeah? So when you say interrogating, you are actually to get the graph, say for example this is the wave, to get the graph you have to sample it at multiple points to find out what is the shape of the graph. And the speed at which you are sampling this graph is the pulse repetition frequency. And if you sample it too low or too high, then they will get artifacts. So one of the artifacts that you get is called aliasing. Do you guys know aliasing? Have you seen it happen? So what is aliasing? Right, so look at this wheel running, yeah? So which direction is the wheel running? Anti-clockwise or clockwise?
Clockwise.
Which way? Quick, clockwise. Keep telling me. Now?
It's too fast. It's moving too fast.
It's moving too fast.
So you get wrong impression.
Right. So is that what the wheel is doing? Is it going clockwise and anti-clockwise every 5 seconds?
On the Ghanaian road, yes.
So the wheel is moving in only one direction. Yeah? It's actually moving clockwise. But why are we seeing it look like as if it's going anti-clockwise? Any ideas?
I think the speed with which we see it confuses us.
Yeah. So you're right, but now let me explain it more technically. What confusion means. So the eye, your human eye is sampling the image that's coming to you. And it looks at it, then there's a little lag, then it looks at it again. So you're not sampling it real time, you're just sampling pieces very similar to like the ultrasound images, but because you're sampling it at very rapid rate, it looks like it's real life. But even real life is static images. Yeah? So imagine the first spoke was at the 12 o'clock position, and your eye samples it. Then the next time the wheel moves, the spoke is at 1 o'clock position. Then you sample it again. Yeah? That's your sampling speed. So you sample it at 1 o'clock. Then you've sampled it at 2 o'clock, 3 o'clock, 4 o'clock. So what does it give you? The brain gets the impression the spoke is going in this direction. Correct? Now, say for example, if the wheel was going really fast, and you sample it at 12 o'clock, but by the time you sample it the next time, it's gone all the way and it's come to 11 o'clock. So the next time the brain samples it, it's at 11 o'clock. Next time the eye will sample it, where is it? Yeah, or 10 o'clock or 9 o'clock, yeah, then 8, 7, 6. So what does the brain think? The brain thinks the wheel is going in this direction. Yeah? So the problem is your sampling rate, because you can't sample the speed at which this thing. Then what happens is, after the 11 o'clock sampling, you sample it at 12 o'clock, but then it goes all the way and then comes back again to 1 o'clock, then you sample it, then it looks like again it's going clockwise. That's why that wheel is changing. Yeah? Sometimes it looks like it's going clockwise, then it goes anti-clockwise, then it goes clockwise again, because the wheel's getting faster and faster. So then it again reaches that stage where it goes beyond that 6 o'clock position, so it gives you a feeling that it's going in the opposite direction. And I'm sure you've seen this phenomena when you sit in the plane and you look at the propeller. Sometimes it goes like this, then it goes this way, then it goes this way, but it's actually going in one direction only. Yeah? So this is exactly the phenomenon that happens with aliasing. We're not sampling the signal that's coming at the rate, and therefore we assume, the machine also assumes that the signal is coming in the opposite direction. So again, if this is the wave, if you sample it adequately enough, you get the right wave. But if I sample it here, then I sample it here, then I sample it here, it looks like the wave is this. So the frequency of this wave and this wave is very different. The wave is the same, but because we are not sampling it adequately, it's giving us an impression as if the frequency is changed. Yeah? And that's why you get a flip in this thing, and that's what aliasing looks like. So if this is your box here, and that's what color should look like. If my pulse repetition frequency is not high enough, then I will get aliasing, and red and blues will start getting mixed, because the machine is thinking the blood is flowing in this direction, then it's feeling it's flowing in this direction, so it kind of mixes the red and blue, yeah, both. So you don't know which direction the blood is flowing. And on the pulse, because it mismatches the frequency at the higher velocities, up to the velocity where the pulse repetition frequency was enough, it was fine, but then the peaks, they get put there, because the computer is thinking that it's going in the opposite direction, that bit of the blood. So that's what it looks like on pulse Doppler. Yeah? The tips get transported under the line, under the graphite, because it's thinking it's flowing in the opposite direction, all of the velocities which are not being sampled adequately. So what do we do to kind of rectify these sampling? So you can increase your pulse repetition frequency. So that's a button which you have here. Yeah? But if you increase the pulse repetition frequency, you start losing slower velocities. So if you're looking for slow velocities like synovitis in joints, then reduce the pulse repetition. Then you will pick up slow velocities. If the velocities are very high, like in a carotid stenosis, then you have to up the pulse repetition frequency. Otherwise, you'll get aliasing. Yeah.
Is it the same as the scale?
Yes. So yes, that's right. So pulse repetition frequency, some machines they call it scale, but it's the actual word is pulse repetition. And even on the button, you might say it says scale. So try whichever machine you are talking about. As you put the scale up, look on the side. There are lots of numbers here. And there will be a number which will be labeled PRF. So normally the pulse repetition frequency is in kilohertz, and it would vary from 0.4 kilohertz to 12 kilohertz. So if you're looking for synovitis, bring it down to at least 0.6. If you bring it down very low, like 0.4, you'll start getting a lot of artifacts. Even your hand movement will start creating Doppler signals. Yeah? So you have to just find the right pulse separation, but it's the same buttonless scale, which on the pulse just increases the scale. So you'll see suddenly it's picking up velocities up to 120 centimeters. If you increase the scale, it will pick up to 300 centimeters. So on the graph, the scale is going up, which is the same thing because it's picking up higher velocities now. So that's why some machines, they call it the scale, because it's just increasing the scale. Right, so in terms of the physics, frequency choice, depth of imaging, be aware of artifacts, manipulate your factors to get a good image, manipulate for Doppler angle and the PRF, and know the knobs on your machine.
Still on the PRF, a concept I read about but never really got it, the Nyquist limit. It was never clear when I read it, so I don't know if you could comment on that.
So, sorry, repeat the question. Nyquist limit. So, Nyquist limit. Nyquist is a mathematical equation for doing Fourier transformation, and I'm also not exactly sure how it kind of plugs into the PRF, but that is the mathematical limitation of sampling. So that's why they kind of use that word to kind of say whether your sampling is adequate or not. But I think in simpler terms, because we have only one button to control, we are not actually controlling the mathematics of the thing. So as long as you understand that increasing the PRF will help you pick up higher speed velocities without aliasing happening, and reducing the PRF will help you pick slower velocities. That is good enough for you to know the Nyquist theorem, and the Nyquist number is the mathematics of what it's doing in the background. So you'll have to, there is a formula for it. At one point I actually knew it, but now I forgot.
So I think it's just how high your PRF has to be for you to detect the low frequency. We're just about adjusting.
So it's half this thing, isn't it? Yeah. So if you want to pick up velocities or a shift in velocity of say 12 kilohertz, then your PRF has to be 24. Yeah, there is a mathematical explanation of why it's double.
Because I took this exam last year, so don't trust me, but what I remember is
I took this exam 30 years ago.
So I think it has to do with how waves travel, so and how you measure it. So you have to measure 1, 2, 3, 4. So if the graph that you showed us earlier of how the sinusoid distance,
So the minimum number that you need to get this graph, so this is, they've actually sampled it, oversampled it, but you've got a very good figure. But if you sample it here, if you sample it there, if you sample it there, that's enough. But if you sample it here and then if you sample it there, that's not enough. So it needs 4 samples to be, and that's how somehow it becomes the double figure,
Otherwise, it's less than that. See in the second figure, the one you think it's actually slow when it's not slow. The frequency is actually higher than that because you're not sampling high enough. Someone did the maths, I forgot the formula, but it has to be formula. For you to sample it accurately and know that it's actually crossing the horizontal line. That's specific.
So that's the relation between the sampling rate. So there's a frequency of the sampling rate, and there's a frequency of this wave. So that's the relationship between the sampling rate frequency and the frequency of the probe. So it has to be, the sampling rate has to be double the whatever the frequency is, shift in frequency. Right, so this, I think I can skip this because this is for the surgeons to try and tell them, and I've seen lots of surgeons who do scans, they don't know there is a mark on the probe, and they hold it upside down and they're wondering what is happening to the anatomy, and sometimes they get it completely wrong as well. So in fact, I had a urologist who was struggling to kind of find a nodule for a prostate biopsy, and he called me, and he was holding the probe upside down, and he didn't know what that mark meant and what that screen meant, and therefore he didn't know what is cranial and what is caudal. So, but obviously as a radiologist, I'm sure you all know that there is a mark there on the probe that tells you where it's on the screen. So you have to be absolutely certain that you've got your orientation right. Advantages, disadvantages, Khawla already spoke about. Now this is very similar to what Khawla was talking about, which is ultrasound scanning in the acute situation of shock and hypotension. So very similar to all of the other protocols that Khawla was talking about. There's a rush protocol. So if you have a patient who is in shock or in hypertension and you want to quickly find out what's going on, there's no time to kind of get a history, no time to kind of, or there is nobody around to tell you what the history is. And obviously the patient is not going to tell you. So a quick ultrasound to assess the various differentials, kind of narrow down to where the problem is very useful. And this protocol essentially looks at the heart, IVC, Morrison's pouch, aorta, and the lungs. So, there's a kind of prescribed mechanism that look at A first, B first, or whatever, but it doesn't matter as long as you've looked at all of these things. And I'll quickly show you examples of how that helps. So, when you come to looking at the IVC, so IVC is very important, that's one of the things to look at in the rush protocol. So that's a normal IVC. These two images are upside down, so the heart is there, the liver is here, and this one, the heart is there, and the liver. So that's the IVC going into your right atrium. That's what the normal IVC looks like. It pulsates due to the cardiac pulsations, and it should at least shift by 30%. Whatever is the caliber of the IVC, it reduces to less than 50%, then it goes back up again. But if the IVC and the hepatic veins are dilated, like in that case, and it's not, there's a cable index. So the cable index is more than 50%, which means that it's not pulsating enough. That tells you that there's a raised right atrial pressure. In this case, there was cardiac tamponade, which was causing this. So that is a very good sign to straight away. And this not only in acute cases, it's very useful in normal scanning as well. You quite often see this with the IVC, and the patient might be coming with pedal edema or something, and they might be saying, oh, is there a pelvic mass? And then you spot, and that's the first time they realize there's a problem with the heart. In fact, I had a patient whose IVC showed this reduced cable index, hepatic veins, and they had an echo which was reported as normal. So they said, no, there's no heart failure. But I said, no, the IVC is dilated and it's not pulsing, there's something wrong. And the patient had kind of pedal edema and things, and the cardiologist had said, it wasn't the cardiologist, the echo was done by a technician. So I said, no, the IVC, there's something wrong with the heart. Get a consultant to look at the heart. So, and then they got a cardiologist to do the echo. And there was a very unusual condition, eosinophilic myocarditis or something. So it was a restrictive heart disease where the heart size was normal, yeah? And the traction of the left ventricle was normal, but the deposition was all in the right. And there was no pericardial effusion. So this is a very good sign to kind of pick up that there's something wrong with the heart. And you can just mention on your report sensitive of raised right atrial pressure. You're not saying what the reason might be because you're not doing the echo here, but that kind of leads them to do the echo. Right, so the other things like very similar to the fast scan, you need to look at the Morrison's pouch. So these scans are just quick scans, you're not actually scanning the livers in detail. So Morrison's pouch, normal, left upper quadrant looks fine, and pelvis, urinary bladder looks fine, transverse and one sagittal, yeah? So there's no fluid, no fluid, no fluid, so that's fine. But if you have fluid, then you might pick up fluid, so that's fluid along the spleen, so clearly something's happening there. You might pick up, if it's obviously trauma, splenic hematoma, so that's, you can actually see blood in the hematoma, so the patient was actively kind of bleeding. This again in the left upper quadrant, bit of blood, which is more hyperechoic, so it's not fluidy, like a clot. Right upper quadrant, again in the Morrison's pouch, there's blood, and quick look at the liver. It's slightly hard on this image, but there's a little hypoechoic area, so there was a liver contusion or laceration. Again, pelvic scan, and you can clearly see there's a bit of free fluid there, and that tells you there's obviously something going on. Then the next structure to look at is the aorta. And the aorta can be seen in the suprasternal location. So that's quite a handy thing again for radiologists to learn as well. Yeah? So have you ever looked at the aorta from the suprasternal? You need a slightly smaller probe. Yeah, you can't do it with the sector. But with the smaller probe, if you put it in the parasagittal location, you see the arch of the aorta quite well. So that's the ascending aorta, that's the descending aorta, and you can see the three great vessels coming out. So it gives you a very good idea of what's happening in the aorta there. So if there's any dissection, you can pick that up. Aorta in the, obviously in the abdomen, you guys are very good at looking at, so the celiac axis and the SMA, and then also in the transverse scan, scroll through just to make sure there are no aneurysms for dissection. So again, aneurysm seen in the aorta there, transverse section of the aneurysm, again clot in the aneurysm, and another big aneurysm with swelling of the blood because of the large size of the aneurysm. So looking at the heart, like Kaula spoke again, that's very important as well. So parasagittal gives you this, and this is again a very handy image to learn. Yeah, it might take a little bit of practice. It's an oblique parasagittal slice, and that goes through your right ventricle, interventricular septum, the left ventricle, and the left atria. So that's your mitral valve, that's your aortic valve. So you see the heart beautifully in this, and you can cover a lot of areas just in this one single slice. And this is what a normal heart would look like. So you can look and see whether the heart's contracting normally or not. And you do so many ultrasound scans just for practice sake, keep looking. So the 4J view, which is this one here, and the short axis view and the parasagittal view. So these views again get used to them, and you can pick up so many things which may be relevant to what's happening in the abdomen. Yeah? Obviously, in the acute scenario, you're looking at the aorta, and you can see in this case, can you see the aorta there at the back? And there's a little flap there. Can you see there's a flap there? There's a flap there, and there's a flap there. So there's a dissection flap. Yeah? The next thing to look at is the lung. So the lung normally looks like this. Kaula again showed you, and she showed you examples of pneumonias in lungs and the signs to pick up pneumonia. But this is what a normal lung looks like. You can see it's a slightly speckled line which just moves a little bit. Yeah? But and you can do a M mode. So the M mode is just kind of a straight surface there. Yeah? That's where the lung surface and the intercostal muscles are. Again, that's what a normal lung looks like. But if you have a pneumothorax, then you see the lungs not moving. Can you see here the lungs not moving? It's just a straight line, and you get this little parallel artifacts from that reverberation. So that's a reverberation artifact, and you can see the lungs moving there normally. So there's a little bit of air which is not in the lungs because it's not moving and it's lying in the front. Exactly the same thing in the intercostal space, the lungs not moving. So there's a pneumothorax there. If you do the M mode, where the lung surface and the pneumothorax are sitting, you get this little peaky thing. Because the lungs poking into the area of the pneumothorax, then it's going out. Then it's poking, then it's going out. So in M mode, it looks like this rather than that straight line. And once the lung re-expands, then the lung comes back again. So again, a handy thing to know, because sometimes you might do biopsies of chest wall lesions, which we might do on ultrasound rather than CT. But then once you've done the biopsy, you might want to kind of check and make sure that you haven't created a pneumothorax. But obviously in the acute situation, this is one of the things to look out for, because tension pneumothorax would again cause hypertension. Yeah?
Can I just ask a question about B-lines?
Yeah.
So if you can see B-lines, can that also indicate pneumothorax? Because the horizontal lines posterior to the pleural, the pneumothorax.
So these lines. Yeah, so these lines normally, this is a reverberation artifact. Yeah? And the reverberation artifact happens in multiple places, but if the lung is not moving, then you will get the reverberation artifact. So, but more importantly, I think, rather than depending on that, it's that straight line which is not moving, yeah? Compared to, say, for example, this. So this is what the normal lung looks like, but you can clearly see the pneumothorax
segment, and the pneumothorax may not be everywhere, so you might actually have to hunt, and it's more commonly anteriorly if the patient is supine. Venous thrombosis, so that's the kind of next thing to kind of look for. So you can look for clots, obviously look at the IVC, clot in the IVC, or in the veins as well. So you can see in this case there's a big clot hanging in the superficial femoral vein. You can see the blood is flowing around the clot, but there's a clot hanging there, and then obviously that would indirectly indicate that maybe the patient's got pulmonary embolism. Right, so again, this is the view which I think I mixed up my slide. This should have come before the abnormal ones. So that's learn this view quite nicely. So that's the left ventricle, interventricular septum, your aorta. If you angle it a little bit, sometimes you can even see the pulmonary outflow tract, which may or may not, depending upon whether you have a good window with the adjoining lungs. But then you see the mitral valve quite nicely, and you have to see the aortic valve as well. Also get used to the M mode through the valves. The M modes are very useful. Have you ever done M mode through cardiac valves? So the valves, they have particular motions, yeah? So like the mitral valve has a motion that I can probably draw it for you. So, So the M mode is just drawing the motion of the valve. Yeah? So it's systole and diastole, so that's time. Yeah? You can see when the valve opens, the anterior fluid goes like that. And the posterior fluid goes like that. But then they close, so they oppose each other, so that's where it's kind of closing. So that's what a normal M mode of a mitral valve should look like. But say for example, if there is a mitral regurg, so the valve is not closing, so that line won't happen. Yes? So it will come like this, it's open there, then it's open there. So it's very simple, but if you know what the M mode looks like, then it's handy. Similarly, the aortic valve, it looks like a box. So that's what the aortic valve movement looks like, yeah, normally. But then again, if there is either aortic stenosis or if there is aortic regurg, you'll see that it's not kind of closing. So this, because the motion is too fast, you can't see the motion in real time. So this just makes it graphical, the motion. So you might think that this is not my job, but it's very handy to have this skill. Because, and then that gives you that extra edge as a radiologist where you pick up things, and then you might not make a final diagnosis. You might say, oh, I think there's a problem there, and then send it off to the guys who are really good at it. Yeah. So again, heart, cardiac tamponade, Khala showed a few examples. I think she showed off this thing, but in acute situation, that's very handy to pick up and then tell the different physicians. And you, again, another cardiac tamponade, but this time there is fine internal echoes in it. And I was overhearing you saying that something which was specific for tuberculosis. What was it? Was it septations?
Thickening of the visceral layer of the pericardium.
Oh, okay. So this is the hemopericardium. So there's blood in the pericardium, and you can see there's fine. And you can also look at the wall motion. So here you can see the ventricles are not contracting as much as they should. So again, you really don't need to quantify anything, but you know that the left ventricular function is not good. So maybe that's why. So it's cardiogenic shock rather than anything else. So again, you can see that the heart's not moving. This is actually the heart's in fibrillation. You can see the blood's not moving at all. So this, he needs actually to be shocked. And here with the MI, you can see, if you put Doppler, you can also see there is perforation in the septum, which is leading to a shunt. This McConnell sign is a sign for pulmonary embolism. So the right ventricle apex starts contracting. So if you remember the last ones, the apex is quite open, but here you can see the apex contracts more than the
the rest of the chamber, and that indirectly tells you there is something blocking the pulmonary artery. I've never seen this I've taken from somewhere, so, but that's again a good sign to kind of know. And then occasionally you will see clot. I've actually seen clots quite a few times, and that's very handy as well. So this one is in the left atria, but you might, in the right atria, but you might see a clot in the left atria as well, which again might indicate why the patient is having kind of spokes and things. Right, so essentially, once you've looked at the heart, IVC, Morrison's pouch, aorta pulmonary, then you can kind of get to your differential. So if there's obviously pericardial effusion, there's cardiac tamponade. If there's a pneumothorax, then it's the pneumothorax which is causing as hypertension. Right ventricular dysfunction, that means there is either massive PE or there's some problem with the right side of the heart. If there's a left ventricular dysfunction, again IVC plus the left ventricle is not dilating, then think of cardiogenic shock. Normal, if the heart is normal, then, and if there's free fluid in the peritoneal cavity or there's aortic aneurysm, then it tells you there's internal hemorrhage or rupture of these things. And if there's nothing there and he's still in shock, then you're thinking of sepsis, anaphylaxis, toxins, dehydration. So it kind of helps you very quickly get to the bottom of your differential. And then as radiologists and also now as physicians, you can potentially put needles in. So if you see fluid in the peritoneal cavity, is this blood, is this pus, is this just consultation, just quickly put a needle in and in 5 minutes can tell you what it is. Yeah? So whether it's ectopic, if it's blood and the situation is of ectopic, then you can rush the patient straight to surgery. And you can also help put cannulas in, because obviously if the patient is in shock, then it's hard to kind of find veins. And that's again where your skill to be able to help put cannulas into veins can come in. So I think that summarizes essentially not only surgeons at the point of care, but even as radiologists, having these skills are quite handy, and especially so if you're going to be working in remote areas where you don't have other imagings and you don't have that many personnel. Thank you.
So now we will have another intervention downstairs. We're doing a CT-guided drainage downstairs, and then the other group can go into the room and the other group will have to watch from the inside so that it's fair. Okay, so 5-minute break, and then we'll reconvene in a bit.
Good.
Since the liver is more accessible, we're going to take a sample from the blood test, which is bacterial mass that we can identify. So we might target this lesion, but I think this will be more accessible. We have a look at the ultrasound, try to identify what target we can lesion, and then decide. We're comfortable, we're confident. We'll decide. Okay? So we'll start by scanning. Is it okay for you to lift your gown for me? Can you lift it up to here for me to scan here? So. Can you take a deep breath? Hold your rest for as long as you can. Take it in. Breathe away. And take a deep breath again.
Gallbladder is very thickened, so it's possible it's a gallbladder cancer in the liver.
Can I just take this up a bit? Thank you. We want to make sure our sample is diagnostic. So this is a critical factor. Confidently multiple diagnosis.
Let's just make sure they don't Comfort, what's that surgery? You had some surgery, haven't you?
Yes.
Sorry?
Yes.
C-section.
And another one for fibroid.
I'm just checking the descending pool. So it's quite useful to look at how so it's a dirty shadow there that sometimes we take a couple of minutes to mask. Does the CT range cover the pelvis? And I think it's the gallbladder. And the gallbladder is still thick there. It's probably locally calling there and that region is probably common.
Sorry, you said it was
Conator.
yeah, there's a lesion inside there.
So this one looking like a lift. Is this a pancreatic?
It's separate lesion on the
You can see it's anything with the liver from there.
It's actually the
And the pancreas is actually it's extremely hard to have that large of pancreatic and even not have pancreatic. You can actually see come this way, I think it would be nice.
You can't live forever now. I just stop.
Right, so Comfort, we've got a position now, we just need you the way you are, yeah? We'll clean up and then we'll start with the local, and so like we said, yeah. Now, throughout the procedure, just breathe normally. There's going to be one time when Kala will ask you to hold your breath. When she asks you to hold your breath, just hold it where it is. Normal tendency is when people say hold your breath, just to take a deep breath in and then hold it, yeah? But I don't want you to do that. Just stop breathing for a couple of seconds, and then when we ask you to breathe, then you can breathe normally, yeah? So we practice that once. So I might say something like, hold your breath now for me, Comfort. Breathe normally. Okay, that's it, that's the way. So, no deep breathing, yeah? And the needle with which we take the biopsy, it makes a clacking sound, yeah? So don't get startled by that sound. So when we ask you to hold your breath, you might hear the sound after that. So don't jump by the sound, yeah?
So this is the biopsy gun that we're going to be using. Have you guys seen one before? So because we haven't seen one big lesion that we can target, there are multiple small ones. That's why we're going to choose to use a 3.8 centimeter flow. That means we're sure we're traversing multiple lesions and we know our sample size. So we'll be choosing this. Comfort? Are you comfortable in this position? Yeah? So try not to move. Can you come slightly closer to me? Come closer now. Stay in the same position, but shuffle a bit closer to me, and your entire chest. Yeah, perfect. And then can you take your gown up? Slightly higher, yeah. And then thank you. I'm just gonna clean the jaw. And I'm going to clean
It's roughly it's got glass in it.
Can you lower the drape just slightly to make sure this sticks? Don't move, you're doing great. I'm just letting you know that we're going to be lowering the drape slightly. I'm going to put drape over you.
I'll just demo this gun to you. Have you seen this gun before? The biopens here. It just loads and it gives you different firing sensors. 1.3, 2.3 and 3.3. Just load it. And this is a core biopsy needle. It's not a true cut. So there's a difference between true cut and core. So core gives you a complete core. True cut, because there's a little tray in it, so it doesn't give you a complete core of the tissue. So this gives you a bit more tissue than just a true cut. And it's got a safety latch here as well for safe for fire.
So that I'm away from the power. It's 90 degrees. Okay, sharp scratch, comfort.
So you can build it like a patient fund.
So comfort. Can I get you to hold your breath for me? Hold it in. Hold it in. Breathe normally. Yeah, same.
Hold your breath. Comfort, hold your breath.
Hold your breath for me. Well done.
Breathe normally.
You said you're not allergic to anything, right?
Can you show me how you what you pressed on the core biopsy?
Yeah, so it has this lever which is to load it. Yeah?
Okay.
So I think right now it's loaded. Yeah? Once it's loaded, that's the button to fire.
Oh.
That's the kind of
Okay, all done?
safety.
Okay.
So that's when it's pulled out.
So that you get changed. So you need to stay in for 4 hours for us to keep an eye on you, okay? We'll check your observations and make sure you're okay. After 4 hours, you can go home, okay? So we should be done for 4 hours. Doing a lot of biopsy. Yeah, that's yeah, okay. Was it there before we did the biopsy or is it here? It's already been there. It might not be related to what we did or it might be related, I'm not sure. Speak to your doctor about it.
It's already loaded. So once I
in a polygon. So this is not what one would normally say when you are syndrome. You might say this is a non-contrast and so on. So I'm not going to say all that because I can see there's a non-contrast on one side and there's a contrast on the other side. But I'm just thinking straight away as to when I see what is my brain thinking. So I'm just thinking aloud, yeah? And it's quite possible at the end of it, I won't get to the bottom of it, but it's still useful to kind of. Do you guys know the answers? Oh, no. Right, so I'm sure some of you have already seen this case, but let me just go through quickly. Yeah?
Like when he was sitting, when he was doing the lectures.
Because I'm coming in the way. Yeah?
Yes. So I want you to sit.
Yeah, you can move to that side. Post-contrast on the left. So the first thought that's coming in my head is this is definitely not a stroke. So that's excluding one thing. But then the next thing that I'm starting to analyze is that where is this pathology? So I'm first going for location. So in location, the things that my brain is kind of, and this, my brain's doing it actually quite fast, but I'm just saying it now slowly so that, so I'm thinking is, where is it? Is it supratentorial or is it infratentorial? So it's clearly supratentorial. Does it have an infratentorial
extension as well. So I'll go back again. I didn't see it at the first look, and I think all of it stops at the tentorium. It hasn't gone beyond the tentorium. So it's clearly supratentorial. The next thing in location I'm trying to ascertain is this intraaxial or is this extraaxial? Which means that is it in the brain or is it coming from the lining of the brain? And clearly parts of the lesion are in the brain. But there's this area on the post-contrast enhanced scan which seems to surround the forks posteriorly. So that looks like could potentially be extraaxial as well. So it looks like it's possible there is a meningeal component. So I'm keeping it open. So I'm saying that okay, yes, it's intracerebral, but it's possible there is a meningeal component to it. So it's possible it's kind of arising from two places. Then the next thing I'm looking at is, okay, is there any enhancement and is there any calcification? So on the non-contrast enhanced scan, you can see that there is clearly some calcification as well. So there's this area which shows calcification. And the enhancement is very bizarre. Large parts of the abnormalities seem to be enhancing. There are some linear areas of enhancement. And it looks like whatever this pathology is, it's managing to scavenge some of the vascularity. So even the normal vessels like the left MCA has become quite big. So it seems to be pulling blood supply from the normal brain blood supply. Then I'm looking at the texture and the lesion. Is it rounded? Is it got a well-defined margin? So it's clearly not rounded. It's just diffusely involving the brain. The matrix looks like there is still some brain parenchyma in the middle, but it's definitely expanded. It's causing perilesional edema, and there is mass effect with the midline shift. So, so far, bizarre pathology. Intraaxial predominantly, but possible extraaxial. It would be nice to have a corneal CT, which I can see we do have, so I'm going to click on that to see what it's doing to the tentorium. Abnormality which encases the tentorium. So the same thing what's happening to the forks to a certain extent is also happening to the tentorium, and a little bit of the tissue is infratentorial. A little bit of the tissue is also gone on the other side of the forks. So it's quite possible this is actually more extraaxial than intraaxial. So now with all of this information, my brain is then now starting to think of differentials. And in terms of differentials, I am thinking, okay, first let's just go high level. Is this tumor? Is this infection? Is this autoimmune? Is this a vasculitis? Is this, so I'm thinking broadly, is it a congenital condition? So obviously so it's not congenital, she's 70 and it looks like she's just recently presented. So that's all out, it's not an anomaly. And it doesn't look like it's a vasculitis, but we could still keep that in mind. It's very focal. So I'm now hedging towards tumor versus infection, and I'll keep malformations on the side as well. Yeah? So just to keep that as a differential. In terms of infections, it doesn't look like an infection because infections invariably they will cause abscesses or they will cause diffuse meningeal enhancement, predominantly basal. So I'm inclined to think that it's not an infection, even though I don't know all of the infections that can happen in Africa. So I might keep it in the back of my mind, maybe it's some weird infection, but for the moment I'm excluding infections. So I'm now heading towards tumor and I'm keeping some weird malformations on the side. So in tumors, I'm thinking now, okay, let's start with intraaxial tumors and then we'll think about some extraaxial tumors like leptomeningeal. So intraaxially, it doesn't look like a straightforward glioma. So it's not a simple astrocytoma. It's not a low-grade glioma like the D-nets and this thing. It could be, sorry? Glioblastoma, yeah. So then going to the slightly higher ones, you have glioblastoma and you have
gliomatosis cerebri. So glioblastomas again are more rounded lesions, scarlet, this thing. So this doesn't look like a glioblastoma. Gliomatosis cerebri is a possibility. Calcification would be a bit unusual. Gliomatosis cerebri technically has to cover 3 sections of the brain at least, and they can go through infratentorily. If this was a gliomatosis cerebri, chances are with such a big lesion it would have gone through the tentorium infratentorily along the white matter tracts, because that's what it normally does. So therefore I'm inclined to think it's not a gliomatosis cerebri. So I'm beginning to kind of start excluding a lot of things, but still not coming to the final conclusion of what it might be. Then I'm thinking of...
Can a lymphoma be there?
Yeah. So lymphoma is the next one that I was just going to talk about. So lymphoma are very commonly periventricular. Lymphomas enhance a lot, so that's fitting quite nicely. Lymphomas can cause mass effect, and lymphomas commonly periventricular. This is a little bit periventricular, but it's kind of gone a little away from the ventricle as well. So I think lymphoma is a pretty good contender. Calcification in lymphoma, again, a little unusual, so I'll kind of put that on the side. And then unusual tumors like gliocytomas, and the gliocytomas are, we still don't know whether they are tumors or they are malformations. They're also known as there are quite a few ganglioneuromas, and ganglioneuromas, you have DNET, you have gangliocytomas, gangliogliomas, and there are a few other kind of variants. And these tumors, they're all in younger patients, so they are kind of young adults or children. So that in itself kind of excludes it. Out of those, there is one tumor which is a gliocytoma, which more commonly happens in the infratentorial region in the cerebellum, also known as Lhermitte-Duclos. And that looks very bizarre. It looks a bit like this, but the only thing is it doesn't happen supratentorially, it happens infratentorially. So I'll park that on the side, and I'm thinking in my head, I don't know that gliocytomas are supratentorial, but is it possible there is a supratentorial variant that I don't know of? So I'm parking it on the side to Google. So, and that's how I kind of in real life also do. So lots of, questions. As you are thinking, you're getting lots of questions in your head. Okay, I don't know this, but I'll have to kind of look at this information. So the two informations that I have parked on the side is that can lymphomas calcify? And I don't know, but I'll try and kind of find out. Can gangliocytomas be supratentorial? Right, and then taking these malformations out, what else is left? Right, so now let's go into the leptomeningeal pathologies or tumors. So obviously you have meningioma. This doesn't look like a straightforward meningioma, it's kind of very diffuse. But it could be a hemangiopericytoma. The other thing also when you're looking at brain tumors, you would see is there a cystic component? Because lots of tumors have cystic component which kind of clinch them towards certain group of diagnosis. But this one obviously doesn't have anything cystic. Hematological malignancies, leukemia, lymphoma, that's possible. A little unusual that it's all focal. Hemangiopericytomas and meningocytic hemangiopericytomas, which is like a overlap between meningiomas and hemangiopericytomas, is a possibility. The lesion is centered on the forks. It does have a plaque-like tissue surrounding the forks and the tentorium. But why is so much of the brain showing the abnormality? That's a bit unusual. Could this be a vascular malformation? Is this a AV malformation or a hemangioma? So the vessels are prominent, but they're not tortuous like a regular AV malformation. It's possible it's some unusual capillary malformation like Sturge-Weber can look like this, but obviously Sturge-Weber won't be in this age group. So I have parked a few possibility of maybe it could be a hemangioma. I think now I'm reaching the end of where my brain can think from what I have in my head. Yeah? And therefore now the next thing I would do is go back a bit more on clinical information, and then go onto Google to see if some of these things might kind of fit. Out of these now, I also then line them up. I said, okay, which is the most likely? So I think lymphoma is appearing very high up on my list, and hemangiopericytoma is probably the second on my list. What did it turn out to be?
Well,
Number
we don't have a biopsy. Whether it's been done or not, we are not sure.
Right.
So all we have is the.
Let's now. Obviously, you have seen this case. I'm sure you guys have thought a lot about it as well. So give us your thought.
One as a top differential. Off the top of my head, I don't remember what I think it was lymphoma that was top of the list of differentials. Yeah, I don't remember us considering a meningeal or extra-axial lesion, with an intra-axial component. So we considered in and out rather than out and in. Yeah.
What's the history?
Okay. It said patient has 76 years, had a fall 6 weeks prior to the study. With right-sided hemiparesis. So they were querying a CVA.
Can I see the whole window?
Sorry?
The whole window.
You can see that all of the occipital lobe, temporal lobe, and the parietal lobe, they are abnormal. So it's not like there is normal brain parenchyma, but it seems to have all got expanded and it's picked up a lot of vascularity. So it's scavenging the normal blood supply and even from the meninges. And lymphoma is one tumor which can give very bizarre appearances. But it's even for a lymphoma, I've seen quite a few lymphomas. This is a very unusual appearance for lymphoma. Right, so this patient, obviously you can see on the scanogram, has had a spinal surgery, and it looks like it's what we call PLIF, posterior-lumbar interbody fixation. But I can see straight away that there are interpedicular screws and there are side rods which are holding the screws, but there are no interbody cages. So quite often surgeons would not only fuse the posterior column using interpedicular screws, but also fuse the vertebral bodies through their discs using interbody cages. But you can see on the scanogram there are no clear cages. So obviously in this case, this is a post-op case. So the first thing you would want to know is why is the scan being done? The surgeons invariably after a PLIF would not ask for a CT scan regularly. You would just do X-ray if all of the pedicle screws are in location and they're fine, that's it, patient's discharged, and you just hope that it fuses. But the reason they would ask for scans is when things aren't going right, and the things that won't go right are that one, the patient still has backache and the spine is not fusing. So one of the questions that you are answering is that is the fusion happening or it is not happening? Two, sometimes what happens in post-op spines is you get what's known as pseudo-arthrosis. So where the fusion is done, instead of the fusion happening, you form an artificial joint and then it will never fuse. So there are certain signs of pseudo-arthrosis and that will also trigger off pain. Then you can get problems with the metalwork, so screws can become loose. Screws could have been put in the wrong place in the first place. So sometimes the screw might cut through the medial cortex of the pedicle and it might touch the nerves. So if the patient's getting radicular pain, then that's the thing to look out for, that is the screw touching any of the nerves. And finally, you may also get complications in relation to opening of the dura, so you might get pseudomeningoceles and you might get infections where the implants have been put. So it's important to know what the question is. So if the question is patient is getting fever or the patient is getting a discharge from the operative side, then it's obviously looking for infections. If the question is the patient's getting new radiculopathy, then you have to look very carefully at the screws to make sure there isn't anything impinging on the nerve roots. If the question is some months down the line, patient still has backache, then you're looking for whether the spine has got fused and whether there is pseudoarthrosis or not. So let's go through this one and see what's happening on the spine. More medial, and it might just be taking the medial edge, and then if that's happening, it might be touching the nerve. So you can see these two screws are well placed, yeah? They're within the pedicle. But it's very useful to also do the same thing on the cornal. So we'll first do it on axial, then we'll come back on the cornal. The metalwork can fracture as well, so look out for any fractured screws or also the side bars. Don't get worried when you see a screw which is doing this, where it's at a slight angle. They have these special screws because they have to send it through the pedicle. Quite often the side bar and the screw might not look aligned, so it nearly looks like as if the screws got bent. It's not got bent, that's the way the screw is. So here it looks like the screw should have gone like this, and it's at an angle to where the side bar is, but that's still completely normal. Look for lucencies around the screw because that would be a sign of loosening. And loosening would look a bit like this. I'm still thinking whether this is or not, but if you look at the right screw there, so that's fine. But on the right screw you can see there's a little bit of this lucency surrounding it. It's possible it's just the streak artifact which is causing that apparent lucency. But obviously if he's acutely post-operative, like the scan's been done just 2 days post-op, then you can't get loosening. So loosening is 6 months, a year, or even further down the line. So, sorry? Yeah, post-op. So that's probably just artificial. So on the axials, the screws looked all fine. I couldn't see valve position screw, but let's go on the cornal. So on the cornals, you need to get the pedicles end on, and then you're looking whether the screw is cutting through the medial cortex. Sometimes it might cut through the inferior cortex, and that might not be seen on the axial images. So you can see all of the screws are well positioned within the pedicle, so it looks all fine. What was the clinical problem, or why did they get it done? Was it just a routine?
Screw position.
So screw positioning, surgeons are actually very good at assessing that on the X-ray itself, but the screws look all fine. And the last thing is to just check the soft tissues for any CSF leaks. So when they're doing these surgeries, obviously they can accidentally open up the dura. If they open up the dura, quite often they have to repair it if they do open up the dura. But despite repairing, sometimes the CSF can leak and can form into what's known as a pseudo-meningomyelocele. So it's a pocket of CSF which communicates with the dural sac, but it doesn't have actual dura lining it. That's why it's called a pseudo-meningomyelocele. And the pseudo-meningomyelocele can get infected as well. The CSF leak can give you headaches and spontaneous intracranial hypertension. And after a little while, if the question is pseudoarthrosis and pain and whether there is adequate fusion. So in terms of fusion, they are essentially trying to fuse two things. One is the posterior column and the vertebral bodies. The vertebral body fusion happens if you put in a cage. If you don't put in a cage, it won't. Or you put in graft. So here what they've done is they've just fixed and they're just hoping that the posterior column fusion will do the job. So obviously it is a bit too early at the moment to say whether fusion is happening, but all of the facets, you should have bone forming right through. Yeah? And if you have sclerosis and if you have turning of the edges, then you think there is pseudoarthrosis. But one good modality, if CT is also not answering the question, is SPECT CT, and we use that quite often. With SPECT CT, it is a combination of CT and SPECT. So in the same machine you have CT and SPECT, and the nuclear scan information is superimposed on the CT. So you know exactly where the hotspot is. So wherever the hotspot is, that's invariably the site of the pain and also potentially the site of pseudoarthrosis. That will also pick up loose screws, SPECT CT. So pseudoarthrosis, you won't find bridging trabecally, and the edges where the fusion should have happened will get turned around, nearly like a joint forming, yeah. And then you can get a bit of inflammatory reaction as well. And on SPECT CT, there will be a lot of uptake on either side of the potential site of fusion.
I have a question.
Yeah.
How much of a cortical breach, let's say anterior breach of the anterior cortex of the vertebral body is problematic, or?
So anterior vertebral body is not problematic at all as long as they don't hit the aorta. So and quite often their screws anteriorly they're too long and they sometimes go anteriorly, and especially in front of the sacrum. It's very difficult to put a screw in the lumbar vertebrae right through the front margin, but in the sacrum quite often. So let's have a look on the sacrum, how far they've gone. So can you see on the right the screws reaching right up to the edge there, yeah? But quite often they will poke through as well. They shouldn't ideally, but even if it does, as long as it's not hit anything major, then it's not a problem. And if they do hit anything major, they would know at the time of the surgery. Any more? Yeah. So the lucency, these lucency, I think they are just beam hardening around the metal artifact, which is giving that appearance. Yeah.
The question is, usually this was acutely post-op.
Yeah.
Yeah, you just want to check for position. Some of these. So I'm asking on behalf of the residents, how do you? When do you think that there's infection? The lucency, what is the size? 2 millimeters.
So yes, so for lucency, if there are two things which are quite useful. So if the lucency is very uniform and thin, less than 2 millimeter, then that could be still normal. But if the lucency is irregular around this thing, or if it is more than 2 millimeters, or if you have sequential CTs and it's increased, then so now like you have a baseline on this one, and it's possible 6 months down the line he is still having pain and they might do a scan, and if you compare the two and you see even though the lucency is not that much but it's increased from the previous one, then that's a sign that it might be loose. But that's, you're still, if it's very smooth and regular, you're still guessing that whether it's loose or not, then that's where SPECT CT is very useful. If there is activity around the screw, then it's definitely loose. But normally you won't do SPECT CT within the first 2 years. Because within the first 2 years, the implant would be active. So that's useful only down the line when things are not improving. We'll get left to head way.
Where is he? He was early 40s, and had persistent headaches, I think a week or two prior to a study.
With the scan is that the 30-day left trial is overlapping the area of the abdomen. Again, CT head, the way I do it is I obviously use the clinical information straight away. Some people, they might blind themselves to the clinical information and then look at the images, and that's also a useful strategy because you're unbiased. You're not biased by what the clinical information is, and therefore you might pick up more things. But I feel that just wastes time. We really have too many scans to report, so let's just quickly look at the clinical information and narrow down to where the meat of the problem is. So like yesterday, Kaula was scanning this patient who had this diverticular abscess who we were hoping to drain today. So she looked at everything, the liver, gallbladder, pancreas, spleen, which is the right way to do it. And I was just getting impatient. I said, get to the meat of the problem. Then she was trying to find the normal appendix, and while she was looking at it, actually, I had spotted where the problem was. I said, oh, forget the appendix, just go where the problem is. But I suppose don't rush, but when you get more experience, then you can probably kind of unbias your brain from the clinical information which is hovering in the back of your mind. So the moment the information, even before I started, when you said headache, my differentials are already kicking in. So I'm thinking, oh, this could be idiopathic intracranial hypertension. That was the first thought. So the second thought was it could be a tumor. Third thought was it's probably a meningitis. Fourth thought was it could be a venous sinus thrombosis. So these 5 or 6 differentials came straight away in my head even before I started scrolling. So now what I'm doing is I'm looking for these things first. Then if I don't find any of these, then I'll start looking for other things. Yeah. So, and while I'm scrolling, the brain is, so the way the brain works is, even though you're taught to kind of look at everything, look at the ventricles, look at frontal lobe, parietal lobe, look at brainstem, look at cerebellum, look at the bones. When you actually start doing radiology, that's not how the brain works. You just scroll through, and because you have a massive directory of normals in your head, the brain automatically is looking at everything in one go, and it's telling you normal, yeah? Because it's matching it to the thing. And where the abnormality is just kind of the eyes stop there, and then the brain starts kicking in. So I essentially get my differentials in with the clinical information, and I'm just scrolling through. My subconscious mind is going to find all the normal things and exclude them, and my brain will find the abnormality, and I will look specifically for those 5 differentials. So the first thing when I was scrolling, I actually didn't look at the brain at all. I looked at the optic nerves. So the reason I looked at the optic nerves was because my first differential was spontaneous intracranial hypotension. So spontaneous intracranial hypotension is a condition in which CSF leaks somewhere in the dorsal spine. You get a drop in the intracranial pressure, and that causes capillary hyperemia in the leptomeninges, and that can cause a headache. So the things you to look for is that the pituitary gets enlarged in spontaneous intracranial hypotension, the meninges become a bit thicker, and the optic nerves can become a bit tortuous. So I clearly saw the pituitary was fine, the optic nerves look okay, so it's not idiopathic intracranial hypertension. Then you also have idiopathic intracranial hypertension. In idiopathic intracranial hypertension, it's in women. This is a female patient, isn't it?
Female.
What does the man mean there? I was wondering whether that meant male.
Naomi.
That's the name now.
I'm Chief Naomi.
No, under that the second line, man.
Yeah. There's also F for female.
And then there is F for female, yeah.
The previous one also had man.
Man on it, is it? Yeah. No, I think it's something else.
It was put in manually, not in
Oh, manually. Also called pseudotumor cerebri. Yeah. And in that, you get an empty cella, you get again dilatation of the CSF spaces in the basal cisterns and along the optic nerves. So I automatically excluded that as well. So those 2 differentials are gone. While my brain was looking, my brain didn't see any tumor. So I didn't spot any tumor, so I kind of excluded. Did you spot a tumor?
No, silly question.
opposite conditions, the optic nerve findings can be a bit similar. On MR, there are more signs of idiopathic intracranial hypotension. You get leptomeningeal thickness, you get sagging of the brain, which you may not see on a brain CT. Once I had excluded that, then obviously on my differential, I also straight away had venous sinus thrombosis. So my brain was looking out for the venous sinuses specifically, and the first thing that I spotted was on the top. So I saw this and I said, oh, that's calcium. So I think, and I'm not convinced that the hypodensity there is a venous sinus. I think it's the calcium which is making that. So I actually disregarded that. And then I came down here and I wanted to see the sagittal sinus, but the trial period thing was on top of it, so I couldn't see it at that time. And then as I went down, I spotted this hypodensity here. So that's obviously the location of the transverse sinus, and just on this window, it looked like it was a bit more hyperdense than you would expect. Just window it to check it out. So at first look, I definitely thought that it was abnormal, and now I've just Googled and I've compared it with the other side. The transverse sinus can be quite asymmetrical, so one sinus may be very small and the other one can be big. So it's possible this one is big and the other one is small, but it clearly looks more hyperdense than you would expect. So I'm getting very suspicious that this is a transverse sinus thrombosis. I spotted those little two calcifications in the choroid plexus of the fourth ventricle, which again my brain automatically kind of discarded. I didn't see any obvious infarcts and I didn't see any subarachnoid hemorrhage. So after a scroll through, I'm heading towards transverse sinus thrombosis.
Does the length of the segment?
Sorry?
The length of the segment does hyperdense.
Yes, so it's all of the transverse sinus. It doesn't look like it's gone into the sagittal sinus. So the sagittal sinus isn't too bad. The straight sinus is okay. So I think it's just confined to the sigmoid and the transverse sinus.
But does the length of the segment that's hyperdense not go against?
It be thrombus?
Yeah.
No, not necessarily. So in fact, all of it can be thrombus. The thrombus can be quite large.
Is it more common than short segments?
Well, the long segment is actually more common. The short segments quite often you can get in the cortical veins on the cerebral surface. So sometimes you might just have one cortical vein being thrombosed. But when you get it in the deep venous sinus, sinuses, quite often it's a long segment. The next thing I would also be interested in is, has the patient had COVID recently, or has the patient had vaccination? Because we've had quite a few cases where post-vaccination they develop venous sinus thrombosis. Was there any such history?
None that I remember.
But is that what the abnormality is, or is there something else going on?
No, so that was what we concluded. Sinus thrombosis. No, unfortunately, I didn't grab the MRI.
Did she have contrast?
She got a contrast on the MR study, but not on the CT. Yeah. So typically, you would go straight and do a contrast phase of the study if you found this, right?
So that can be a bit variable. So if Nick is sitting on the scanner and he's scanning the patient, he would have spotted this, informed the clinicians, then informed the radiologist and done the CT venogram as well. So we have a few proactive radiographers who are really good because Nick does CT head reporting as well. Yeah?
But even before he qualified as CT head reporter, he would have spotted the abnormality, rung up the radiologist, and in parallel also informed the clinician because he's so confident that that's the abnormality. But if the radiographer hadn't spotted this, then it's quite possible the patient would have gone off by the time the radiologist saw it. Because the way we work at the moment, historically we used to sit in the scanner room, yeah, and when we reported, but now we don't sit in the scanner room. So even though we are in hospital, we are a long way off from where the scanner room is. So if the radiographer doesn't spot an abnormality, there are two radiologists who are constantly going on reporting in patients, but it's possible it might be 10-15 minutes after the scan that the turn of the scan to report would come. So if it's gone, then if you are very confident on this thing, then we might straight away do a MR venogram for confirmation, and that would be, we would bring them back for contrast. Because MR venogram without contrast is 100% for venous anastomosis.
To this case, I think they were imaged a few days after birth. I think the clinicians, didn't tell us what they were looking for, but they just wrote thoracopagus. So, a few days after birth, I don't remember how early they were imaged there.
So, obviously, straight away, as the first image came, I'm just thinking again, I'm telling you what the thoughts that came across my mind. I said, is this an artifact? Or is this kind of two babies stuck to each other? So, and you can straight away see that it's a very small skeleton, so it did look like it was a newborn or maybe infants. But then, as he scrolled through while he was just putting the images on, we could see that there are two bodies there and they're kind of fused in the center. So they're like Siamese twins. Now, the details of what all to see in this, I also wouldn't know, because this is something which would probably, in our scenario, go off to a tertiary center straight away. But if we did manage to do a scan, the things we would probably look for is, okay, what's shared and what's not shared, and which bits are kind of fused. So, and the coronal and the axial imaging would probably help with it. Straight away you can see the anterior chest walls kind of fused. It does look like there are two hearts, but it's possible there might be a kind of connection between the hearts. Abdomen, again, you would have to see which all organs are fused and not fused. So I think coronal might be straight away, or Raju might be better. The hearts seem to be quite jumbled up. Obviously, this is quite intricate. You would have to kind of check the plumbing very carefully, what is going where. The good news is the brains are separate, the spinal column is separate. It looks like the liver also might have, either there might be crossover or that they have a shared blood supply. So you have to look at that carefully as well. Kidneys are separate, but I think liver, they have a kind of common supply. Bowel also, I'm slightly unsure. It's possible there's a bit of crossover between bowel.
you need far more imaging to try and assess the crossover between the two tools. What happened to them? Did they get separated?
At the time, I mean, currently, I haven't followed up recently, but at the time the scan was done, a decision really wasn't taken about the next line of events, because I thought the sharing some vessels in the heart, so a decision hadn't been taken as to the next line of treatment, the cause of whether they're going to separate them and what they're going to sacrifice and what they are not. So I need to follow up to see what has come out of this recently.
Too complicated. You want to take a picture of that?
Have you seen all
Yeah.
How many have you seen?
I haven't seen any. I've seen them in movies and
They were not sure about they weren't sure what it was. There's a contrast piece.
That's a contrast. So you take the descending aorta is fine, but it looks like some of the chambers are common as well. That's the interventricular septum. Because this person's heart is ectopic with the other chambers. This heart, you can't see all the 4 chambers, so there's some kind of dual supply happening. I think if they did end up wanting to separate, they would have to probably sacrifice one to it. Looks fine.
Yeah.
Looks very enormous.
Oh, they have to sacrifice one.